as compared to the centromere antibody pattern, which seems to give you a higher risk for pulmonary artery hypertension presentations. And again, with the idiopathic inflammatory myopathies, you get a different set of HLA antigens which seem to code for it. So knowing all this background, when should we start suspecting that a person with an ILD may have a CTD underlying the interstitial lung disease? The problem is the diagnosis often rests outside the respiratory system that we are used to examining. The symptoms are very non-specific. They can happen virtually anywhere. You can have constitutional symptoms, fever, weight loss, fatigue, and so on. Very common symptoms with all the ILDs, irrespective of whether they have an ILD, irrespective of all the CTDs, whether they have an ILD or not. Respiratory symptoms are common to all the ILDs. Nothing changes. They have cough, they have breathlessness, they have fatigue, and this cough is typically a very dry cough with no particular distinguishing characteristics. The ILD typically occurs in the middle age. It does start in the young age, goes on to the old age with a peak around the mid-50s. Gender-wise, CTD-ILD is far more common in women than in men. Involvement of other systems will give you a clue. So if you look at a younger ILD patient, a female ILD patient, a non-smoking ILD patient, you probably should be looking even harder for a connective tissue disorder. I'd recommend people read this position statement. It came out about a year ago from the Australia-New Zealand Society. And they make this important point. The clinical features of a CTD at the time the ILD is diagnosed may be subtle, not volunteered by the patient, or even non-existent, and you've got to really try and dig it out. Serology is the first point we go to, and we can look at various ways of looking for serology, various different autoimmune tests, and I'll just call your attention to the last half of it, which said we need to balance sensitivity and specificity, reproducibility, cost, and convenience. But very, very importantly, we need to know of the lab we use, what are the positive or negative values, when do we call it borderline, what are these thresholds that people are using. You need to talk to your lab before you can interpret them. And always, always, it should be in the clinical context of the patient, and always take the opinion of your rheumatologist. We've already heard he or she is such an important part of your multidisciplinary meeting. And we work very closely with our rheumatologist. There are various common antibody associations. I'm not going to go into this. We move on to imaging, and imaging does several things. It confirms whether you have an ILD. It establishes the pattern of the ILD, whether you're dealing with an organizing pneumonia, an NSIP, or a UIP pattern, or mixtures of these. It may suggest that there is a CTD as an underlying cause for the ILD. And remember that all patterns are possible with the CTD-ILD, so you need to look at these subtler clues. The most common pattern, as I mentioned already, is the NSIP pattern. UIP is less common. Organizing pneumonias are even less common. It's only in rheumatoid arthritis that the UIP pattern is commoner than the NSIP pattern. And in the idiopathic inflammatory myopathies, organizing pneumonia often overlaps with the NSIP pattern, such as in this patient, where the organizing pneumonia is very clearly seen, along with the background of an NSIP pattern. I didn't go into the HRCT because you're going to have a talk on that today later. Radiological features that favor that you have a CTD along with a UIP pattern, so it's not an IPF but more likely to be CTD, is something you've already heard, the anterior upper lobe predominance, and the probability of having a CTD underlying it is almost double that when you have the anterior upper lobe sign. The exuberant honeycombing, you've already heard, greater than 70% of the fibrotic areas are involved. Your ratio of finding likelihood ratio is approximately 3.7 times. And the straight edge sign, again, you heard about, almost increases it by 4.25 times, the likelihood ratio of being a CTD-ILD. So look for these very, very carefully. But one of the things that we should always look for, even when it's not a UIP pattern, is the esophageal dilatation that you're seeing, which often gives you a clue to the underlying CTD. So look for these signs, please. There are various pathological patterns, and again, mirroring what you saw in the radiology, is that NSIP far outweighs the others when it comes to the pathological pattern also, except in rheumatoid arthritis, where the UIP pattern is common. So let me just take you through the last part of this, outcomes. When you have an RA-ILD, you tend to have a poor survival, a 5-year survival about 36% when it's a UIP pattern, but a good survival when it's an NSIP pattern. With the interstitial, the idiopathic myopathic patterns, you tend to have a 60 to 80% survival, but there are some which have a very rapid progression and the person can die within a few months. And the 5-year survival when you have a systemic sclerosis with an NSIP pattern is around 85% and probably better now that we have nintedanib with us. Let me skip the inflammatory myopathies, a complex group which you have to look for. They may not have any obvious features of myositis when they first come to you, and you've got to look for them when you look for the various different autoantibodies. These don't form part of the normal panel, so please be aware of these. Always look for pulmonary hypertension. Always look for cardiovascular involvement, which is common when you have a CTD. Look for involvement of other systems. As I mentioned earlier, these involve all areas. Look for evidence of a latent TB infection because we are going to be putting these patients on immunosuppressive medication. Very important that you don't start them without looking for latent TB infection. Please look for muscle weakness, especially diaphragmatic weakness. Check their oxygen saturation at rest, on exercise, and at night. And I'm going to skip this last part for lack of time, but please remember that there are these conditions called IPAF, interstitial pneumonia with autoimmune features, and we look for domains, at least 2 out of 3, to explain the presence of an IPAF. It's still a research term. And it's important to pick this up because treating these people gives you very good outcomes. The other term that has recently been used is interstitial lung abnormalities, which don't even meet the criteria for a CTD or an ILD, but you pick these up incidentally when a CT is done, probably for something else, or even when you do an abdominal CT and the radiologist notices that there are some patterns or interstitial abnormalities at the base. Pick these up, investigate these patients because they have a better prognosis if you can pick up this abnormality early and follow them up. Last couple of slides, other therapies, oxygen therapy, very important. GERD treatment, like you heard in IPF, it's very important to look for GERD treatment. As you saw, the esophagus is often dilated, and GERD is a very common problem with these patients. Pulmonary rehabilitation early when they become symptomatic, it's not an end-of-life care. Remember your vaccines. Now, as in COPD, we recommend 5 vaccines. Zoster vaccine is not yet available, but influenza, pneumococcal, COVID, and Tdap must be given. Supportive and palliative care throughout the course of illness, not only when the patient is entering end of life. And of course, lung transplant sometimes because patients do not respond to treatments. And some of these patients need both a heart and lung transplant. So take-home messages. CTD-ILDs account for 15 to 20% of all ILDs. And it's important to identify these because the prognosis is usually better than in the idiopathic counterpart. The CTD-ILD may precede or follow the diagnosis of the connective tissue disorder. The clue to the diagnosis of the CTD-ILD lies often outside the lung and not within the respiratory system. And again, repeated examination is important because you can pick these signs up later rather than when you first diagnose the ILD. The pattern of ILD on the HRCT gives you the clue as to the kind of insult, its severity, and the probable cause. Confirmation is by looking at the serology and the antibody patterns. Increasingly, we are recognizing IPAF, though it's still a research term, and interstitial lung abnormality should be followed up and may have very important clinical significance. And management is not only pharmacological, which is going to be the subject of the next talk. Thank you.
Sir. Thank you for the most wonderful and informative lecture. In the interest of time, we will take questions after the session. The next talk is on steroids.
Can I just wish Sonia Dalal a very happy birthday?
So next session is on steroids and immunomodulators in CTD, when, what, and how. I would like to welcome Dr. Padmanabha Shenoy to deliver his talk on treatment in CTDs, ILD. Dr. Shenoy did his MBBS from Kerala, MD Internal Medicine from JIPMER, and it is DM in clinical immunology and rheumatology from SGPJ Lucknow, and he has got more than 50 publications in the field of rheumatology. Over to you, sir.
Thank you. Here, no? It's there. What's happening?
While Shenoy's slides get uploaded, any questions for Murli? So that we don't waste time because... Yes?
We are delayed.
Yeah, go ahead, Sonia.
Whose HRCT has got interstitial lung abnormalities, and the RA and the CCP is turning out to be positive, but then they don't have any articular features, nor do they have any rheumatological features.
Sure.
How do we start management in those patients?
Murli, would you like to answer that? Is Murli here? Yeah.
So I'll have to wait till 12:30. Okay.
Over to you, Shenoy.
Yeah. Thank you, Vishwa, for this kind invite. And thank you, Murli sir, for setting the stage where I can take it off. So I will be straight going to the topic, steroids and immunomodulators in CTD-ILD, when, what, and how. I will try to answer these 3 questions in next 20 minutes or so. So case 1 is a 30-year-old lady who had photosensitive rash over the last 2 months. Along with that, she had, you can see the face there, very clear malar rash is there, presented with severe breathlessness of acute onset. She had, her infectious workup was negative, ESR was 100, CRP was pretty low. This ESR-CRP dissociation indicates lupus, and her dsDNA levels were very high, complements were normal or slightly on the lower side. And you can see the CT picture on the right-hand side, and no marks in guessing what she has. She has a lupus pneumonitis. Case number 2 is a 42-year-old lady who had a palmar skin lesions suggestive of for last 2 months. This is nothing but, it is called invert Gorton sign, which is classically seen in anti-MDA5 myositis. And she had a proximal muscle weakness with elevated CPK, and you can see the CT picture, which is suggestive of a rapidly progressing interstitial lung disease, and the diagnosis was MDA5 positive RP-ILD. Then there is a third case, 40-year-old lady who was symptomatic for 4 years with just dry cough and breathlessness, slowly progressing. If you ask her multiple times, then her complaint is dry cough, but she has breathlessness when she climbs stairs. And she has interstitial lung disease, NSIP pattern with an FVC of 56%, and SEL70 was positive, so she has scleroderma ILD. The question I am asking, case number 4, is 56-year-old male. You can see deformed hands on the right side, UIP pattern in the CT. The classical, this is a UIP, and the diagnosis was RA-associated interstitial lung disease. The question I am asking is, when to treat, whom to treat, with what? These are the 3 questions I would like to answer. And only thing, what the most important things are, all these are interstitial lung disease associated with autoimmune rheumatic diseases. Is the management same? Most of them, all of them have different prognosis. They are different pathologically. So the management is not same. And you need to individualize the treatment of these patients. You need to manage this patient in the way they present to you, and this is the most important thing you need to understand. You cannot compare apple to oranges to grapes to something else. So this is a very, very, very simplified slide for the postgraduates. This may not be the reality what we see. If you look at lupus pneumonitis, so these are the 4 diseases what I told: lupus pneumonitis, MDA5 positive ILD, scleroderma ILD, and rheumatoid arthritis associated interstitial lung disease. What we need to look at as a clinician, as a treating physician, is inflammation is reversible. We know that inflammation begets fibrosis. You start with inflammation. If you don't treat inflammation, it becomes fibrotic. And this is an ongoing process. It is not that inflammation will end one day and the fibrosis start next day. No, it's an ongoing process. Inflammation, fibrosis, but if one area will fibrose, other area will get inflamed. So it's an ongoing process and there will be multiple things happening. In lupus pneumonitis, inflammation far more than fibrosis. In MDF5 positive RPILD, inflammation is much more than fibrosis. And scleroderma-related interstitial lung disease, inflammation and fibrosis go hand in hand, or fibrosis is slightly on the higher side. In the last one, RA-associated ILD, inflammation is less and it is fibrosis is more, or that's why it mimics IPF. This is an oversimplified slide. Again, I am telling you, this is an oversimplified slide, but this is what but it's very useful for managing the patients on a day-to-day basis. And interstitial pneumonia with autoimmune features, most of them we pick up, they more or less mimic scleroderma interstitial lung disease. So you can say that most of the IPAF have inflammation and fibrosis ongoing, but depending on antibody specificities, it may change. So the first question is, when to treat? The answer is as soon as the diagnosis is made. Earlier, the better. Is there a window of opportunity? The answer is yes. What is window of opportunity? This is a slide I have borrowed from rheumatoid arthritis, where we commonly use this term of window of opportunity. What happens is the inflammation begets fibrosis, or inflammation begets damage. So if you treat inflammation, you can see on the y-axis here, the disease activity keeps fluctuating. But what gets added in the gray line there is damage. So if you treat them early, they become completely normal without much damage. But if you treat them late, definitely there will be certain amount of fibrosis which has happened. So this window of opportunity is something to less than 10 days in lupus pneumonitis and MDF5 positive RPILD. If you don't treat them within 1 week, you miss the bus totally. They may die, which has a very high mortality. Scleroderma ILD is not that fast. It gives you time. It gives a couple of years or 2 to 3 years to pick it up and treat. And whether window of opportunity really exists in RA-associated interstitial lung disease, we are not sure, because it is mimic IPF. Treating it may not make a real difference in survival of these patients. So the concept here is time lost is the lung volume lost. So you need to pick them early, preserve the lung volume, then only they do better in long term. And another very important concept, this is from the very old study of Virginia Steen, very clearly showing one thing. I just want you to look at one thing, that the disease duration, the maximum amount of lung volume is lost during the early years. This is from scleroderma interstitial lung disease. As I told you, MDF5 and lupus pneumonitis are very fast. The lung volume loses fast and they die if you don't treat them in first 2 or 3 weeks. In scleroderma ILD, because we follow them up for years, it's a slowly progressive disease. And why I am picking scleroderma ILD is because as a pulmonologist, most of your IPAF more or less mimic the scleroderma ILD in their natural history. So the maximum loss of volume happens during the initial years, 1, 2, or 3, or 5 years. After 10 years or 15 years, most of the time, if the patient is alive, the lung volume remains more or less stable. So when to treat? As early as possible. Whom to treat? So lupus pneumonitis and MDF5, there is no doubt. You have to treat all of them because the mortality is very, very high. Scleroderma interstitial lung disease, you need stratification, which I will come to a bit. I will come to it in a couple of slides later. In RA interstitial lung disease, it behaves more like IPF. Whether to treat or not to treat depends on a lot of other factors, which I cannot detail in because of the time limits. So coming to scleroderma interstitial lung disease, why do we need to stratify scleroderma ILD? First and foremost concept is, in scleroderma ILD or IPAF, not every scleroderma ILD or not every IPAF progresses. Some of them don't progress, they just stay static. So what do we do? One, treat those who progress or those who worsen, or treat those who are at high risk of progression. So treat those who progress. So then we should know what is progression. Progression means, this is one of the arthritis rheumatism article which was published 4 or 5 years back, where they have done this something called composite categorical decline. What is composite categorical decline? You are doing a regular lung function yearly. If an FVC is dropping by more than 10%, or FVC drop is between 5 and 9%, and DLCO has dropped by 15%, then you can categorically say that this person is progressing. So if somebody has dropped their FVC from 60 to 54, that's 10% drop, it indicates that the person is progressing over 1 year. And if somebody has progressed, 6%, lost their lung volume in 6%, 10% in 1 year, look at the mortality curve. You can see the black line down, the 70% 10-year mortality, which is most worse than any of the cancers. Let that point be driven in. When somebody comes to you with an FVC of 70%, and after 1 year he comes to you back to you and say, you do a PFT, it is 62%, 63%. The chance that he is going to be alive after 5 years is less than 30 or 40%. It is much worse than cancer. So in a consultation room, when you are communicating that patient, when you are treating that patient, that seriousness needs to be there. But the problem is waiting for progression is allowing lung to get destroyed. So if a patient comes to you, can I tell you, you come after 1 year, let me say whether you are progressing and I will treat you at that moment. That's unethical, that is not practical, that is not the way we should practice medicine. So then we come to the question, so can we identify those who are at risk of progression? So what are the risk factors of progression? 1, early disease. 2, SCL70 positivity. 3, low FVC at presentation, it's less than 70%. And HRCT showing more than 20% lungs involved. These are the broad things which can predict. There are other biomarkers. I am telling you the practical stuff. So once you have identified whom to treat, those at progression we will treat, those who have risk factors of progression we will treat. But then there are other factors which you need to see. For example, somebody who is 75 years, presenting with an FVC of 65, 70, you won't treat that aggressively. But somebody is 25 years, because you know he has to live another 40 years, you need to preserve the lung volume. You will treat very aggressively. Duration of the disease. For example, 2 people come to me, both have FVC of 55%. One is a 15-year-old disease, and other is 2 years. Which one will you treat? Those who are early disease, because you know they are going to progress. Comorbidity, somebody has scleroderma, interstitial lung disease, has a scleroderma renal crisis. I know his 2-year survival is going to be 5% or 6% or 10%. I won't treat him very aggressively with immunosuppression because that is going to do more harm. And lung volume at presentation is extremely important. For example, if somebody has an FVC of 20% or 15%, 25%, you know his survival is not great. He's an end-stage lung disease. It's almost fibrosed. You won't treat him very aggressively, but if somebody's FVC is 65%, you will treat him very aggressively. And last statement is extremely important. Type of ILD is not really matter. I have not shown you much evidence, but because this is controversial stuff, I'm showing the evidence. You can very clearly see from this chart, then be it NSIP, be it UIP, you can see this is IPAF. This is a very old study. This is an IPAF, but look at the CVD, associated NSIP or UIP, CTD associated NSIP or UIP, all of them have almost similar survival, except one is rheumatoid arthritis ILD, which mimics IPF. So if it's a scleroderma patient comes with NSIP or scleroderma patient comes with a UIP, your approach has to be the same. So after answering these 2 questions, when to treat and whom to treat, we will move on to the last question, with what? So look at the armamentarium of drugs. This is why all of us are very much interested in this. In 2010, when I was doing my DM, we had steroids and cyclophosphamide. In 2020 today, we have steroids, we have cyclophosphamide, we have mycophenolate, we have tocilizumab, rituximab, tofacitinib, and nintedanib. So many drugs have been added over the last 4 to 5 years. Remarkable progress has been made in the diagnosis and treatment of these autoimmune lung diseases. Cyclophosphamide was the first story. The story started way back in 2006 in New England Journal paper of scleroderma lung study 1, where cyclophosphamide, 80 patients, 160 patients randomized to cyclophosphamide versus placebo. Marginal difference of FVC 2.5% better, cyclophosphamide statistically better, clinically not really meaningful. But these patients were followed up without maintenance. What happened later was more interesting. This has to be understood because when you are treating somebody with cyclophosphamide, what happens here is that, you can see here what happened. At the end of 12 months, there was a difference of 2.7%. At the end of 18 months, there was almost 5%. Next 6 months, basically the lung function kept improving in the cyclophosphamide arm, but in the placebo arm, it slightly deteriorated. So what does this tell us? Control of inflammation today is going to prevent a fibrosis tomorrow or day after tomorrow or after 1 or 2 or 3 months. So cyclophosphamide, control of inflammation has to be the primary outcome, which will prevent the increasing fibrosis. So at 2 years, then they followed the patient at 2 years. This is 2-year data. What happened? the lung function became almost back to normal or placebo. But what did this tell us? This patient needs maintenance. So SLS2 2-year data very clearly showed us that we need to continue some kind of immunosuppression. You cannot say that I have given cyclophosphamide, I have cured your scleroderma. It is not possible for any other autoimmune rheumatic diseases, so it is not going to be possible for scleroderma too. Then came the new kid on the block, mycophenolate mofetil. From 2008 we have been using this. This is our own data which we have published in 2016, and on the right side is the famous scleroderma lung studies 2. It's a randomized control trial. Ours was a retrospective study which I had done in Kochi. So we had compared mycophenolate vis-a-vis IV cyclophosphamide. You can see in both the charts are almost similar, around 5 to 7% improvement in FVC in both cyclophosphamide and mycophenolate mofetil. So cyclophosphamide and mycophenolate mofetil work equally well in these patients. But mycophenolate mofetil is better tolerated because cyclophosphamide has more number of infections, ovarian toxicity, and possible malignancy and bladder toxicity at a later date. So mycophenolate is generally better tolerated than cyclophosphamide, but cost of mycophenolate is much higher than cyclophosphamide. But always remember, mycophenolate requires gastric acid for absorption. So if you're combining a proton pump inhibitors or anti-acid therapies, the drug level decreases by 50%. We have our own study showing the same. So always remember, it has to be given at empty stomach without any PPIs. This is extremely challenging when the patient, especially they are having a GERD associated. So when we treat with mycophenolate to cyclophosphamide, which are the first line agents, around 70% of the patients respond. You can see the upper chart, 64%. But around 30% of them, 1/3 of them don't respond to these two drugs. What do we do with them? First and foremost is somebody who has been given cyclophosphamide, switch to mycophenolate. Somebody who has been given mycophenolate, switch to cyclophosphamide. Other options are rituximab and newer options. So what about rituximab? The rituximab, this is from our own collaborators from Kolkata, Indian study, where they studied rituximab vis-a-vis cyclophosphamide. You can very clearly see this is a randomized control trial, 60 patients. Rituximab improved for forced vital capacity, while cyclophosphamide stabilized it. So rituximab slightly superior in this study. Then came meta-analysis, which was published last year in Rheumatology, Oxford, showing that rituximab is slightly better, preserves lung function. You can see at 6 months, the improvement in FVC was 5%. At 12 months, it was 7%. So it improves FVC. But this is the recent trial which was presented in American Thoracic Society meeting this year, recital trial, where they compared intravenous cyclophosphamide vis-a-vis rituximab. As you can see here, they included majority of patients with inflammatory myositis. Almost 47% were inflammatory myositis. And if you look at the increase in FVC from baseline, cyclophosphamide and rituximab, both of them did equally well. So the conclusion is cyclophosphamide presents is equal to rituximab. Tocilizumab in scleroderma, focus trial again, 210 patients. Tocilizumab vis-a-vis placebo. You can see here what happens. The red line is tocilizumab. Tocilizumab preserves lung function, while in placebo there is a dip. And so tocilizumab is a useful drug, especially in early scleroderma. And there's a long-term extension data available showing the same thing, that tocilizumab preserves the lung function, and in the placebo arm when there is a drop in FVC. And last but not the least, nintedanib, the anti-fibrotic agent. It's a very useful drug, especially in patients. This is Senesis trial. I am sure all of us must have read this. Only one thing I just wanted to point out is that when you combine mycophenolate with this anti-fibrotic, the response is much, much better. You can see this. The loss of lung volume, when you combine with mycophenolate with nintedanib, is -40. Vis-a-vis in placebo arm, it was -112. So there is a lot of difference. While comparing mycophenolate with nintedanib, you are likely to get an additional benefit. How to use this drug? So I will just be very brief. We have to look at the regular pulmonary function test and look for stabilization. So so if you have to know what is stabilization, you should know what is progression. Progression is, as I told you, FVC fall more than 10%, or progression of disease by HRCT. So you start with mycophenolate or cyclophosphamide first, or some people say the cyclophosphamide can be replaced with rituximab. If the patient is progressing, then you add mycophenolate, add nintedanib. If the patient is stabilized, you maintain them. How do you maintain them? With one of the agents. Most of the times we use the same agent, mycophenolate is there, you maintain with mycophenolate. Most of the time, mycophenolate is the preferred agent for maintenance, so rituximab 6 monthly can be used, or tocilizumab also can be used. And if the patient is stabilized, continue maintenance. But extremely important, some of the patients starts progressing when when we switch from induction regimen to maintenance regimen. If they are progressing, we need to switch back to the original therapy. So basically, the most important thing is treat to target and target your aim at stabilization. So don't allow the patient's lung volume to deteriorate. And it is our own data showing that maintenance therapy prevents mortality. I don't want to go into details because of lack of time. Role of steroids in 1 second, they are life-saving, especially in lupus pneumonitis and MDFI. You have to give high dose. They have very limited role in scleroderma. They almost have no role in scleroderma interstitial lung disease. And steroid more than 5 milligram in long term will cause a lot of damage. So please don't depend on steroids for controlling the disease. So what do you use in second-line agent in MDF5 and lupus? In lupus, it is mycophenolate and cyclophosphamide. In MDF5, it is triple therapies. Triple therapy is CNI inhibitors with IV cyclophosphamide is the standard of care. Rituximab, tofacitinib, plasma exchange, mycophenolate, all of these have been useful, but MDF5 is a very difficult nut to crack. But please watch for CMV when you are treating in MDF5. It's very common. So this is comes to the last slide. As I told you, somebody who has a lot of inflammation, like in lupus, you combine steroid with mycophenolate. In MDF5, it's a lot of inflammation again, you give triple therapy. In scleroderma, because basically there's inflammation is less, so a lot of steroids is less. You use mycophenolate and cyclophosphamide, or cyclophosphamide or rituximab, along with plus or minus nintedanib. I usually add nintedanib when the patient is not responding to the primary immunosuppression. RILD, it's a fibrotic disease, behave more like IPF. Nintedanib may be the first agent, adding on rituximab or mycophenolate at a later date. So to summarize, lupus and MDFI is like 100-meter race. It is how you start is what that matters. But in scleroderma is a marathon. How you start doesn't matter, but your consistency of the follow-up is what matters. Last slide, I'm ending. So food for thought is, disease is deadly if untreated. We have reasonably good investigations, heavily underutilized. We have drugs which is effective in close to 90%. Evidence emerged over last decade. Underdosing is hugely prevalent. No, most of the time, monitoring doesn't happen in a lot of patients, and no switching because once the drug is not effective. And monitoring tools are available, but we need to set the target. Treat to target, stabilize FEC, preserve lung. You have a good outcome if you have these three things: optimized treatment, optimal investigation, optimal monitoring. And thank you for patient listening.
Thank you. Thanks, Shenoy. Thanks, Murli. Any questions, because we are running late, and then we can break for the opening ceremony. Any questions from the audience? Yeah, Vijay, please.
Last week I had a patient who had on HRCT ILD some skin changes, and I investigated for the connective tissue disease, and I asked for a ANA profile, and SCL70 came positive. Referred to a rheumatologist, he did a ANA ELISA, which was negative. So what do we do?
ANA ELISA is outdated technique.
Right.
So you should never do ANA by ELISA, and ANA has to be done always by immunofluorescence. So autoantibodies is always, ANA has to be done by immunofluorescence.
So we have to give due respect to the
depends
SCL.
on the width of the band. If the band is reasonably high width, definitely you need to treat the patient take it as a scleroderma and treat the patient.
Yes. Thank you.
Sir, one small question, sir. Regarding MDA5, when do you start immunosuppression? As soon as you detect this antibody or ILD?
I always wish we could have identified the patient earlier. So on day one you hit. MDA5 is the nastiest. We have 3 patients currently in the ward. Very, very difficult to treat. But with intense immunosuppression, they respond, but still CMV reactivation, recurrent infection, because MDA5 is part of TL, innate immune pathway. So infection happens, the MDA5 flares again. That's why regarding COVID also, it is people say that anti-MDA5 is one of the mechanisms how it causes pneumonia. So MDA5, day one you hit very hard with steroids and mycophenolate at least. Or
as soon as ILD is detected or MDA5 detected?
As soon as ILD is detected. Some of the MDA5 do not have ILD. Then in that case you can start mycophenolate. So they have only skin lesions, but it's rare. But most of them have ILD, associated ILD. And treat them very, don't take a laid back attitude telling that this patient is less.
We lost two of our patients.
Yeah, that's why it's extremely dangerous disease.
Yeah, one quick comment. I think it was a nice presentation. The ATS ERS position paper in 2022 regarding scleroderma ILD, they have cut the bar of FEC from 10 to 5%. Similarly, DLCO from 15 to 10%. And they have endorsed the tocilizumab, they have included in the guidelines to treat the scleroderma ILD, as it stabilizes the lung function. There's a lot of data, they have done a meta-analysis, so they have choice of drug they used is a tocilizumab.
I've already told that tocilizumab is very useful. The problem with tocilizumab is cost. And second is increased risk of infection when compared to mycophenolate and rituximab. So because it lowers the CRP, once the patient develop an infection also, you will never know. That's the problem. Tocilizumab is not as simple as what we look at, because we have all burnt our fingers with tocilizumab. Thank you.
Sujit, just one small question to Dr. Murli Mohan. Sir, in your presentation, there was about 30-40% of these people of connect may develop ILD. So can you consider doing a PFT or a DLCO at an earlier stage, before you go in for imaging and doing all serological testing? Maybe say a rheumatoid arthritis, you do a DLCO, if you find it on the lower side, then you go ahead and do it with, is it a sort of a thing which I wanted to talk?
So I would certainly recommend doing two things, going by the symptoms, of course. So they start to have any undue respiratory symptoms. Two, doing a 6-minute walk test. I think that's extremely useful. Look for a desaturation when the person is walking. And if you have any suspicions, don't go by a normal X-ray, because a normal X-ray does not rule out an ILD. We heard this earlier for HP also. Then I would go for an imaging. But I would usually start when a patient has not have symptoms, maybe I would do a periodic 6-minute walk test and spirometry.
Yeah, I mean, spirometry also.
Spirometry. Oh, definitely.
Yeah, that's what I was trying to stress on.
Absolutely. Completely agree.
Thank you.
Yeah, I think Tridip also it would determine your treatment there. Because if you have a DLCO below 50% desaturation, that would lower your threshold to start treatment, as Shenoy was saying. If you have an absolutely normal lung function, you think twice about starting aggressive treatment for such patients.
Fair.
My question to Dr. Shenoy. Sir, here. So, sir, we have like CTD ILD, but some patient will come with the ILD and there is some immunological features. It's not clear cut. So whether to start on base of lung volume or whether go for the aggressive therapy or the what?
See, I will tell you something. Why I am a person who likes chaos. And interstitial lung disease is a person, there's a lot of chaos. So chaos means you have a lot of art to it. It is not science. Let us be very clear about it. Lot of art is there. How you decide which patient to treat or not to treat depends on lot of factors. And depends on what antibody is positive. For example, somebody's SCL70 is strong positive. I will go all ahead and treat. But anti-centromere positivity, I know it is not going to progress that much. I may not go aggressively and treat it, I will observe.
So here, there is a confusion. Like there is antibody is negative. Some immunological feature is not clear cut.
Some immunological means clinical features.
Some clinical, like for the example, the patient suggested of CT scan suggested of CHP. You do for biopsy, proven the CHP, but RA is some about the 20 or 30. Right? There is no that much of clear-cut history of the joint pain, swelling, and etc. So there is a common scenario we can just find out.
Yeah. If somebody who has an rheumatoid factor and anti-CCP are strong positive, there is a UAP pattern in the lung, I will go ahead and treat. But RF is 20, 15, depends on which method you are doing. You have to always do RF by a nephrometry. So you see your lab whether they are, people still do by latex agglutination and you get some report which is very vague. So immunology, the way, and I can tell you one thing, in coming years, 5 to 7 years from now, RA-ILD or interstitial lung disease, the way we are going to treat is going to totally change. We are going to look at inflammatory phenotype. We will do a transcriptome and see how much fibrosis is there, how much inflammation is there, then decide whether to give nintedanib or mycophenolate. So it is you do a skin biopsy of scleroderma patient, see what is there, or you do a transbronchial lung biopsy, send to lab. They will tell you your gene expressions are of TGF-beta or antifibrotic or collagenase, or is it a TH1 or TH2. Depending on that, you will decide there is a new drug which is coming up, anifrolumab, which is anti-interferon therapy. So it is going to completely revolutionize in another 10 years with the molecular techniques. So, but we are still stuck at the basic autoantibody stuff. So we need to really go in a fast track mode to catch up.
So the medicine is an art and you do really artistic to perform that with the patient.
Thank you.
Hand over to Thorgan, please. Go ahead.
I thank the speakers for the wonderful talk. In fact, I must say all the slides have been very beautifully designed, all the presentations, so easy for the postgraduates and young pulmonologists to pick many things. May I request the chairpersons to kindly offer the memento to Dr. Murli Mohan and Dr. Padmanabh Shenoy, sir. May I now request Dr. Vijay Agarwal, sir, to kindly offer a memento to Dr. Varun Patel. May I now call Dr. Pavan Gorkanti, sir, the Director of Yashoda Hospitals, to kindly offer the mementos to Dr. Narendra Kumar and Dr. Sujit Rajan, sir. I welcome you, sir.
Thank you, Dr. Pavan sir, for coming all the way for inauguration of this event. Now we have a very small inauguration. So as we all know, that this Pulmomentor, as I said before, is a series of academic meets which we are planning for educating the young pulmonologists, especially to do their practice in a much more confident way. And with that motto, we have started off with the ILD and the pulmonary vascular disorders. And now I request Dr. Pavan sir to take over to come to the dais for the inauguration. And along with Dr. Pavan sir, I would like to call upon Dr. Vishnu, our Chief Medical Officer, Dr. P.N.S. Reddy sir, who has been our inspiration and a pioneer in the Department of Pulmonary Medicine, Dr. Raghutam Reddy sir, who is a senior pulmonologist in our department, Dr. R. Vijay Kumar sir, who has been always an inspiration for all the pulmonologists in the city of Hyderabad, and Dr. Subhakar Kandi sir, to come on to the dais and our CEO, Dr. Karthi Velan sir, to come on to the dais for the inauguration of this meet officially. Now on this auspicious day for us, we would request the dignitaries on the stage to light the lamp and officially inaugurate this academic event. Thank you, all the dignitaries on the stage, and in the interest of time, we'll hear to few words of wisdom from our own PNS Reddy sir, who has been always an inspiration for all of us. PNS Reddy sir, over to you, sir.
Good afternoon, everybody. From the morning, we are listening to all the speakers regarding the ILDs, which is constitute about 20% of the, as per the registry also. So as the cases are increasing, they need a specific attention in the diagnosis and in the management. But that is the main reason why we wanted to initiate an ILD clinic. It will go a long way. They need some compassionate attention, early diagnosis, and appropriate treatment. I think this ILD clinic will go a long way in helping the sufferers in future. Thank you.
Now I request Dr. Vijay Kumar sir to share a few words about the event, and we are also officially launching the ILD clinic in our institute, and his views about the same as well.
Friends, we are all here to listen to so many wonderful, well-known, renowned faculty coming from across the country. Let me tell you, having organized 100 conferences myself in the last 30 years or so, it is very, very difficult to organize one, to bring all the faculty across the country and to spread and percolate this knowledge to all those people like postgraduates, practicing doctors, is a tough thing. And the most important is the help from the institute. The hospital, which is actually supporting, sponsoring all these activities, providing the technical help, the logistics. And I congratulate Yashoda hospitals, especially Dr. Pavan Gorukanti. Not all hospitals are doing this, mind you, but Yashoda Hospitals has taken a long step forward, and Dr. Pavan is very keen that this kind of knowledge percolation should happen. And knowledge, just like the electricity, the water, the heat, always flows from a higher level to a lower level. So there has to be a gradient. So this gradient is being utilized so that knowledge reaches everybody. The more you share, the more you grow. Thank you very much.
Thank you, Dr. Vijay Kumar sir. Now I request our very own Pavan sir to say a few words for all the young pulmonologists over here.
Yeah, thank you all. Dr. Vijay Kumar sir has put it in a very great way, knowledge flows from, this I did not hear before, but now that I think it is true, sir. Thank you all. Yes, we do support these conferences in my personal interest also, because I'm forgetting pulmonary otherwise, so at least a few words I can keep refreshing myself. Otherwise, Nintantinib may become first time Nintantinib, okay, Nintendo, like a video game or something like that. You can add some, otherwise these things are tough to recollect and all. So, great all, thanks for coming, but I genuinely feel I don't mind saying this. After coming from US and all also, I say that pulmonary here is the most advanced specialty in the country. I think everybody is connected everywhere to multiple countries also. And I think it's mainly the knowledge sharing. I mean, yes, this theory is the same, but I'm looking at many other departments we're also trying to do there, but no other departments comes close to pulmonary department in being absolutely catching up to the latest and linking everybody. Whatever happens here, everybody in the country will know, and not only the country, multiple other countries also. And yes, pulmonary at one time was tumulu dagalu cough and colds and cough, but now it's evolved a lot, and I think from now on, yeah, I mean, there is no other alternatives. I think malaria, typhoid, and all these things have gone down. So, I mean, if it is something for the T cells, it has to be some virus or protozoa. So, I think pulmonologists will be in the business, and that's we're in a good field. But thank you all for coming despite busy schedule. Like outside roads look empty. I don't know. I'm thinking, is it like COVID kind of things or whatever? But maybe after Diwali, people are at home or yes, whatever. But or maybe the elections or people are busy there. But because you have a lot of people from around the country have come, and please use this opportunity without any hesitation, any kind of questions. Theory is one thing. Practically, how do you deal with patients is another thing, including how to talk to patients, what to do in practice, and these kind of things. You'll not get a chance multiple times. All the leading luminaries in the country are here, so and they are more than willing to share their knowledge and experience. So, in addition to the usual things, you can, no question is too embarrassing. Please make use of this. And as Vijay Kumar sir was saying, and I mean, no better thing we do than sharing knowledge. Whatever we know, we need to try to share to as many people as possible in whatever way. Like healthcare systems are different in different parts. Like now, like I was in Osmania MBBS, so I know government hospitals. At that time, like I remember some patients with heart attack, forget about streptokinase, they did not even have aspirin, so I had to buy and give it to them, and 200 patients used to come in 3 hours or something. I don't know how did we manage to dispose those patients, and yeah, as in Manipal after that, and US residency and pulmonary critical care fellows. Even in US also, it's different in different parts. But in India, wide varieties of healthcare systems are there, so we have to try to do our best, considering the finances and everything else too. And but most importantly, we have to keep having these kind of academic sessions frequently, because you'll get to meet the leading luminaries and what exactly inspired them to be in pulmonary and what exactly motivates them to continue in this field. Otherwise, day to day, you know, the practice is just demands of practice is very high too. So you need to take a little time to interact with people and have some fun. So maybe academic fun now and the regular fun in the nights or something. Okay, thank you.
Thank you, Dr. Pawan sir. Now I request Dr. Pawan sir to officially inaugurate our ILD clinic. We have made a small ILD clinical pro forma, which we thought would be useful for all the people who are practicing, and I would like to request Dr. Pawan sir to officially inaugurate it. Dr. Pawan sir and Dr. PNS sir and Dr. Vijay Kumar sir and all the dignitaries on the stage. Yeah, definitely. Actually, it is put in all the broad files also for you. You credit to Yashoda. We want to use it. Make it little personalized also. Yes. Great work. Thank you. And wonderful. Thank you. I went through this. Yeah, thank you. Yeah. This one is in November. Next one. November, December. Yes. Thank you everyone for the patient hearing, and thanks to all the dignitaries on the stage. Now we'll move on ahead with the academic session. Sir? we can announce the team. Sir, now we'll go ahead with that. So we'll just play a small video snippet of what are the services which we are trying to offer in the ILD clinic. Followed by that, we'll go ahead with our academic session as planned. And I will also take this opportunity and I would request Dr. Pawan sir to felicitate our interventional pulmonology fellows. We have been running an interventional pulmonology fellowship course, and every year we have 3 participants in that, and this year we have got 2 people who are passing out from our institute. I would like to call upon Dr. Sindura, who has just finished her interventional pulmonology fellowship here. She's Thank you, sir. Now we'll. Thank you, Dr. Pawan, sir, for. Now we'll go ahead with the next session. So in this session, we have a talk by Dr. V.R. Pattabhiraman, sir, who is a pioneer in the field of interventional pulmonology. And can we have Dr. Pattabhiraman, sir, on stage, please? And to chair this session, we have Dr. Ragautam Reddy, sir. I think we need to call. Dr. Vinay Kumar, sir. I think people are there in the tea break. Yeah, sure. So we'll just break for 5 minutes and then we'll resume it back. Yeah, sure.
I just wanted to. He's been asking for that road. What is asking? We should just be trying. They should. I mean, we would do this. We all of us. I come and sit here.
There's one video, the most important video. should I take it out or?
No, you can just check it.
I just want to know whether that video runs. Why is this not coming up?
We'll just copy this PPT sequence.
It's got. Okay, just drag it out. Let me see if it runs in this. What does it say? Well, that's all that I wanted. Okay, I'm good to start. I don't think you should waste time on introducing and all that stuff. Let's just go on with this.
Chairperson.
Just ask who's the chairperson. We just say this is the first slide, is the introduction.
Yeah,
This is introduced already, so let's just go on with this. Just don't bother about introducing. Just
Yeah, I will start. Raghutam sir alone you call. We will start. So we are resuming our academic session. So for this session we have the talk on cryo-TBLB in ILD by Dr. V.R. Pattabhiraman sir. And to chair this session we have Dr. Vinay Kumar from Karimnagar, Dr. Giriraj Boma from Dr. Giriraj Boma sir, and our own Dr. Raghutam Reddy sir. Thank you.
Good afternoon. Thank you very much for the Yashoda group and Dr. Vishwa for giving this opportunity. And Dr. Pattabhiraman doesn't require introduction, well known across India, and enthusiastic, and has done so many interventions. He's a consultant and interventional pulmonologist at Royal Care Hospital, Neelambur, Coimbatore, and he's a visiting professor at SRMSC, Chennai, and a full-fledged interventional pulmonology group called CAPI at the Royal Care Hospital, Coimbatore, and he introduced endobronchial ultrasound to the country in 2008 and bronchial thermoplasty program in the country in 2017, and has published so many articles, more than 15 in IP, and authorized chapters in 2 textbooks, and has done training programs in IP and many guest lectures and talks in national and as well as international conferences, and organized BronchoCon in 2018, and runs a 1-year IP fellowship course affiliated to IAB, and special interest in training in IP. Over to you, sir.
Thank you, Chairman. Thanks, Vishwesh, for this opportunity. So I'm not going to waste a lot of time. Let's get on with cryo-TBLB. So we've had discussions so far, and so let's just discuss whether we need histological patterns in the diseases that has been discussed so far, and if yes, I mean, why do a biopsy? Because the treatment would be between glucocorticosteroids, immunosuppressive drugs versus antifibrotic agents. So in an ideal situation, all patients should get a lung biopsy. There has to be a definitive diagnosis, and you can actually, circumvent medical legal issues. And for research purposes, it's quite, scientifically appealing to get to the bottom of it. Unfortunately, any diagnostic procedure in medicine is not only painful, it's expensive, and it can potentially kill. So you have to choose, and you have to choose wisely. So I'm just going to take you through the following agenda. When can we do a biopsy? When can we do without a biopsy in ILD? So what are the cases where I wouldn't really bother to do a biopsy or consider a biopsy? What is the role of flexible bronchoscopic lung biopsy, which is a TBLB? when to perform a surgical lung biopsy, what is the role of cryobiopsy, when not to perform a lung biopsy, and what to do with the biopsy report. So these are the things. Let's just get on with when we can do without a biopsy, when the clinical context and HRCT chest pattern can provide a confident diagnosis. So it's very important to have a clinical context to the HRCT things. And the HRCT is consistent with a definitive usual interstitial pneumonia in an elderly smoker with no other features apart from the interstitial lung disease features. Then you could circumvent if it's a definite IPF, UIP, IPF. Or in a case of a connective tissue disease related ILD with a very strong serology and in a proper clinical context. And also, this term is no longer used, not subacute, it's now called non-fibrotic hypersensitivity pneumonitis with a typical exposure history. You wouldn't probably do it. At times, we would end up doing it if the patient really wants to know whether there is a definite association. So, HRCT consistent with a definite UIP pattern with the peripheral basal predominant disease with honeycombing with the absence of the following. We've already discussed radiology. So if it's a definitive UIP with a consistent clinical picture, we wouldn't bother. So, this is a definite UIP when you have all these features, and it's encountered in about 50% of patients with IPF, and a probable UIP is all the above features without a definite honeycombing. So even in this group of, in definitive UIP with a context of IPF, you wouldn't bother. But if it's a probable UIP with HRCT showing everything in the peripheral thing with a reticular pattern without a honeycombing, that is a probable UIP. If the age is more than 60 years with a lot of interlobular septal thickening and large area of traction bronchiectasis, again, you could do well without trying to do biopsy. And CTD, we already told the association between histopathological pattern and clinical outcome is less certain than that in IPF. So it doesn't matter whether it's a UIP or an NSIP, you would anyway have probably the treatment wouldn't differ and prognosis probably might be mildly affected. But again, so we'll do it only at the insistence of a rheumatologist. They don't really advise a lot. Some studies suggest that UIP pattern histopathology is associated with poor outcomes in rheumatoid arthritis and scleroderma, but other indicates that the extent of the disease is more important. So response to immunosuppression seems to be similar across the histological subtypes. So these are the reasons why we wouldn't want to do a biopsy in a connective tissue disease, because it's unlikely to provide an additional prognostic information. HIPAF is a different thing, of course, and this is a typical non-fibrotic HP, wherein if there is a involvement like a frank pigeon exposure, you would probably get away without anything. So in our practice, no lung biopsy if the HRCT is consistent with definitive UIP, and clinical possibility is IPF. No lung biopsy if HRCT is consistent with the probable UIP and age is, elderly population with interlobular septal thickening and traction bronchiectasis. Only if the patient is not fit enough for TBLC, I would add. And no lung biopsy in serology and clinically correlating CTD-related ILD. We do not perform lung biopsy in subacute, or non-fibrotic HP with typical exposure history with no other explanation. Let's go on to what is the role of, TBLB is just one slide. It's sarcoidosis. Yes, in others, when there is only, a bronchocentric thing with the pulmonary alveolar proteinosis where lavage can do. It's only when there is an alveolar filling and there is nothing else apart from that, you might be able to do it. And with a reasonable certainty in lymphangitic carcinomatosis, you might get it with the proper clinical assessment, but there's no role in diagnosis of idiopathic interstitial pneumonia. So let's move on to surgical lung biopsy. Surgical lung biopsy is the reference gold standard in all these cases. But in our practice, we consider it only in those patients who, where there is a difference between NSIP and UIP is the issue, because you need to go to the pleura and along with that, subpleural areas, mostly in a setting of a failed TBLC. Elsewhere, we do cryo-TBLB. So these are the three biopsy specimens. You can see that these are low power thing. You can have a surgical biopsy on your left side, which is a bigger thing, where a cryobiopsy is an adequate thing in most of the situation. And it turns out that you'll need to have at least a 5 millimeter, on average, and more than 100 alveoli, which usually happens in most of our things. And transbronchial biopsy is a very small piece, which we cannot really, depend much on. So let's go to the role of cryobiopsy. You see that conventional TBLB, you just take a small bit of it between the cups of the biopsy forceps, whereas in cryo-TBLB, you actually put in a cryoprobe distally. you allow the tissue to, coalesce around, and then you kind of yank it out so that the traction will get you a lot more of tissue without any artifactual, compression artifact is not there. So you actually have a retained architecture when you just do this. The problem obviously will be bleeding and pneumothorax will be, which are the issues that needs to be taken care of. So cryo lung biopsy or cryo TBLB, which came out in respiration in 2013, early 2010, 29, I think, the cryo TBLB, which started off, and now we kind of, it's more nuanced now as to what are the areas that needs to be targeted. If you go too proximal, you will end up having a large vessels, you might have a lot of bleed. If you go to the subpleural area, you will have a lot of high risk of pneumothorax. So the target area will be the low risk of pneumothorax, lower bleeding risk due to smaller vessels. That is the area around. This is where you can target a TBLC. So it goes without saying that differentiating between an IPF or a, which requires a subpleural thing, you might have to go a little further down, so you'll have to accept a higher, pneumothorax rate. So it could go to the tune of 22%, in one of the studies 24% in fact, where their specific agenda was to look at whether it was a NSIP versus a UIP. In those cases, you might have to go distally. And we've actually, in that paper, I think from the Italian group, there were a lot of intercostal muscles in pleura were seen in the biopsies. So I think it's a very aggressive form of biopsies where you'll have a lot more of things. So this is the average specimen on the left. This one is a transbronchial lung biopsy. This is a cryo lung biopsy. You get a reasonable amount of information. You would avoid in anyone more than 70 years, FVC more than 1.5 liters will be a useful thing, and it shouldn't be a hypoxemic and room air. And mild pulmonary hypertension is okay. The more important things are it is best done under rigid bronchoscopy. The conduit is very important because you will need to protect yourself against the bleed. Use of occlusion balloon turns out is mandatory. Fluoroscopy should be used if it is available, and at least 4 biopsies, each measuring at least 5 mm in short axis, or in fact together 5 mm also is accepted, ideally from 2 different lobes, at least from different segments, but ideally from 2 different lobes. These are the technical aspects. And the area of samples strongly correlates with the diagnostic yield. The median area of sample this is the difference between, VATS lung biopsy versus cryo TBLC. Pathologists suggest 5 mm as accepted diameter for TBLC sample. So this is a procedure. This is just in our bronch suite. This is our colleague Dr. Arjun doing it. So you can see that there is a rigid bronchoscopy in there. The first thing is you put in an occlusion balloon. So the occlusion balloon is preferably parked in the place where you need to do a biopsy. So you just put in a Fogarty, you inflate and test that the Fogarty is okay. And you can see that in the rigid, you can put the occlusion balloon on the side, not on the main bronchoscope. So on the side port of the rigid is where you put the occlusion balloon, and then you have the bronchoscope which goes in and the cryoprobe which goes in. The most important thing is the fluoro. If you can concentrate the fluoro, you can see that the fluoro comes here. It goes as distal as possible, and then you take about 1 to 2 centimeter back, 1 to 1.5 centimeter, and after that you do a cryo. Now the cryo is on. You can see that the cryo along with the probe along with the scope is taken out. Now this is the reason why you'll need a balloon occlusion, and you can see as soon as it comes out, the person will be who is handling it will make sure that the balloon is inflated, and he'll inform that, because there is some time taken for the probe to come out and the specimen to be thawed out, and the probe comes out, and then you go back in. So with this, you can see that you'll need a rigid bronchoscopy for a few reasons. One is it's a good conduit so that you can go back easily. And second thing is a balloon can go on the side port, not through the bronchoscope, so that you can park it the place where we want it, and one person specifically takes care of the occlusion part only. And then the bronchoscope comes out, the cryoprobe comes out, and then this is teased out, and then the probe comes out, and you go back in. It's about 1 minute. And if there is going to be a massive bleed in that 1 minute, you're going to have a problem. And if you have a fluoro, then you obviously have a protection against pneumothorax, because we know how far away from the pleura you are when you're doing it. And you go back in and you can see that this is a good way of inflated balloon. So imagine if there is a lot of bleed happening in that subsegment, you can actually have a patient with a very poor reserve, because imagine these are patients with bilateral interstitial lung disease, and if you have a significant bleed and they occupy most of your areas, then you'll have a problem secondary to hypoxemia, and some patients don't really do too well. So we actually, 4 of our centers, this happened pretty early in our thing. This came out in 2017. After pooled data from 4 of our centers from India, ours, Dr. Ravindra Mehta's from Bangalore, PGI, Durya was the first author, and AIMS, Dr. Karan Madan is there. So 4 of our centers, we just pooled our data and found out that we had 128 subjects. Overall diagnostic yield was around 78%. 4 deaths occurred, 2 because of acute exacerbation of IPF. So this is a GA, and so there is a very elegant study done by Dr. Pannu et al., who showed that if there is a rapid deterioration of a lung function, then you wouldn't really time your GA at that particular point. And Durya's meta-analysis showed that the mortality is 0.1%, severe bleeding 0.3%, and pneumothorax in about 7% of the cases. Again, there are different studies which had different rates. But look at all these studies, you can see that the diagnostic yield is 84% in cryo-TBLB as against 90% in VAD. So it's just most of the diagnostic work with the flip sides being a lot less. Mortality is 0.5% versus 2.3%, and bleeding is about 21%, but it's mandatory to have an occlusion balloon, otherwise you just don't think. Some of the examples, this is a 64-year-old smoker. CT showed a probable UIP, and CTD exposure was negative, TBLC was done, and you can see that some patchy area of fibrosis and a fibroblastic foci. And a patient who was not really looking like an interstitial lung disease, but not specific patterns, and we did found out that there were some clumps of abnormal looking cells which are mucin secreting, which is diastase positive in those pink areas, and it was a mucin secreting adenocarcinoma, versus this patient who had a history of pigeons, but he was not really, it was in the terrace, he was not growing it, but we had a provisional diagnosis between IPF and a chronic HP with this kind of a probable UIP pattern, concentric interstitial thickening, cryo-TBLB was shown. So here you can see that these are refractile bodies inside. So these are the pathologists who would clearly call it a cholesterol cleft or refractile bodies inside the alveoli or inside the bronchiole. So this is inside the airway. So it is either due to aspiration or because of alveolar injury due to an inhalation thing. So this, along with some giant cells which are loosely formed and some anthracotic pigments on the left side, and you could see that there are a lot of lymphocytic aggregation. So the interstitium with an expansion due to infiltrates of lymphocytes, histiocytes, and few plasma cells, occasional histiocytic aggregates, and another thing that is usually seen is peribronchiolar metaplasia. These are all features which are compatible with hypersensitivity pneumonitis. So when not to perform a lung biopsy, when not to consider a lung biopsy, initially we discussed when biopsy is not required. Here we're discussing why we shouldn't do a biopsy even if it seemingly requires it. This is a right away from the surgical people. They've just found out that the complications are very high if you do a surgical lung biopsy in a mechanical ventilated patients. But if you look at the recent ERJ, there were 2 studies that looked at people who were at risk for a TBLC in a conventional basis, and those 2 studies were discussed. And here you could see that 38 patients with high risk versus 58 patients with low risk. The age group, these are more than 75 years, higher BMI, more than 45, FVC less than 50%, DLCO less than 30%, or significant reduced EF. These patients were also subjected, and they found out that the adverse events was equal number of bleeding, pneumothorax, mortality, and hospital stay between the 2. So you could probably extend your indications, and you might not be put down with a poor performance status. We are also compiling our data with all these, most importantly, less than FVC less than 50, and DLCO less than 30. We are in the process of collating the data. But these are patients who walk in and walk out. What happens if the patient is critically ill in acute hypoxic injury? And this is a fascinating study by Mata et al., which is rather brave, bordering on stupidity, because patients who were actually hypoxic respiratory failure, almost on the ventilator. I'm not too sure what they were going to prove, but the diagnostic yield was 88%, so they proved quite well. But look at the adverse events: 35% of pneumothorax, ICU mortality about 1 in 2 patients didn't really make it because of the procedure. So these are the ones that you probably wouldn't actually want to get in at this particular point. So these are the valid contraindications. Some are relative: age more than 75, FVC less than 50%. Are relative. Moderate is relative. Severe PAH, we wouldn't really bother. And hypoxic respiratory failure. Most importantly, hypoxic respiratory failure might tolerate a procedure which goes uneventfully. But you are looking at a 10% chance of a pneumothorax. Even a small chance of pneumothorax will be a problem. And also bleeding. For these people, if the borderline, you might have to go to Fogarty into subsegment. So those are the issues there. So you must understand these are not really comfortable procedures. These are not procedures like in EBUS. These are not standalone interventional pulmonology procedures. For cryobiopsy or for obstructive airway disease, these are the ones, the interventional procedures that has to be done in a setting of multidisciplinary team meeting, not as a standalone thing. You can't say that I'm an interventional pulmonologist, so I'll do these procedures. It has to be under a context of a team thing. So we do not obtain lung biopsy in those with hypoxemia and moderate pulmonary hypertension. FVC, we still have a bit thing, but we do not get any form of lung biopsies in mechanical ventilation. So what to do with a biopsy report is the most important thing. You can do a rocket science in terms of getting all these tissues out. But there has to be a proper framework on what the pathologist wants to do and all that. I mean, there are very elegant thing. Our pathologist is also trained with Dr. Tazelar and Mayo Clinic. And so there are avenues of actually learning with you as far as interstitial lung disease goes. So the pathology report should be combined with clinical data and chest imaging pattern. I think Deepak briefly alluded to it. MDT has to happen before with the pathologist and after the biopsy procedures also. This is because the same histologic pattern can be seen in variety of ILDs. And so you just don't want just the pattern, you want a comprehensive diagnosis. And the cryo-TBLB is a non-diagnostic in about 20%, surgical biopsy is non-diagnostic about 10%. So MDT approach is now considered as a reference standard and is recommended the standard of care for a diagnosis of ILD. So sometimes after MDT, it's also, I mean, with all these things, there can be a poor concordance. So this is reasonable to provide a best fit working diagnosis. So to summarize what I've just said, cryo-TBLB as a, I mean, biopsying and with the cryo-TBLB, because we now assume that biopsy in an ILD will be a cryo-TBLB, and following all the recommendations now, started with American recommendations in ERJ. If you read that paper which I showed you briefly, they just, there were about 11 people, which was a task force which was looking at the role of cryo-TBLB exclusively, and they looked at 4 PICO questions and 2 narrative questions, and it's a fascinating read. I think we've got a lot of information now to really crystallize what you're going to do. The combination of clinical context and HRCT may provide a confident diagnosis in a significant number of cases. You can actually, in an MDT, you wouldn't want to biopsy those cases. In appropriately selected cases, cryo-TBLB or surgical lung biopsies in Indian context, I would suspect it's going to be lumped together, can provide a valuable diagnostic information that cannot be obtained by any other means. And lung biopsy may be unnecessary in those patients with a definite UIP or on HRCT or a well-defined, both serologically and clinically defined CTD-ILD or a drug-related ILD or an occupational exposures and so on. And surgical lung biopsies are associated with increased morbidity and mortality. In fact, the open lung biopsy is now done away with because mortality is 5% or more, in some studies about 17%. And VATS lung biopsy is the standard, and a VATS lung biopsy has a mortality of around 2.5, and average stay is 3 to 7 days, in fact 5 to 7 days, and pneumothorax rate is 100% because they always leave the chest tube thing. So I think there is a lot of thing, and there is a higher chance of worsening of IPF following a surgical lung biopsy than in a cryo-TBLB also. So there is some gradient both in terms of diagnostic capability and, more importantly, in terms of the harm that it can provide. There is a significant, TBLB can be used as a first-line technique in sampling lungs in ILD after understanding the risk-benefit and after fulfilling the training needs. No, these are very important. These are not ordinary procedures because the procedure per se looks easy, but the patient in question is not very stable. It's not like a mediastinal lung thing, or not even like a malignancy where there is a acceptable prognosis, and the patient invariably gets better after you go in with the therapeutic thing. Here, you're going to do more harm than not in about 1 in 7 patients that you're going to do. So you'll need to have the training needs in a setup that is experienced both in doing the procedure and handling the complications, and also in a setup where there is a pathologist who can actually, of course, that can be, that part of it can be outsourced, but you'll have to have a pathologist who is actually trained in identifying all this. So this, I thank Vishwesh and be happy to answer questions.
So wonderful talk, sir. Where exactly the cryo-LB can be done, that sir has elaborated very nicely. Any question from the audience side? Just we will take it, 1 or 2 questions.
Yeah.
Just 1 or 2 clarifications. What is the youngest age you did cryo? Our center also we do quite number of cryo LBs. Because why I'm asking this question, recently I have a boy with 8 years. He has diffuse ILD. He visited many centers, many corporate hospitals, finally landed up with me. I'm little hesitant to do cryo, just your
Younger patients, we usually get you a VAT surgeon because things are more controlled there. If the patient has a reasonable lung reserve, we do not have any experience in that.
Okay. What is the youngest age you did?
Youngest case we did? It must be in the 20s.
Okay.
Yeah, we've not done it. I'm talking about very specifically cryo-TBLB in diffuse lung diseases. Focal lesions and all are different, but these are,
this is
here
diffuse.
thing is you get a one shot. So if you get a one shot for a GA, I would rather go for a thing that has a better yield, and that's why we would probably consider a VAT surgeon. In fact, we have a VAT surgeon who can also do the proper thing. So that is the reason why we would. I think it is a choice that if you have no other alternative, you could probably go in and do the procedure. Now, obviously, whichever way you look at it, it's only pneumothorax and bleeding. And if you use a proper thing, you can probably have a probe which is of a lesser diameter from 1.1 to 1.7. You have other things, and you have appropriate blockers, appropriate Fogarty's, appropriate rigid scopes, and appropriate bronchoscopes. So I think the technology and the wherewithal is there. So I wouldn't think that you should be, you could do either a cryo-TBLB or a VATS biopsy. I would be tempted to do a VATS biopsy because we do not have a lot of experience in smaller samples in younger people. So it must be something rare. So I would rather have a better sample for the pathologist than that.
Thank you.
So, Ravi, could you please allude on the number of the cryo probe that you use for the transport?
We use 1.9. So there are 1.7, 1.9, and 2.4. Bulk of the initial data came with 2.4. And then subsequently realized that 2.4 has a limit in going to the periphery. Though it can get a larger picture, there has been 55 to 60% based on the Duria's data. 55% of them were done with 1.9, and I suspect even now it's 1.9. 1.9 is the workhorse for a cryo-TBLB. And that is, both good in terms of going all the way and, getting a reasonable chunk of tissue. So we would think that 1.9 would be ideal to start.
And you take from both the lobes now, since we know that there are a lot of discordance as far as the histopathology is concerned.
Yes, we usually use at least 2 lobes.
2 lobes or the segments when we are doing a transplant.
So if you're doing only, it depends on the CT. If you have a wide thing, we use at least 2 lobes. If it is within the same thing predominantly involved, we might take 1 from others and the remaining 3 from more involved in different segments though.
So you control the bleeding in the first and then you go to the other because you have a Fogarty which is...
so typically you put in a Fogarty and then you do the procedure and then you go back, you deflate the Fogarty and then see if there is no much of a bleed, we just go ahead and do it. If there is a bleed, we'll wait for the bleed to settle down before we go that. There are aggressive people who use multiple Fogarties, the smaller sizes. There are 4 mm Fogarties and 2 mm Fogarties. So to not to waste time, they'll just keep plugging 2 or 3 Fogarties. I think Polity does that. I see no reason to do that because it's going to prolong the procedure in a few more minutes for you to wait and do it. And we'll also be happy that there is not a big bleed there, so we'll constantly go for the next bite.
Okay, thank you.
Yeah. Okay, sir. Sir, all the NSIPs and probable UIPs which are reported by the radiologist or in the radiology, sir, those are subjected to the cryobiopsy, you mean to say?
Yeah, cryobiopsy is offered to them.
Cryobiopsy is the option. After evaluating everything,
Yes.
NSIP and probably VIP.
No, chronic, see, there are different things that you'll need to know. The difference between a chronic HP versus IPF. So if I've just told the first three scenarios, if it is not in these three scenarios where you don't really need a biopsy, everything else we'll offer a biopsy. But we'll not do it in certain cases which have been explained like in high risk for the procedure. So our thing is very simple. You rule out, if MDT need not necessarily be in a AC room with all these people with the slides, projectors on. So we just pick a phone, there are 3 people, and then we over a cup of coffee we can finish that. So MDT will be done, of course, with the proper radiologist sitting there. And if they say that, okay, this is it, and if the clinical context is there, we don't do it. And which is happening in at least 50 to 60% of the cases. Remaining cases, we'll offer them. And if the patients are not really fit, we'll not do. So that is our logic.
Thank you, sir. Thank you very much, sir. Thank you.
Sir, for cryo, have you searched for pulmonary artery hypertension if there before putting a patient subject for the cryo?
Yeah, all of the patients will have an echo before.
And how much of the safe you can go for the RVSP pressure?
So the studies say mild, but now there are studies saying that moderate also is okay. So, I mean, it's not the pulmonary vascular bleed that usually happens. It's usually the bleed happens around the main bronchial thing because it's going too proximally. So that study which came out in 2021 said that even if it is a moderate to severe hypertension, the risk of bleed is just about the same. Having said that, the guidelines still suggest 45 as a cutoff, and beyond that don't do. So at this point, we are not really very aggressive on that particular point. Thank you.
Thank you, sir. We'll take the questions afterwards.
May I now actually request Dr. Raghutam Reddy, sir, to please join the chairpersons. And the next talk would be by Dr. Harjeet Dumra, sir, on management of pulmonary vascular diagnosis to follow up. Kindly request you to introduce.
Dr. Harjeet Dumra, sir. He is a consultant transplant pulmonologist, sleep medicine and critical care specialist, KD Hospital, Ahmedabad, Gujarat. Director, Sparsh Chest Disease Center. Honorary pulmonologist and critical care consultant to His Excellency the Governor of Gujarat. Teacher of DNB Critical Care. Teacher of IDCCM. And numerous papers in the indexed medical journals. Authored chapters in textbooks of pulmonary and critical care medicine. Faculty in various national and international conferences also. Areas of interest is mainly in the critical care, pulmonary hypertension, interstitial lung disease, lung transplant, infections, and interventional pulmonology. So the stage is yours. You can continue.
Thanks. I know this is an intervention. I'm going to deliver my talk before lunch, and I know I am between you and lunch. So thanks, Vishwesh, for having me here. I'm going to talk on something which is not commonly talked at conferences. So this is pulmonary vasculitis. A new topic for me as well, because although we see these patients on and off, but sometimes because it is not so prevalent, because we are not well versed with diagnosing them and sometimes treating them, we usually end up referring these patients. But I think as pulmonologists, we should take the center stage now and treat pulmonary vasculitis in addition to help from the rheumatologist. So I'm going to base my session around a talk, and I usually use a vignette of a case, and I'm going to highlight the salient features about managing pulmonary vasculitis. So this is a patient, 52-year-old, non-smoker. He has occasional rhinosinusitis, and he presents to the emergency room with worsening breathlessness since last 1 week with productive cough. His SATs on room air around 88%. Additional history shows that he's got low-grade fever since quite some time, has had significant weight loss, and now he's down to 32 kgs. He's also complains of heartburn and dyspepsia, and he's been throwing up over the last 4 days. Additional history, he gives me a history of asthma for the nearly last 10 years, has been taking ICS-LABA combinations. On detailed history, it's with poor technique and very low on compliance. Usually finishes 1 salbutamol MDI in a month, and he's on a bunch of oral drugs. He's been having frequent hospitalizations for exacerbations in the last 5 years, and each time this exacerbation is treated with high-dose steroids. Some additional information, his absolute eosinophil count in the last 3 to 4 years, depending on what I see, is between 450 to 1800. IG is on the higher side, does not have any spirometry, and ECG is normal. I can pick up an echo from 2009, and that was normal. And the present echo, which was done around 2 months before he came to the hospital, showed global LV hypokinesia with an ejection fraction of 35%, associated mild pulmonary hypertension and mild pericardial effusion. This is the CT is already carrying with him. You can see that in the right base there is a focal consolidation with perifocal ground glass. There is some pericardial effusion, some left pleural effusion, and basically some septal thickening. Obviously, I advise hospitalization for this patient. We sent some workups, we stabilized this patient and sent additional workups. The salient ones, his absolute eosinophil count is about 2,000. His ANCA, which we did right up front, was negative. His BNP is on the higher side. Cultures turned out to be negative. Once he stabilizes, we run a coronary angiography because his LV had gone down. That turns out to be normal. Prior to discharge, we plan a spirometry, shows a severe obstructive loop. It's around 30%, 35%, 30% post bronchodilator FEV1. So just to summarize that, this patient has long-standing asthma, he has eosinophilia, he has polycirrhosis, pleural and pericardial effusion, and he has normal coronaries with global LV hypokinesia signifying a cardiomyopathy. So I suspect a vasculitis. Now, because this ANCA was negative, I was not confident whether he had a vasculitis or not, so obviously I get the rheumatologist to take a look at him. Just to run a brief on pulmonary vasculitis, this is a wide spectrum of disease. Usually the unifying factor amongst all these diseases is inflammation and destruction of the blood vessels within the lung. And depending on the site, the size, and the type of vessel involvement, you would classify these vasculitis. The site could be in the sense it involves the lung, it involves the kidney, it can involve the skin, it can involve even the large arteries, the medium-sized arteries, the small arteries, and it could be posse-immune or immune complex mediated, and hence, depending on these three factors, you end up classifying vasculitis. Vasculitis management is usually a challenge. Why? First and foremost, these are multi-system disorders. So it's not easy to differentiate a vasculitic presentation with an infective focus, with connective tissue disease, and occasionally a malignancy also. Secondly, you cannot easily differentiate between active vasculitis and maybe a complicating infection, drug toxicity, or it could be a combination. And thirdly, it is associated with significant mortality. So ignoring or mistreating it would lead to death. So how do we classify vasculitis? Primarily, we look into vasculitis in the form of secondary, which is secondary to some multi-system disorder. It could be autoimmune, could be infection, could be paraneoplastic, or primary vasculitis. Now, primary vasculitis could be idiopathic or immune complex mediated. Usually, the idiopathic varieties are classified into large vessel, medium vessel, and small vessel. Just to sort of cut a lot of talk there, this diagram would simplify stuff. So usually the large vessels are Takayasu's and giant cells. The medium vessels are Kawasaki and polyarteritis nodosa, but we are primarily focusing on small vessels. So once you identify a vasculitis, the second thing you usually ask for is an ANCA. Now, since 2012, the Chapel Hill Consensus Conference formally adopted the term ANCA, for which 3 disorders were grouped in one ANCA-associated vasculitis. These are microscopic polyangiitis, granulomatous polyangiitis, eosinophilic granulomatous with polyangiitis. So if you have a positive ANCA, you end up having one of these 3. If you have a negative ANCA, the next test you ask for is an IgA. If that is positive, you suspect a Henoch-Schönlein. If it is negative, you suspect cryoglobulins and so on and so forth. I'm not going to focus on the others because those are the ones which we don't see commonly involving the lung. So today for the session, I'm going to focus on ANCA-associated small vessel vasculitis. So what are ANCAs? Basically, these are autoantibodies against nuclear or cytoplasmic antigens. Depending on where you pick up the antigen, if it is a cytoplasmic antigen, you label it as C-ANCA, or to be more specific, a perinuclear PR3 antigen, or if it is basically a perinuclear antigen, it is called P-ANCA, and that is myeloperoxidase. Sorry, this is proteinase 3 antigen, and this is perinuclear. Perinuclear is around the nucleus, and proteinase 3 is in the cytoplasm. So if you have a C-ANCA, by and large, you are talking about PR3. If you're talking about P-ANCA, you're talking about myeloperoxidase antigen. Why is the relevance of ANCA? Most of the times, if you have a positive ANCA, it confirms the diagnosis. That is the most common scenario when you're dealing with granulomatous polyangiitis, or as we commonly know it as Wegener's. In fact, 95% of Wegener's would have positive ANCA. The proportion would be around 90% in microscopic polyangiitis, but it will be as low as 40% if you are dealing with EGPA. So a lot of ANCA-associated vasculitis could be ANCA negative, and the commonest scenario like that would be seen with EGPA. It is rarely seen with GPA and occasionally seen with MPA. So just if you have a negative ANCA, it does not rule out an ANCA-associated vasculitis. To clarify that thought, I'll come back to that a little later during the talk. First and foremost, do not send ANCAs indiscriminately. Why? Because if you don't have pre-test probability, the chances that false negatives would come up or false positives would come up are extremely high. If you have a C ANCA or anti-PR3 positive, it is extremely specific for GPA or Wegener's. But if you have an MP or a P ANCA, it could be seen in other disorders like rheumatoid arthritis, Goods-Pasture syndromes, or IBDs as well. So a C ANCA is extremely specific, but a P ANCA is sensitive but not specific for MPO. Why do we need to look at ANCAs besides diagnosis? It also indicates remissions and can predict relapse, but a negative ANCA does not necessarily mean that the disease is in remission, and a positive ANCA does not necessarily mean that the disease is active. You need to take a wholesome picture. So how do you approach a patient of vasculitis? So any patient who presents with multi-system involvement, which is not an infection or malignancy, you can think of vasculitis. First and foremost, the thought should cross your mind that I'm dealing with vasculitis, that is considered the diagnosis, and then you look at clinical, radiological, laboratory, and HP pictures. So usually these patients have constitutional symptoms like fever, weight loss, anorexia, and then you can have involvement in the upper airways, in the skin, in the neurology, renal syndromes, diffuse alveolar hemorrhage, and lung involvement. So usually they are widespread. One of the presentations is diffuse alveolar hemorrhage, but in the Indian context, do not think of vasculitis as the first and the only cause of diffuse alveolar hemorrhage, because there are several tropical illnesses, there are drugs like anticoagulant therapy, and so on and so forth, which could lead to DAH. So vasculitis is one differential, it is not the only reason for DAH. ANCA can also be seen with interstitial pneumonias. In fact, MPO ANCA is the one which you would see with interstitial pneumonias. We rarely see PR3 ANCA. And the most frequent radiological presentation, if you have an ANCA positive ILD, is UIP. The other patterns are less commonly seen. And if you have a vasculitis presenting as an ILD, that is without other features of vasculitis, the mortality is higher. And if the pattern is UIP, it is again the mortality is higher as compared to other patterns. Sometimes vasculitis can present as venous thromboembolic disease, that is DVT with pulmonary embolism, to the tune of 8 to 10% of ANCA-associated vasculitis. The presenting feature could be thromboembolism. So we are looking at three main diseases in the lung: GPA, MPA, and eosinophilic granulomatosis with polyangiitis or Churg-Strauss. How do you end up differentiating them? Primarily in the upper airway, epistaxis is one of the common manifestations with ulcerations in the nose in Wegener's, while asthma is the commonest presentation with eGPA. Airway involvement is not uncommon with GPA, but it is in the form of stenosis, where here it is asthma. The radiological presentation is consolidations, cavities, and nodules with GPA. It is usually alveolar hemorrhage. So if you are seeing an alveolar hemorrhage and if you suspect vasculitis, MPA is the commonest presentation. Like I said, venous thromboembolic disease can be a presentation. Musculoskeletal disease is across the three vasculitis, but with GPA, kidney involvement and skin involvement in addition to musculoskeletal. 100% definite kidney involvement with microscopic polyangiitis, and in addition to pulmonary, GI and cardiac manifestations in eGPA. I know this is going to be difficult to remember, but I'm just sort of setting that ball rolling. You can go up and read this up. What about radiology? Any manifestation in the CT could be a manifestation of vasculitis, whether it is ground glass opacities, it could be alveolar hemorrhages, it could be nodules, it could be effusion. So any particular pattern does not help you confirm the diagnosis of vasculitis. But if you want to differentiate the three, with GPA, you should have nodules or cavitating consolidations or masses. With eGPA, that is eosinophilic granulomatosis with polyangiitis, pleural effusion is a giveaway. So if you have effusions coming up, think of eGPA. And with MPA, when you think of it, it's alveolar hemorrhage. So these are three different manifestations which will help you differentiate it on the radiology. A busy slide, no need to focus. Other vasculitis are not commonly seen in the lung, apart from Behçet syndrome, where pulmonary aneurysms can come up in the lung. But large and medium vessel vasculitis are usually not seen in the lung. Do we need biopsies to confirm diagnosis once you have CT? Well, most of the times you do need them because some vasculitis could be ANCA negative and you need to rule out infections and malignancies also. So it would be easier to biopsy the skin or maybe the sinuses, but usually you will not pick up the diagnosis for them, and hence a renal biopsy or a lung biopsy is preferable. But transbronchial biopsies will not pick up vasculitis. Still, a bronchoscopy is helpful. It helps in ruling out infections, it helps in identification of DAH, and it also helps us in picking up endobronchial complications like stenosis. So bronchoscopy, but not for biopsy. It is basically to rule out alternative causes. Now, involvement of vessels is obviously going to be the central core histopathological lesions in the form of necrotizing vasculitis, capillaritis, and so on and so forth. But what is extremely important is involvement of parenchyma in any form, organizing pneumonia, diffuse alveolar hemorrhage, pleural involvement is not uncommon with vasculitis because eventually the vasculitis causes tissue necrosis. And this necrosis can be in form of granulomatous inflammation, organization, NSIP, so on and so forth. Always remember there is a huge list of differential diagnoses which you need to rule out before you go on to a confirmation of diagnosis. It could be infectious causes, non-infectious causes, so on and so forth. Now to confirm diagnosis. So now you strongly suspect a vasculitis, you have ruled out alternative causes, and then you confirm which is the type of vasculitis you are dealing with. Is it GPA, is it MPA, or is it EGPA? And the American College of Rheumatology very recently, March 2022, came out with these guidelines about criteria to help you confirm each and every kind of vasculitis. The sensitivity of these criteria for GPA is extremely high, and so is the specificity. What I want you to focus is, in a patient who has a positive MPO or a blood eosinophil count which is high, that rules out Wegener's. So negative marking is also important. For microscopic cholangitis, if you have an anti-PR3 antibody or nasal involvement or high blood eosinophil counts, it is less likely to be MPO. And for EGPA, again, anti-PR3 antibody or renal involvement would again make it less likely. So positive criteria have a role, but negative criteria also play a role. And hence, even if you are ANCA negative, these guidelines clearly tell you how to identify vasculitis, even if you are dealing with a 20% chance of an ANCA negative, ANCA associated vasculitis. Anyway, the rheumatologist came back for our case and he confirmed the diagnosis of EGPA. Now, EGPA, obviously, all of you know, is background of asthma followed by the eosinophilic phase and the vasculitis phase. So what I have told you, I'm just going to summarize in this slide. First and foremost, look at the CT. If you suspect a vasculitis, whether it is pulmonary artery aneurysms, which is very rare, Behçet's is the disease. If it is large vessel, which is again rare, Takayashu and giant cell. But if it is nodules, masses, or diffuse alveolar hemorrhage, look for an ANCA. If your ANCA is positive for C ANCA, suspect GPA or confirm GPA. If it is P ANCA, it could be either EGPA or MPA. If your ANCA is negative and there are pulmonary symptoms, it could be Good's pastures. If there are no pulmonary symptoms, then again it could be a huge list of IgA or cryoglobulinic or skin vasculitis. So anyway, we started this patient on steroids. What about immunosuppression? Now these are the guidelines, again came up in 2021 from American College of Rheumatology. It clearly, I would like you to read them because it's an extensive, wholesome document. It specifies what you mean by active disease, severe disease, and non-severe, just to focus. Severe diseases, organ-threatening, non-severe diseases, non-organ or life-threatening. They have specific drugs for induction and maintenance. Induction drugs are usually strong drugs, usually rituximab and cyclophosphamide, in addition to glucocorticoids. Maintenance drugs are milder drugs, usually methotrexate, azathioprine, and mycophenolate. For GPA, severe form, rituximab is better than cyclophosphamide, and for maintenance, methotrexate is better than azathioprine, which is better than MMF, which is better than leflutamide. Again, I'm giving you a very short form of this, but this is what the entire slide means. If it is non-organ threatening or non-life threatening GPA, then you need not give rituximab or cyclophosphamide. Methotrexate with glucocorticoids becomes the drug of choice. What about EGPA? For severe disease, whether it is GPA, MPA, or EGPA, cyclophosphamide and rituximab stand the same. But for maintenance therapy, there is a little difference with EGPA. I'll come back to that in a little time. There, usually we have an anti-IL-5 like mepolizumab, which has come up in a huge way, and I'll show you a slide in the next few moments. Anyway, we started him on cyclophosphamide in addition to methylprednisolone. Few months down the line, he develops peripheral neuropathy on cyclophosphamide and steroid, left peripheral nerve palsy, and this was a relapse which was occurring on treatment. So how do you address relapses? You can change the drug. So if you give rituximab, you can switch to cyclophosphamide. If you give cyclophosphamide, you can switch to rituximab. But rituximab, you can again repeat if the duration since the initial bolus or induction has elapsed to quite a while. So this patient was initially treated with cyclophosphamide. So we went with rituximab. This patient stabilized. Over the next 5 years, we gave him maintenance rituximab 1 per year. His exacerbations came down. There were no extrapulmonary events. His lung functions improved remarkably. From 30% FEV1, he came up to 40% FEV1. Remember, this is a 20-year-old disease. And his echo also normalized, clearly showing that these drugs work. But he started having side effects with steroids, a lot of osteoporosis. Is there any way which we can avoid steroids? Yes, if we can predict which patient is going to do well, we can. So there are scoring systems there. The BVAS, the Birmingham Vasculitis Activity Score, is a cumbersome, I'll just take 1 more minute, is a cumbersome index, but we commonly look at the 5-factor score. Again, you can read about it. A smaller score, easy to implement. A 0 5-factor score, good prognosis. A greater than 1 5-factor score, bad prognosis. So you can decide if it is 0, you can go with steroids. If it is greater than 1, you can go with immunosuppression. If it is greater than 2, in addition to steroids, you can give stronger immunosuppression like rituximab and cyclophosphamide. So our patient by this time was at 0. He was having side effects with steroids. So we tried out an anti-IL-5 therapy, which is now introduced in the management of EGPA. It doesn't work with any of the other vasculitis. There are studies which have shown mepolizumab works, and there are studies which have shown benralizumab would also work in this kind of a scenario. So eventually given benralizumab, it's been almost 1 year, continues to do well. Steroids have been tapered, no exacerbations. Maintenance therapy is usually minimum of 18 months, but it depends on previous relapse history, extent of organ involvement, and disease characteristics. If it is PR3, it will relapse, so you might need longer maintenance therapy. Whenever it relapses, always rule out infection, thromboembolism, drug toxicity, and other disease states related to vasculitis, and only then you stamp it as active relapse. So this is my final slide. Whenever you see a patient of vasculitis, the first thing you do is divide it into organ threatening and non-organ threatening. If it is organ threatening, go with strong drugs, rituximab and cyclophosphamide in addition to high-dose steroids. If it doesn't work, then you have alternatives like IVIG, plasma exchange, or a combination of drugs. If it does go into remission, go with milder drugs. Azathioprine is preferable over methotrexate, is preferable over MMF, is preferable over leflunomide. If it is ILD, treat it just like an ILD. If it is fibrotic, you need antifibrotic. If it is an overlap, you give immunomodulatory therapy with an antifibrotic. So that is how we manage vasculitis today. I hope you get some clarity on this, and I thank you for a patient listening.
Thank you, sir. Questions we'll take afterwards, after the lunch.
I thank the speakers for sharing the clinical experience with us. Now, may I request the chairpersons to kindly offer the mementos to the speakers, Dr. V. Pattabhiraman sir and Dr. Harjit Dumra sir. May I request Dr. Shamil Sarkar, sir, to kindly offer the mementos to our chairpersons. So we move on to our next session. The chairpersons for the next session would be Dr. Bharat Toshniwal, Dr. Balakrishna sir, Dr. Ambarnath, and Dr. Nitin Kumar. I request them to kindly come over to the dais. And the speaker for this session would be ILD Year in Review, Dr. Amita Nene, ma'am. Over to you, ma'am.
Hello. Good afternoon, everyone. So, I would like to introduce someone who doesn't need any introduction. Dr. Amita Nene, ma'am. She's the head of Department of Pulmonary Medicine, Bombay Hospital, Mumbai. And she's the program in charge and director and teacher in DNB. She has many publications to her name, and I was unfortunate that I could not attend the best of chess, so I am lucky. Over to you, ma'am.
Thank you very much, Dr. Bharat, for the wonderful introduction. Thank you, Dr. Vishwesh, for organizing this wonderful ILD day today. I'm having an incredible, brilliant academic feast. So I'm going to be talking today about ILD Year in Review. I spoke to Dr. Vishwesh, and we basically felt that ever since COVID started, probably we've not really had the time to read many, many papers. And therefore, I decided, with his permission, that I'll go through papers from Jan 2020 till October 2022. So I decided to identify 4 areas which I want to talk about. So there were 8,500 papers, of which I thought 324 papers were relevant. I shortlisted 22 papers which are relevant to the areas that I've decided to discuss today. And out of these 22 papers, I'll be discussing some in detail and some I'll be just mentioning. So in these 20 minutes, we will quickly discuss a few new terms in ILD, some updated ILD guidelines, some interesting new studies which actually change our practice, and exciting future innovations in ILD. So first thing I want to talk about is a very important term, interstitial lung abnormalities, also known as ILA. So an excellent paper came out in October 2021 in European Clinical Respiratory Journal. And in 2020, we actually got the white paper, the position paper from the Fleschner Society on ILA. And I'm going to be talking about both these papers. I'll be mixing them and telling you everything that's important about ILAs. So ILA is something which is even more important than ILD. So the term interstitial lung abnormality refers to the presence of CT findings which are compatible with ILD, but without any suspicion of ILD. So the patient may be asked to do a CT scan, maybe he's a smoker, we want to rule out CA lung, and therefore the CT scan is done for that, and we find certain abnormalities on the CT scan which resemble an interstitial lung disease. So when you find ILD without suspecting ILD on the scan, it is known as interstitial lung abnormalities. So when we see these ILAs, it's very, very important to find out if the patients have symptoms or not. So you ask the patient, do you have dry cough? Do you have breathlessness? Examine, do they have fine Velcro crepitations? So if none of these symptoms are there, then this becomes subclinical ILD. Patient doesn't have symptoms and instantly you picked up an ILD which was present. However, the patient, if at all, has symptoms, then based on the symptoms, this becomes a mild or a moderate ILD, which was incidentally picked up. Now, ILAs are very, very important because they are often associated with respiratory symptoms. They have functional impairment. There's risk of progression, and increased all-cause mortality in ILA are very high, and therefore ILAs become extremely relevant in today's day and age. So ILAs are increasingly being recognized as a common feature in the CT scan of elderly people and people who are smokers. If you do a CT scan, any person who is a smoker and more than 60 years of age, then 4 to 9% of people get ILAs. And if it's a non-smoker, we are getting 2 to 7% ILAs in non-smokers. And identification of interstitial lung abnormalities will increase once we implement the screening for CA lung. And we're also doing now, after COVID, we are doing CT scans so often. So we are going to keep on picking up ILAs more and more, which is going to be very useful for the patient. And these abnormalities are associated with radiological progression, with increased mortality, and the risk of complications from medical interventions such as chemotherapy and surgery if the patient also has CA lung. So it's very, very important. And whenever you see ILAs, you find out if this is subclinical ILD or it is actual clinical ILD, and then you decide how to treat this patient. So what imaging findings are consistent with ILAs? So incidental identification of non-dependent abnormalities, which could be ground glass, it could be septal thickening, it could be lung distortion, traction bronchiectasis, honeycombing, non-emphysematous cysts. If any of this is present, but they should be involving more than 5% of one particular lung zone. It could be upper, mid, or lower zone, right, left, anything, but more than 5% has to be involved for you to call it ILA. So ILAs have been subcategorized into 3 categories. This is important. So the first one we are seeing in figure A, if you can see over here, there's ground glass, it's circled over here, and these are central. They are not peripheral or they are not subpleural. So this is the first one, which is non-subpleural, non-fibrotic. Usually these are very, very slowly progressing, and you have to follow up patients for years together before they start getting symptoms. So this is the best of the lot. The second one is figure B, which is subpleural. You can see it's subpleural, but it's ground glass. This is non-fibrotic. So subpleural, non-fibrotic they are likely to progress, but not very, very fast. So anything that is subpleural is not great, but if it's subpleural non-fibrotic, then it's slightly better than the third category, which is subpleural fibrotic. So as you can see the figure C, over here in the lingula, we've got actually honeycombing cysts, or we have reticulations, traction bronchiectasis. So this becomes subpleural fibrotic, and these people actually have probably, they are presenting as probable UIP or a UIP pattern, and they have a very, very high chance of progressing that too fast. So these people are somebody who you want to really look out for. So progression of ILAs actually takes place. So the rate of progression is usually 20% over 2 years and 48% over 5 years. So ILAs actually progress. And as you keep on following them over a period of time, you come to know what is really going on. And very often people could be having ground glass to begin with, but over 5 to 7 years, they will actually develop traction bronchiectasis, honeycombing, everything. So just seeing ground glass and ignoring it is not okay. So this is a patient over here. You can see there is subpleural ground glass in the left lower lobe. This patient was followed up, and 7 years later, now he's got subpleural septal thickening, and he's got honeycombing, he's got traction bronchiectasis, and new opacities have now come up in the right lower lobe. So the thing is that even if it's ground glass, it is bound to increase, and therefore ILAs become very, very important. There are certain risk factors for progression of ILAs. So clinical risk factors are smokers, any other inhalational exposures like vapor, dust, inhalation of other gases, then medications, so whether it's chemotherapy, especially immune checkpoint inhibitors, which are commonly used for CA lung. If they are given radiation, if they undergo surgery for CA lung or any other thoracic surgery, these people have a high chance. And radiologically, the ILAs which are basal, means involving the lower lobes more, and those which are peripheral or subpleural have a high chance of progression. So is it really important to diagnose ILA? Because I'm talking 5 minutes of my talk only about ILAs. So it is actually very, very important because clinical outcomes of ILA are not really good. They have increased risk of death from a respiratory cause, especially pulmonary fibrosis. These patients have increased chance of CA lung and higher mortality because of CA lung. They have a high chance of getting ILD, high chance of getting COPD. And if at all they get any illness, they have a very high chance of getting ARDS also. Also, if they undergo any thoracic surgery, then there's a high chance of they getting ARDS, pneumonia, respiratory failure. If at all they take radiation for CA lung, they get radiation pneumonitis. They get more drug-induced ILD because they have ILAs which are present. What we need to remember is that rheumatoid arthritis is a very important CTD, which is known to be associated with ILA. And if rheumatoid arthritis patients have ILAs, then there's a very, very high chance of they progressing faster and they having a worse PFT and more symptoms. So which patients should be screened for ILAs? So wherever there is family history of ILD, IPF, always please screen them even if they are asymptomatic. Certain connective tissue diseases, especially because Sonia had asked us. So rheumatoid arthritis patients, if it's a male, elderly person, cigarette smoker, if RA test is positive, anti-CCP is positive, or if MUC5B genotype is positive, we have to do an HRCT test. If the patient has systemic sclerosis, even if there are no symptoms, but if anti-SL70 antibody is positive, we have to do an HRCT test to rule out ILA. If the patient has polymyositis, dermatomyositis, if antisynthetase, anti-PMCA, SCL, and anti-MDA5 antibodies, any of these are positive, we have to do an HRCT test even if the patient has no symptoms. If there's occupational exposure to asbestos or any metal, wood dust, any kind of gases, we have to do HRCT test. So basically, whenever we get an ILA, we are going to find out if the patient has symptoms or not. So the patient doesn't have symptoms, ILD, in which case we are going to see what the PFT is looking like, and we're going to see what is the extent of the CT scan, and we are going to see what are the risk factors of progression. So the patient is a smoker, he's got occupational exposure. If the patient has any connective tissue disease, then you want to really follow up this patient very, very well, in which you may want to do PFT, 6-minute walk test every 3 months, or you may want to do a CT scan every 1 year, or earlier if there is any clinical worsening. And the minute you find clinical worsening, you want to put them on treatment. And if at all the patient has symptoms, he becomes a proper ILD, and then you treat the patient for ILD. There are certain risk factors which predispose you to getting ILAs. One is advanced age, second is male sex, third is tobacco smoke exposure, fourth is occupational environmental exposure to anybody, anything, and most important is carriage of MUC5B mutant T allele. So this is very, very important, the MUC5B mutant T allele. And so basically, I'm sure all of you all know that MUC5B has become so very hot for last 3 years, last few years, whether it's AJR, CCM, whether it's Annals of American Thoracic Society, whether it's Lancet, whether it's ERJ. Everybody keeps on talking about MUC5B in the pathogenesis of IPF, IPF and MUC5B. MUC5B has really become synonymous with IPF. So basically, the funda is that Caucasians and Asians, they have a very high chance of getting MUC5B, single nucleotide polymorphism. And if this is present, then they have a 4-fold higher chance of getting sporadic IPF. So the thing is, we know that Caucasians have a chance of getting this, Asians have a chance of getting this, but in Asians, we know data about Japan, China, Korea, but data about India is not known at all. So we really don't know if we have this, and if we have a chance of getting IPF because of this single nucleotide polymorphism. And this was a fantastic paper, a wonderful study done by our PGI friends. And this has come in October 2022 Chest Journal. We could not have been more updated. So a very, very good paper. And the aim of the study was to see what is the prevalence of this single nucleotide polymorphism of MUC5B in normal Indian people who don't have IPF and Indians who have IPF, and to see what is the connection of survival if this polymorphism is present. And basically, there were 106 patients of IPF which were chosen, and 161 control subjects were seen. And this minor polymorphism was seen in 12% of control who did not have IPF, and 34% of patients who had IPF. So in India, even if we don't have IPF, this polymorphism is seen. But if you have IPF, this polymorphism is seen much more. So if we compare our results to Caucasians, it's very, very similar. In Caucasians, 11% of normal people get it. We were 12% of normal. And in Caucasians, 32% of IPF get it. In ours, it was 34% of IPF. Asians, our results were much, much higher. So in Asians, 0.74% of normal get it. In our population, is 12%. And in Asians, 2.1% of IPF patients get it. In our population, it was 34%. So this becomes very, very important, because if you look at this graph, so this is the graph, this is the lifespan, survival in patients who have this polymorphism. So this is very, very good, because in India we have this polymorphism which is quite prevalent, and this polymorphism actually improves our survival in IPF. So whenever we have patients of IPF or sporadic cases, I think it would be very, very important if we look for MUC5B polymorphism, and if it is present, then we know that this patient has a better survival from IPF as compared to other people. And therefore, this is, I think, a very important paper which tells us about IPF and the prognosis. So what else is new in IPF? So for this, I would like to talk about the update in the ATS guidelines on in IPF, and these were published in February 2022. So something that will make Dr. Patabi very happy, that a conditional recommendation was made in this update, and transbronchial lung cryobiopsy has been accepted alternative to surgical lung biopsy for diagnosis of IPF in centers with appropriate expertise. So as Dr. Patabi was telling us that surgical biopsy has so much of complication, and now cryobiopsy is absolutely accepted finally, which we are very, very happy about. So if you're suspecting IPF and you need to do a biopsy, and if your center has the facility and expertise, then you could do a transbronchial lung cryobiopsy. Always use a balloon to prevent chance of hemorrhage. Also, conditional recommendation was made against antacid medication and anti-reflux surgery for the treatment of IPF. I think this is a huge thing, because ever since I was a resident, we were always writing PPIs for people, even if they had just no symptoms. But now it has finally been found that you don't really need to do it. A new term, progressive pulmonary fibrosis, was introduced. So what is progressive pulmonary fibrosis? So in a patient with ILD of known or unknown etiology, which is not IPF. So patient has ILD, you may know what the cause is or you may not know what the cause is, but it definitely is not IPF. But radiologically on CT scan, you have to have fibrosis. So PPF is defined in this patient if at least 2 of the following 3 criteria are met within past 1 year. So one is worsening of symptoms. The cough, breathlessness could be getting worse. The second is radiological progression. And the third is physiological progression. So out of these 3, 2 have to come positive. So physiological evidence of disease progression has to satisfy one of these 2. Absolute decline in FVC more than 5% or equal to 5% predicted within 1 year of follow-up. So as Dr. Kandi told us some time back, the 10% has come down to 5% for FVC. And you can have this, or you can have absolute decline in DLCO, which is corrected for hemoglobin important, of more than 10% predicted within 1 year follow-up. So one of the 2 things happens, then we call it physiological worsening, or you have to have radiological worsening, which could be new groundlets with traction bronchiectasis, worsening of traction bronchiectasis, worsening of reticulations, new honeycombing, new traction bronchiectasis. So you have worsening of symptoms, physiological, radiological worsening. Out of these 3, if any 2 happen in last 1 year, then you're going to call it progressive pulmonary fibrosis. So what I want to basically tell you all is that actually we had progressive fibrosing ILDs. So this term has been replaced with progressive pulmonary fibrosis because we feel that this term is more appropriate, because when we say progressive fibrosing ILD, that means the problem is only in the interstitium, but we have found that as the disease advances, in addition to interstitium, it also affects the airway and the alveoli. Also, the second cause is that people know IPF is bad. So if something like PPF, it sounds like IPF, then patients will take it a little more seriously. And therefore, I also feel that this term PPF is probably better. Now, for treatment of PPF, you treat it with steroids, with anti-inflammatories, etc. But for antifibrotics, a conditional recommendation was made for nintedanib, but pirfenidone was not allowed for treatment of PPF. And they have said that additional research into efficacy, effectiveness, and safety of pirfenidone is still required. So now I want to talk about this trial, which is a relief trial, which was published in Lancet in March 2021. So fantastically planned trial. So this was about the role of pirfenidone in different types of fibrosing ILDs. So the thing is, there were 127 patients who had PPF other than IPF. 64 received pirfenidone and 63 received placebo. And basically they were recruiting people, and they took more than 2 years to recruit 127 people. And therefore it was decided that the trial had to be prematurely terminated because the recruitment was very slow, and this would have actually affected the final results. And therefore the relief study was almost given up. But the thing is, when you go through the results of these 127 people, at the end of 48 weeks, the people who received pirfenidone, there was remarkable reduction in the worsening of FVC as compared to the placebo. This wasn't statistically significant because the number of people was different. But what I want to say is that pirfenidone is probably definitely going to work. Unfortunately, the trial was terminated prematurely. So although the guidelines are not saying that for PPF you can use pirfenidone, but I think if the patient can't tolerate nintedanib, then pirfenidone definitely could be used. Any more new ILD guidelines? Okay, so in August 2020, we got hypersensitive pneumonitis guidelines, which came up, the update came after 18 years. what was new, what I really liked about was that historically we are describing HP as acute, subacute, and chronic. But this is of no use at all because it depends on what is the amount of exposure. It doesn't really tell you how the patient is going to do. So now we have understood that if the patient has fibrosis with HP, this patient will do badly. If there's no fibrosis, the patient will not do badly. And based on this, the new classification is now described HP as to be having fibrotic HP and non-fibrotic HP. So acute, subacute, and chronic HP is given up. So when you see HP, it's either fibrotic HP or it's non-fibrotic HP, and basically either HRCT chest, so radiology, or biopsy, histopathology will decide whether it's fibrotic or non-fibrotic. So if it's non-fibrotic HP, it has to be purely inflammatory. And if it's mixed inflammatory and fibrotic, or it's only fibrotic, then you'll call it fibrotic HP. So this is very, very important because you are going to classify this based on the fibrosis, which is going to decide the outcome of the patient, and therefore this is more objective, and this is going to decide the clinical cause and the outcome of the patient. So I think this is a very, very useful paper. So just let's look at this. So over here, this patient has ground glass, there's air trapping, there's mosaic pattern. So this becomes non-fibrotic HP. Over here, we have centrilobular nodules, we have ground glass and air trapping. Again, there's no fibrosis, there's no reticulation, there's no traction bronchiectasis. This again becomes non-fibrotic HP. Over here, we have the classical head cheese sign, the triple density sign, no fibrosis at all. So this again becomes non-fibrotic HP. Now this patient has mosaic pattern, air trapping, ground glass, but we are seeing honeycombing and we are seeing some traction bronchiectasis. So this becomes fibrotic HP. This patient has, over here we can see honeycombing, we can see traction bronchiectasis, all involving the upper lobe. This again becomes fibrotic HP. So what we want to say is that whenever we see CT scans, we're not going to call it acute, subacute, or chronic. We're going to call it fibrotic or not fibrotic. And this is how we'll decide the treatment also. So we all know about antifibrotics in fibrotic HP. We had the inbuilt trial which came out in 2020 in Lancet. And basically it was shown that people with progressive fibrosing ILDs who received nintedanib 150 BD at the end of 52 weeks, their decline in FVC was statistically reduced as compared to those who did not, and therefore nintedanib can be used for fibrotic HP. I would like to talk about this paper because this was in a small journal, Egyptian Journal of Bronchology. So this paper was not entertained by the ATS guidelines, but I think it was a very good study, small study, 20 patients of chronic HP given pirfenidone, 20 patients given other treatment but pirfenidone, and statistically reduced FVC decline was seen in the pirfenidone group. So small study, but it tells us that pirfenidone works in chronic fibrotic HP, and a very, very good trial is going on, which is known as the Pichion trial, where proven fibrotic HPs are enrolled in a double-blinded trial where pirfenidone versus placebo is being given. The results will be out in 2 years, and this will be the verdict. Sarcoidosis, after 12 years, we've got new guidelines in May 2021. So basically, the guidelines, the important part is that if people require steroids for pulmonary sarcoidosis, and with steroids, if they are not doing well, or if they have too many side effects, then the first drug you want to replace steroids with or add on to steroids is methotrexate. We need to remember this because in our country, we are not really doing it too much. So methotrexate, which is the first alternative to steroids. And after adding methotrexate, if the patient still doesn't do well, then addition of infliximab. So these are two different recommendations which are new for treatment of sarcoid. However, the authors themselves said that though there was not too much of proof, they said that they can't put them in guideline, but they actually gave this table and they said for some reason if you can't give methotrexate, then azathioprine, leflunomide, mycophenolate or hydroxychloroquine, one of these four also could be given. And also if people don't do well with methotrexate or infliximab, rituximab, JAK2 and JAK inhibitors are also recommended. So this is about sarcoidosis. And now last 2 minutes I'm going to take about something which is really fascinating. So in 2018, a superb study came on salbutamol, inhaled salbutamol, which was used for patients of IPF. So we basically know based on the size of the drug, we know where the medicine will go. So if the size is between 2 to 10 microns, it's going to go into bronchi, bronchioles. And the size is in 2 microns, it will go into alveoli. So the thing is, this is what the deposition was. So patients of IPF were given nebulized salbutamol of different sizes. And you can see if the size was 6 microns, it went in the central airway. If the size was 1.5 microns, it went also in the periphery. And if we give nebulized salbutamol, it has maximum deposition everywhere in the lungs. So also what is really fascinating is worse are the lungs, better is the delivery. So for IPF patients, nebulized drugs would be very good because their lungs are really, really fired. So based on this, a superb paper came out in 2020 February where they had a randomized double-blinded placebo-controlled study where inhaled pirfenidone was given. So basically patients of IPF, half patients got nebulized pirfenidone 100 milligrams and the other half just got placebo. And what was really fascinating was that nebulized 100 milligram pirfenidone, it had hardly any systemic absorption, but the alveolar level of the drug were much more than the levels reached by 800 milligrams of one tablet of pirfenidone. So this was fascinating. 100 milligram of nebulized pirfenidone equals to a tablet of 800 milligrams of pirfenidone. So this is very, very good. And after this, basically a new trial was taken up in Australia involving 91 papers, and this was actually presented at 2021 in the ISAM conference. And again, a fantastic study with wonderful results. 91 participants in Australia. So 46 patients got 50 milligrams once a day of pirfenidone nebulized, and 45 patients got 100 milligram twice a day. And they basically looked at the FEC. And basically people who got 100 milligram of nebulized pirfenidone twice a day, they did not see any drop in FEC at the end of 24 weeks. Whereas people who got 50 milligram once a day, there was significant drop in FEC. So the thing is that if you give patients 100 milligrams of nebulized pirfenidone for 6 months, there is absolutely zero drop in FEC, which is fantastic. So this trial was ongoing, and then at the end of 24 weeks, the committee actually said that not to continue with the 50 milligram arm, and the continued 52-week study is going on with all the arms getting 100 milligram pirfenidone nebulized twice a day. So this is really very, very good because this is very safe, it's very well tolerated. The adverse side effects are very few. People get rash, they get some nausea, vomiting, some people get flu-like symptoms. So also we know that oral pirfenidone really works in fibrosing ILDs, but it's very, very difficult to tolerate. In 2400 dose, sometimes patients are not really tolerating. So if you can give 100 milligram 3 times a day by nebulization, the alveolar levels are much, much better than what pirfenidone orally is getting. There are hardly any side effects. So I think this can really be a game changer for patients of IPF and also for patients with other fibrosing ILDs. So this is something which I think is very, very promising. This really, my heart melted, and I felt so nice when I read this paper. So with this, I would just like to come to an end. I think I've spoken too much, too fast, 24 papers in 18 minutes. So I just want to consolidate everything in the form of take-home messages. So ILA, interstitial lung abnormalities, need to be identified. Please look for them even if you're not suspecting. And if patient has them, please work them up because these patients have a high chance of mortality and morbidity. ILAs are subcategorized as non-subpleural non-fibrotic, subpleural non-fibrotic, and subpleural fibrotic. Specifically, subpleural fibrotic variety is high chance of progression. Please look for them. High chance of they progressing to UIP. You must screen for high-risk patients that we spoke about. MUC5B single nucleotide polymorphism is very, very relevant in Indian population. The prevalence of this polymorphism in India is as much as Caucasians. And the best thing is it has a survival benefit. So when people have sporadic IPF, please look for this gene and you are looking at a better survival. In 2022 guidelines on IPF, they have said that transbronchial cryobiopsy could be done in place of surgical lung biopsy to confirm IPF diagnosis. No, they have said not to do anti-reflux surgery, not to also give anti-acid medications. Progressive pulmonary fibrosis has now replaced the term for progressive fibrosing ILDs. HP is now fibrotic and non-fibrotic HP, which is very, very important. Sarcoidosis, if steroids are not working or too many side effects, then please use methotrexate first, followed by infliximab. If that also doesn't work, then rituximab. Newer modality of drug delivery in IPF are in the horizon and can be the game changer. And results of inhaled pirfenidone are highly promising and suggests that inhaled formulation of pirfenidone may prove efficient than oral pirfenidone and is safe and well tolerated. Thank you.
Thank you, madam, for the nice presentation. And we can take the questions in the lunchtime. Thank you. Next speaker is Dr. Rajam K. Nair. Palliative care in ILD, a neglected domain. Madam is MD DNB MRCP, Diploma Palliative Care Medicine, Cardiff University. Present position in Pulmonology and Palliative Care Consultant, Bhatia and Hinduja Hospitals. Madam got Har Gobind Award. Please, ma'am.
So thank you very much. I know I'm a fairly new face in the group of pulmonology, though I've been a pulmonologist since 1995. I really appreciate this audience for sitting in here from 9 a.m. It is not easy on a Sunday post Diwali when you've had so many celebrations. So I'm trying to, with a show of hands quickly, can you tell me if Vishweshwaran did the right thing by having this talk here today? Because I think I'm going to shift the gears. Everybody has been talking about how to diagnose ILD better, how to make it, what are the earlier ways of diagnosing, improvements in imaging, how do we make our patients survive acute exacerbations. So I'm going to be shifting the gear, and I'm not sure how many people are really going to like it, but I really want the young people in this audience to kind of be more sensitized to what I am trying to say. So it's, totally looking at it from an angle of the patients. So if you think, you've been talking of survival of this horrifying disease, which is interstitial lung disease. And of course, we have this category of IPF, which is really can be compared to certain kinds of cancers. So if you think of how our patients of interstitial lung disease are dying, it could be one of the trajectories is the graph C. These patients do lead a prolonged period of high symptom burden. And what is the most harrowing part is that these people do not perceive interstitial lung disease as a life-limiting disease. And partly we are responsible for that when we break the news and the diagnosis to the patient. It is, you all will accept that it is an incurable disease, it is a progressive disease, and these patients, we see them only when they come into the hospital with the acute exacerbation, which is the dip that you see when they get hospitalized. When these patients go home, progressively their quality of life is much worse. We do not even budget how these patients lead their life. Do they eat on their own? Are they self-caring? Are they walking to the toilet? And what is their mood? We see them only when they come in an acute exacerbation to the hospital and to the ICU. Therefore, we need to realize, what are we dealing here as doctors? Are we even budgeting suffering? Is the suffering that we see in our patients only physical, or it's emotional, psychological, social, financial, as well as spiritual? We as doctors need to know when to wear the palliative care hat. I know this room is full of busy pulmonologists wanting to do state-of-art intervention, wanting to try the newest drug, wanting their patients to live long. But are our patients living well? Is the question we really need to ask. And we really need to focus on this graph of organ failure, because our patients are slowly and badly marching towards death. So when you diagnose a patient to have a chronic illness like interstitial lung disease, it is like falling off the skyscraper. And the manner in which you land depends on the way you fall. So very typically, we see patients being referred to palliative care when they're already in the ICU or when they're already on 24/7 oxygen. It is probably too late for us to enter the scene because this patient has not got the time to process and analyze what he's in for. So if this fall of this patient, which you and me know, we have seen more patients of interstitial lung disease than the patient and the caregivers. So it is our responsibility to foresee and foretell what his disease trajectory is going to be. And that is going to be possible only if we punctuate the patient's fall with unhurried, sensitive, timely conversations so that the patient is prepared, has the time to process what's going to happen to him, along with the caregivers, so that we avoid futile, unnecessary, life-sustaining treatments. It's very important, therefore, to include palliative care in respiratory medicine, because all of you will realize that our patients slowly die a social death even before a physical one. The psychosocial aspects of looking after a patient of COPD for 10 to 15 years or interstitial lung disease for 5 to 7 years affects the full family, not just the patient, the caregivers, and also, since in India, 80% of our patients do private medical practice. A lot of patients suffer financially. And one of the studies actually say that 55 million Indians go below poverty line trying to keep their loved one alive in the last 2 weeks of life. So are we justified in doing life prolonging treatments in a condition, in a background of progressive, advanced chronic respiratory disease? So the impact is huge. It's not just on the patient, on the caregiver, but on the society and the way the health-seeking behavior and the utilization of health resources in a country which is already resource-crunched. So we need to think holistically, not just for the patient, but also for the caregivers and for all of you. How frustrating it is to see a patient of interstitial lung disease faring badly on a ventilator. Every night you get this horrifying feeling that this patient is going to die. Am I doing the right thing? So there is this needs of interstitial lung disease that you need to understand before you realize the integration of palliative care into respiratory medicine. And it's not just physical. It is also got to do with his emotional needs, with his financial needs, how he's going to be treated at the end of life. And for past few years, we've seen a lot of young patients with interstitial lung disease. Therefore, their lifestyle, their choice of, even getting married, sexuality, so many other aspects of interstitial lung disease are not taught to us in the textbooks when we finish our MD and DNB. So we need to realize that these patients lead a suboptimal life. It's a life-limiting disease, and we need to tell our patients. And because their needs are way more beyond their physical needs, we also need to give them a holistic care and not just dishing out prescription of pirfenidone, nintedanib, or any other immunomodulant along with oxygen or NIV. Their needs are way more than that. Because our patients are stuck in this vicious cycle, which is beautifully described in this model, which is the breathing, thinking, functioning model. Because of his interstitial lung disease, he is breathless. And because he is breathless, the only thing that is overactive is his mind. So he's anxious, he's scared, he's frustrated, there's a loss of role, he's bedbound and is housebound. Both these lead him to walk less and less and become more and more deconditioned. Hence, this feeds into the cycle of being constantly breathless, constantly scared, and constantly, in a position where he's not able to lead a decent quality of life. This vicious cycle is actually the whole ethos of palliative care, where the pulmonologists focus on the pathophysiology and give treatments to delay and slow down the fibrosis. The psychologists deal with the mental anxiety. If you can imagine a patient being constantly breathless and sitting in one place in his house. The physiotherapists deal with the functioning of the patient and improve the conditioning of the patient. Therefore, a multidisciplinary team, which I've been hearing since morning, somehow, unfortunately, none of the talks included me. So I'm trying to push myself and throw my weight in, which I have plenty. So I really think the multidisciplinary team treating ILDs must include a palliative care physician. Now, it need not be a pulmonologist. It can be just an MBBS doctor trained in palliative medicine, along with psychologists, volunteers, social workers, physiotherapists, and patients' caregivers, because they are the ones with abundant knowledge of how to look after a patient with interstitial lung disease. And this brings me to what all our patients of interstitial lung disease suffer from, which is defined as chronic breathlessness syndrome, which is most under-recognized and therefore under-treated. It is a symptom where patients are constantly breathless despite being on maximum treatment for their underlying respiratory cardiac disease. And when their breathlessness starts affecting their psychosocial, emotional, and social factors of their day-to-day life, that is what is called chronic breathlessness syndrome. So most of our patients, if you go back and ask them and see what and how their life has changed because of breathlessness, those are the patients who are affected by chronic breathlessness. Even in COPD, you've given them the maximum dose of inhalers, you've given them LTOT, they are on pulmonary rehab, and yet when they experience breathlessness, these are the patients who whom you define as chronic breathlessness. Because if you think in MBBS and MD, when we are asked about history taking, we never go beyond, is your breathlessness better? Is your cough better? Are you sleeping? Are you eating? But there are issues way beyond that which affects our patients, which we do not ask, because that is actually tipping the Pandora's box. You ask this to the patient and you say, oh God, there goes my 20 minutes. So the busy consultant is obviously not wanting to venture into that because he cannot deal with it himself. Patients with breathlessness are scared, they are anxious, they are frustrated, they're probably angry. There are so many other things happening in their life which you and me as pulmonologists are not able to tap into. And it's extremely important to deal with it so that the patient has a better disease experience. He realizes that his doctor cares for him, not as just patient of COPD, but as a human being, Mr. or Mrs., whatever that is. And it's important to get back that compassion and get back that kindness in our profession, because you and me are going to become patients tomorrow, and we will definitely want to be dealt with as a human being and not just patient. So very often we need to change the way we ask our history. We, like I said, keep asking, is your breathlessness better? But if you swap that question to what have you stopped doing because of your breathlessness? What is it that you have given up because you're breathless? That is what is going to give us the patient's routine and the fact that the patient is depressed and frustrated because of his underlying condition, though the best pulmonologist in town is treating him with his symptoms. We really need to explore the patient's anxiety, the patient's desire, and the patient's belief, because the first pillar of medical ethics is autonomy. We need to ask him what he wants, how he wants to be treated, especially at the advanced end of life care. There are enough, the couple of slides next I'm going to show you how the physical deterioration of health in a patient with advanced chronic lung disease also is directly proportional to the deterioration of his mental health. Do we ask enough questions to our patients? Are they coping with their illness? Other things is the similarity of symptoms that lung cancer patients as well as patients with lung disease suffer, which is non-lung cancer. So everything is the same. In fact, in interstitial lung disease, breathlessness is even more overwhelming than what our patients with lung cancer suffer. Also, at end of life, it is seen very often that patients with lung cancer get more palliative care, patients with lung cancer get more treatment of their symptoms, they get less aggressive treatments, less CPR, and probability of them being intubated is less. While the patients with non-cancer, because it's not even recognized as one of the life-limiting, these discussions don't happen. We need to have these difficult dialogues with patients, because you and I know that patients who come with very bad, poor, advanced lung diseases do very poorly on the ventilator. But because we haven't had a discussion, the patient comes to casualty, goes to ICU, and it's like a conveyor belt that one thing follows the other. Are we doing right? Are we contributing to the suffering, or are we actually alleviating suffering as health care professionals? Somewhere the word care seems to have completely lost its significance. So what do we want to do as palliative care? We want to integrate palliative care into all specialities, because there is suffering across the board, whether it's MND, whether it's Alzheimer's, whether it's Parkinson's, whether it's COPD, whether it is cirrhosis, CKD. We want to integrate it so that we are not seen as another department. We want to be integrated so that the transition from curative care to palliative care is smooth. Patients and caregivers have the time to process their illness, come to a discussion with us and a conclusion of how they would want to be treated at end of life. And also, most importantly, we don't arrive 2 hours or 2 weeks before death and talk to these patients whom we have no rapport with. And the beauty of palliative care is we continue to talk to relatives even after the death of the patient, which is not possible for busy consultants, as many of you are in this room, because the patient's family has lost a loved one forever, and the bereavement can be complicated, especially if the patient has suffered for a very long time. And these are the aspects of palliative care which is so very important, especially to somebody like me who's gone through loss of a loved one, and it's immensely important to get the support of a doctor who has actually looked after your loved one. So with all this in mind, the domains of care are not just symptom related, it's the best supportive care, it's the psychologist, it's the physiotherapist. We discuss what is patient-centered care. So it's shared care. It is not that in my 30 years of experience as a pulmonologist, you should do 1, 2, 3, 4, 5. I think you should do 1, 2, 3, 4, 5. What are your thoughts? It has to be the patient's choice. We really need to focus on that because, like I said, tomorrow during end of life care in an emergency, if you know what the patient wants, it is much easier for the caregivers to decide not to intubate. Therefore, it is much easier for the physician to not intubate that patient and offer comfort care. I always feel that it is much easier for a physician to put the patient on ventilator. It takes 2 to 5 minutes, but it takes 2 to 3 hours to talk to relatives of not putting the patient on ventilator and to avoid aggressive treatment. So it does take time, and I understand that people in this room will not have the time. That is why all the more reason to train yourself in palliative care or to refer to people like me only so that you know when to wear your palliative care hat and when to avoid futile, aggressive medical treatments and offer the dignity and comfort to patients, especially at end of life, because that's the last time you're going to look after that patient and it is the last chance to help a human. And the other important thing is the quality of death. Nobody wants to talk of quality of death, the quality of life till death or quality of death. And unfortunately, India ranks amongst the 60 countries out of 80. So we are 60 out of 80 in the quality of death. Our patients are dying poorly. And worse, non-cancer patients do not even receive enough palliative care. Therefore, they end up having much more aggressive treatment at end of life. So currently, we have 2 patients in Bhatia Hospital where Sujit and I work, where one patient is clear she doesn't want to enter the ICU and wants only comfort care with the condition of interstitial lung. And there's another gentleman who's been intubated twice because the family can't just give up and cannot accept the fact that this not intubating is going to, end his life and the suffering will continue. But we really need to give patients time so that they can come to a conclusion, because these are difficult decisions. So the next important thing, I'm not going to focus a lot because I know we are running short of time, is the surprise question. Often pulmonologists feel referring to me is giving up. But if you sit in your OPD and you think this patient is not going to live the next 1 year because of your clinical acumen, his age, comorbidities, lung function, multiple admissions, that's the time to refer to palliative care so that we have enough time to process and analyze and have the difficult dialogues. So simple thing for you is an algorithm of how serious is the need of the patient, because palliative care is need-based. It is not diagnosis or prognosis-based. So if you have an IPF you know is going to go downhill quickly, then you need us. If you have something who's going to get stabilized like a CT-ILD or an HP, watch for his needs and his deterioration. Something which is more indolent course like a sarcoid, again the follow-up questions, is he coping, is he falling apart? Those are the things that you need to pick up. I know you're not going to have the time, but send them to a counselor, send them to the physiotherapist and make their disease experience better. So we do a lot of non-pharmacological before we end up in pharmacology, and simple things like a battery-operated handheld fan works wonders for patients who are in chronic breathlessness. So we all jump up to put in the oxygen, but these patients might not even be hypoxic. So relaxation techniques, breathing techniques, positioning the patient, handheld battery-operated fan, massages, music therapy, PET therapies can be tried for a patient who is chronically breathless. Please remember that all patients who are breathless are really not hypoxic. So before you stick on that oxygen, please measure the pulse oximeter. And these patients benefit wonderfully with low-dose opioids. Opioids being narcotic and used in cancer pain on higher doses. For breathlessness, we use small doses of 2.5 milligrams immediate release twice a day with laxatives and slowly titrated to 3 to 4 times a day, never more than 20 milligrams, to make the patient less breathless. It just decreases the sensation of breathlessness by working on the central nervous system. therefore decreasing the work of breathing, improving the tidal volume, and making the patient feel less breathless. So that his quality of life improves. He can eat with his family, he can go to the toilet, he can wash himself alone, and these things matter to our patients because I think we take a lot of things for granted when we are enjoying good health. This is something I don't need to talk about, but the simple thing is non-pharmacological when the patient is mildly breathless. Consider SOS opioids when the breathlessness is more, long-acting opioids when he's severely breathless, and please discuss end-of-life and advanced care planning to your patients and involve caregivers. You must involve the caregivers because they suffer as much as the patients and their life is as much as halted as that of the patient. It's extremely important to explain to them. And the intervention of palliative care, this is the famous study which Breathlessness Support Service says that patients not only live longer, yes, of course you cannot change the outcome, but you can make their journey much, much more bearable. So slide on palliative sedation, which I will skip for now, but other distressing symptoms that our patients experience, which is cough, which also we treat with both codeine as well as morphine. Very often, Sujit comes out of his room exasperated, saying this patient is constantly complaining of fatigue, insomnia, and there's something that he can't handle at all. But I think acknowledging that these symptoms are distressing solves 50% of your problems. It helps the patient, it helps the caregivers, and overall, the care experience. So in short, the ABCDE of palliative care for ILD is assess your patients for their needs and their values, educate them because we really need to give them information, foresee and foretell, support them with all the paramedical staff, comfort care when you know that none of your disease modulatory drugs are working. Please talk about end of life. We really need to start using the D word and talk to the patients how they would like to be treated because withholding care, withdrawing care is medically, legally, and ethically the same as per the judgment from the Supreme Court on 9th of March 2018. So the key take-home messages is that palliative care is not just for cancer, palliative care is not just for end of life, it is to make a difference to the patient's quality of life and not focusing on quantity of life, making the patient prepare for his eventuality, taking the caregivers along with them, and overall win-win for the pulmonologist, intensivist, patient, caregivers, and also the hospital administration because the turnover of ICU beds makes a difference for your revenue. So I think we all need to stop and think of why we have become doctors and how we can improve the experience that our patients have after suffering a chronic illness because bad death is avoidable and death is inevitable. And we really need to focus on what we want to give our patients. Thank you.
Thanks, ma'am. Thank you very much for elaborate and elusive talk on real role of palliative care in ILD patient. And definitely it is included in pulmonary rehabilitation.
Thank you.
Thank you, madam, for talking about holistic approach and the mental health, which is definitely the need of our. That was a power-packed session by two beautiful speakers. So I request the chairpersons to kindly offer the mementos to the speaker, Dr. Anita Nene ma'am and Dr. Raji Maya ma'am. Yes, much power to you. Yeah, much power to you.
Thank you.
You made us like...
According to my friends, I have 2 milligrams per kilogram of my weight.
Nice. People were like hypoglycemic, but still you made them. We'll come back to the session. We'll have lunch. May I request Dr. Balaraju sir to kindly offer the mementos to the chairpersons. Thank you, ma'am.
Thank you.
I definitely need your number.
To Dr. Nitin. You finish this, then I will take for lunch.
So you come.
For a very short lunch, 30 minutes, and the academic session resumes at 3.
Thank you, sir. Now we have a lunch break scheduled because of the time constraint, just 30 minutes, and then we'll come back with the academic session again. Thank you.
Very welcome. Yeah, she did. And ma'am is able to yes, we have evacuated. Yeah. We've not got the multi-house. No, we got this Arbe. APC also Arbe. Arbe. Everything. To Rapo, E-bus, to school, and
Okay. It's fully corporate.
Well,
So
it's
they
just
would
deep pockets there.
very deep. Sir. Otherwise, they would not get people to work. So initially,
Obviously, so here there's a hierarchy in Kerala. I'm not sure they'll they'll do that, but here the hierarchy, the professor gets a lot of cash, but they as he keep going down the thing, you would get beaten.
Nice,
So
sir.
the difference is huge,
Yeah,
and that wouldn't work there.
They wouldn't. So
Delhi,
what they've
the
done is they've
INTERSTITIal.
moved teams from places. No.
Yeah,
So
of
if they've
course.
moved
Yeah,
teams,
that's the usual Delhi.
Delhi thing.
Delhi thing.
So they can't. So 2017, they were offering us. We'll give you UGC assistant professor salaries. We'll give you 70,000, 80,000. You can give. So they approached Dr. Talwar.
Yeah, because he was the one who was here. Talwar's son, daughter,
everyone, yeah, son-in-law. So, you're offering him 1 lakh rupees. You crazy? So,
One small change is
yeah,
there.
yeah, yeah.
Everybody is having their flight problems.
Alright.
So I'm cancelling these two and you're coming in panel.
Alright. So you're cancelling these 2 talks?
After the panel, these
Good afternoon, everyone. We are resuming the academic session. So the next session, we will have only one talk in the interest of time. So the talk will be on pulmonary hypertension in India, technical challenges by Dr. Prashant Bopte. So to chair this session, we have Dr. C.N. Prasad sir from Karimnagar, and Dr. Suresh from Warangal, and Dr. Gangadhar Reddy from Yashoda, Secunderabad.
I can.
Good afternoon. I welcome you all again for our post-lunch session. Now we are going to have some interesting talks. To start with, first we have pulmonary hypertension, which will be dealt by Dr. Prashant Bohate. Pulmonary hypertension, though it is a rare disease, but it has got very much high morbidity and mortality. And the prompt diagnosis is very, very essential. So, but we face some certain challenges in diagnosing and instituting the treatment. So to listen more about this, we are going to listen from Dr. Prashant Bohate, who is a consultant pediatric cardiologist and in charge pulmonary hypertension clinic at Kokla and Dhirubhai Ambani Hospital, Mumbai. He's authored many papers, more than 42, both in national and international, 7 chapters in national and international textbooks. And his areas of interest is pulmonary hypertension, fetal echocardiogram, pediatric cardiac ventilation. With this brief introduction, over to Dr. Prashant Bohate regarding pulmonary hypertension. Please.
Thank you. Thank you, sir, for the kind introduction. I would also like to thank Dr. Vishweshwaran and the entire organizing team to invite me here to share my small experience about setting up a PH clinic and how do we work in the PH clinic in India. So the topic was technical challenge. I added a small footnote to it as technical and social challenges because as we know, all chronic diseases, and as beautiful lecture before the lunch by Dr. Raja Mayer, where she talked a lot about social issues of lung disease. Similarly, pulmonary hypertension also has a lot of social issues, social psychological issues which need to be dealt with. So disclaimer, I am a cardiologist, actually a pediatric cardiologist in a room full of pulmonologists. And most of my talk is going to be on group 1 pulmonary hypertension, that is pulmonary arterial hypertension. And have received a small grant for running a multicentric study of yoga in pulmonary hypertension from CCRYN and the Dinosaur Trust. So what are the challenges of management of pulmonary hypertension in India? These were some of the challenges were there in 2014. Over the last 7-8 years, some of these challenges have come down significantly. But we'll start, when we started in 2014, what was the problem? There were technical challenges and there were social challenges. In technical challenges, there were very few dedicated PH clinics. There was lack of standardized evaluation and treatment protocol. Right heart catheterization was thought to be unsafe. There was non-availability of prostacyclin analogs. Lung transplants were done in very few centers, especially in the south of India, and very few cardiac rehabilitation centers, and this problem is still existing all over the country. Social challenges, we have vast variance of patient, both in education as well as the financial status. Social and mental conditioning of the patient is often neglected, and lack of dedicated patient support group was a very, very big thing when we started our program. So what is a PH clinic? A PH clinic is actually a consortium of all specialists, and which is led by a PH specialist, and there has to be a cardiologist, a pulmonologist, a pediatric cardiologist, rheumatologist, cardiac surgeon, cardiopulmonary rehabilitation, a psychiatrist and a psychologist, and now I also have to add a palliative care person after Dr. Raja Mayer's talk before this. So there is a lack of standardized evaluation from the Indian point of view. However, the ESC, ERS guidelines as well as the ATS guidelines give us a standard protocol. And I think all of us are pretty aware as to how this goes. So I will not go into the details of this for the lack of time. But each patient has to be evaluated stepwise until we reach at the final diagnosis of what is the cause of pulmonary hypertension. So we'll start with this, case 1 is an 18-year-old female who was symptomatic since last 2.5 years. He was having easy fatigue and dyspnea on exertion. Was diagnosed and treated for pulmonary hypertension since last 2 years, and she had marginal response to pulmonary vasodilators, not much response to pulmonary vasodilators. And at that time, she has come to us for evaluation. So what has happened is somebody has done an echocardiogram and directly diagnosed the patient as idiopathic pulmonary arterial hypertension without actually going into what is the cause of pulmonary hypertension. And when we did evaluate at our center, we saw the VQ scan. There is a lot of areas of hypoperfusion. This is a CT scan which is showing a large thrombus in the pulmonary artery. And she also had factor V Leading deficiency. She underwent a pulmonary endarterectomy. Her mean PA pressure, which was suprasystemic at the time of surgery, came down to 22 millimeters at time of discharge. She's now in follow-up with us for more than 2.5, 3 years, continues to be in function class 1 and 2, and she's not on any pulmonary vasodilator. She's just on oral anticoagulation. This is the endarterectomy sample which was removed during the surgery. The second patient was a 14-year-old boy, had dyspnea on exertion again, routine symptoms of pulmonary hypertension. Again, an echocardiogram was done and started on pulmonary vasodilators, and he came for a second opinion. And this is what we found. So this is the splenic vein. This is the inferior mesenteric vein, that's a splenic vein. They're joining together and forming the portal vein. And there is a huge communication which is there between the portal vein to the systemic vein. This is what we call as extrahepatic portocaval communication. It's also called as Abernethy malformation. We close this Abernethy malformation by using a device over here. And 4 years post-procedure now, he's in functional class 1. PA pressures have normalized on echocardiogram. There is normal RV function as well as pressures, and he's not on any medications. And then we published our own series of patients of almost 10 patients who had Abernethy malformations who were detected, who were actually labeled as idiopathic pulmonary arterial hypertension, but it turned out to having Abernethy malformation, and most of these patients now have normal PA pressures after closure of this extrahepatic portocaval shunt. So as we say, fever is not a sign of ceftriaxone. All fevers, we don't need to give ceftriaxone. Similarly, all pulmonary hypertension, we don't need to give sildenafil. So this is extremely important. We need to remember this. Next was a right heart cath, and both the availability as well as the safety was thought to be very, very unsafe. But we have now 556 patients in our PH clinic, out of which 226 are idiopathic pulmonary hypertension. Almost 90% of these have undergone cardiac catheterization at our center with inhaled nitric oxide using 20 ppm inhaled nitric oxide. And only one child had an adverse event. He went into pulmonary edema. And as soon as we gave him nitric oxide, he went into pulmonary edema, probably had pulmonary veno-occlusive disease. And more important is 16 of these patients, that is almost 9% of these patients, satisfied the sit-bond criteria. Now, if they satisfy the sit-bond criteria, we can start them on calcium channel blockers and sildenafil. And we know that if the patient is vasodilator positive, the prognosis is much better if the patient is vasodilator negative. So the cost of the medication decreases significantly, as well as the prognosis improves significantly. So right heart cath is not only safe for diagnosis, but also for prognostication of these patients of pulmonary hypertension. So standardized treatment protocol, this has been given by ESC ERS, and I know most of us have already read through this. We don't need to go into detail of this, but what we need to understand is acute vasodilator testing, do calcium channel blocker, do risk stratification, and then if the patient is intermediate or high risk, he either goes on double or triple combination therapy. And if it is already in high risk, directly goes for IV or subcutaneous prostacyclin analogs and refer for heart and lung transplant if the patient does not respond to the initial therapy. Now, in India, we have 3 additional factors to factor in before we go through this, this flow chart. And these are, what are the patient resources? Does the patient have the resources to go for a heart and lung transplant? Does the patient have the resources to take the medications? Availability of prostacyclin analogs in 2014, there were no prostacyclin analogs available in the country. It is only in March of this year, Selexipag has been available. And heart and lung transplant, as I said, both the cost as well as availability was a problem. And this is our small facts about India's economy. India has a mixed economy, and most of us know this. Half of them are agriculture workers. The median income last year was 145,000 rupees per year, and the annual combination therapy cost, that is sildenafil and bosentan, or any combination therapy cost, is coming up to 75,600 rupees per year. So almost 50% of the per capita income would go in taking medications. And on addition to that, if we add the prostacyclin analogs, some of which were not available, Iloprost, if we add, it was costing approximately 3,84,000 per year. Selexipag now, in spite of being manufactured in the country and sold in the country, is costing 3,60,000 per year. That's a very, very huge cost. And if some patient requires subcutaneous treprostinil, it's costing approximately 2 to 3 lakhs per month. So what has been our approach? So we retrospectively reviewed our data from January 12 to June 2021 of 541 patients, out of which 224 were pediatric. Obviously, there were more female patients, age group right from 2 months to 86 years. And 64% of our patients were having annual income of less than 1,50,000 rupees, 1,50,000 rupees per year. And 125, that is 23% of our patients were in the high-risk category, wherein we have to add, according to the guidelines, if we go, we have to start them on prostacyclin analogs right away. So we did risk stratification at presentation and 3 to 6 monthly on follow-up, and upfront combination therapy was a norm. Now the question is, if the patient is not improving, if the patient is doing well on upfront combination therapy, they continue that. If the patient is not doing, then what are the options we had? We could start them on prostacyclin analogs, refer for heart and lung transplant, or do a reverse spot shunt. And I will go into each of these. So prostacyclin analogs, our experience, we initiated Iloprost in 24 patients, 8 patients on subcutaneous treprostinil, and 32 patients on Selexipag right now. Age group from 3 years to 56 years. This is the dose of the medications which we are using. Our follow-up period was 18 months. This is our youngest patient. He was 3 years of age. He's taking the Iloprost on his own. and there were no major side effects which required withdrawal of medications. Most of the patients showed improvement in the echocardiographic parameters as well as the functional class, and the 6-minute walk test and NT-proBNP had decreased in most of the patients. However, we know that this patients undergo tachyphylaxis. So this is a slide which was, there's a paper in 2013 which showed that once you initiate the prostacyclin analogs, there is an initial drop, but however, it goes on increasing again over the next 2 to 3 years after therapy. This is exactly what happened with one of our patients. When we started her on iloprost, she was in functional class 4, NT-proBNP was very high. It came down, her functional class improved, but after 2 to 3 years, she went on worsening. And this is the time we changed from iloprost to treprostinil. And she's right now in functional class 2, her NT-proBNP is down to 500. So sometimes changing over from one medication to another also helps. Now this patient was not willing, she's a doctor by profession, was not willing for a heart and lung transplant, and that is why we had to start her on treprostinil. Pod shunt is also an interesting concept. It was first described in 2004 for pulmonary hypertension by Bartu et al. And what is done is a connection is made between the left pulmonary artery and the descending aorta. So what will happen is the elevated pulmonary artery pressures will decompress into the aorta, descending aorta, and there will be improvement in the RV function. So basically, we are converting an idiopathic pulmonary arterial hypertension patient into a patient with PDA with Eisenmenger who have much better prognosis. So it is a very interesting concept. So we counseled 52 patients who were in functional class 3 and 4 for pod shunt. 25 of them have undergone pod shunts. 19 have undergone surgical, and now we also have started doing transcatheter or transcutaneous pod shunt, where we puncture the aorta and the pulmonary artery and place a cover stent in between them. All were in functional class 3 and 4. Out of 25, we lost 5 patients. We were not able to, they had intraoperative mortality. 2 patients did not tolerate intraoperative clamping of the pulmonary artery, and 2 patients had intraparenchymal bleed. One patient had a crisis, because these are done during general anesthesia, so they had crisis during induction of anesthesia with persistent right heart failure after the procedure. All the survivors were follow-up. We now have a median follow-up of around 38 months. And this is the echocardiogram. So this is the echocardiogram before, this is the echocardiogram at follow-up. Before the procedure, you can see there is a hugely dilated right atrium and right ventricle. This is the interventricular septum which is bowing into the left ventricle. RV function is compromised. After the procedure, you can appreciate that the interventricular septum is now in the center, because it is going to be, the RV pressure is the same as the LV pressure. Here the RV pressure is more than the LV pressure. Improvement in NT-proBNP, improvement in RV function. And most of the patients, we were able to come down on medications. There were 2 late deaths because of right heart failure and 1 with lower respiratory tract infection. Survival of the patients, this was the general cohort, and the survival of the patients who underwent pod shunt was much better. The survival was better if we did it earlier, before irreversible right ventricular dysfunction ensued. As we all know, heart and lung transplant is a standardized therapy. However, availability is a problem, and also patients with pulmonary arterial hypertension fare worse as compared to the other causes of lung transplant. Moreover, the 5-year survival after lung transplant is only 50%, and this is in the Western country. Western countries were not sure what is happening in India. Graded exercise training and cardiopulmonary rehabilitation, again, was initially believed to be detrimental, but this is a recent recommendation, which is functional class A, level of recommendation A. However, if you see what is the distribution of cardiac rehabilitation, this is the distribution of cardiac rehabilitation centers in India. So most of them are concentrated in metro cities with very few centers which are available everywhere else. Only 1 slot is available for 360 patients per year. And average cost, this is in addition to the medication, is approximately 5,000 rupees. So we thought of, so we have initiated, we have just got ethics approval, and we already have the funds to start the multi-institutional randomized control trial to look at yoga and cardiac rehabilitation in patients with pulmonary arterial hypertension. Psychosocial impact, as beautifully shown by Dr. Rajam Iyer before, not only the patients, but the carers also have an effect on employment, inability to work, reduction in household income. And that is the reason most of the patients have anxiety and depression. So if you see 51% of the patients had anxiety, and this is incident patient and prevalent. So 53% of the patients had depression and anxiety, and almost of the incident patients, and for the prevalent patient, it was close to 20%. And the patients who had depression fared much worse in the short term as compared to those without. So we also need to involve a palliative care person, and patient support group also play a very, very important role in this. So it was virtually non-existent in India till 2 to 3 years back. Now we have Pulmonary Hypertension India. It's an active group which is almost having 740, more than 700 patients from across the country. They're very active on social media, address the issues with day-to-day living with pulmonary hypertension. So one patient, when talks to the other patient, they get encouragement as to how to live their daily lives. They also know, because right now what is happening is if you put pulmonary hypertension on Google, they say that the median survival is only 2 years, you know, and that is a problem, and that's one of the major reasons why the patients go into depression. And we are working very, very hard because treprostinil is manufactured in India by 2 Indian companies, but it is still not available for our patients. So we are working hard along with the Pulmonary Hypertension India to get this available in India at a reasonable cost. To conclude, in India we have a vast diversity of patients and resources, challenging to have a standard treatment guidelines for evaluation and treatment. It needs to be tailored based on the needs of each individual patient, and active cooperation between various specialties, especially cardiologists, pulmonologists, pediatric cardiologists, palliative care person, psychosocial evaluation of the patient and cardiac rehabilitation is extremely important. Thank you.
Thank you, sir, for that lucid presentation.
Thank you so much.
Congratulations. So we are not taking questions because of lack of the time. You can interact with the doctor in your leisure time. So now moving to the next session, that is the panel discussion.
Panel discussion, sir. So before we move to the panel discussion, I would request the chairpersons to felicitate our speaker, Dr. Prashant Bopte. Dr. Prashant Bopte, onto the dais, please. I request Dr. Sonia Dalal to felicitate our chairpersons. Dr. Sonia Dalal. And it is also her birthday, as Dr. Murali Mohan has already said, and happy birthday from the team of Yashoda as well, ma'am. To Dr. Gangadhar, sir. To Dr. C.N. Prasad, sir. To Dr. Suresh. Now there is some slight change in the schedule, and because most of our speakers have to take up their flights, which is pretty close, we are moving ahead with the panel discussion now. So for this panel discussion, which is the most awaited event for the day, like we have none other than Dr. Rajadhar, sir. I think he doesn't require any introduction even in India and abroad as well. So he will be moderating the session, and I would request him onto the dais, please. Dheeraj. And this time we have a mixture of panelists here. We have Dr. Sujit Rajan, who is a very senior and an experienced person who has got a special interest in the field of ILD, and he will be there to clear most of the queries which we will be seeing as the case progresses. And we have Dr. P.V. Pravakar Rao, who is a senior consultant pulmonologist, and we hope that his wisdom in treating so many patients for so long period of time would add more interest to the ILD, which is a rapidly evolving field. And we have Dr. Gopi Krishna, who is our very close friend and colleague from Yashoda High Tech City. We have Dr. Arjun Khanna, a young, dynamic, and always an inspiring person, all the way from New Delhi. And we have Dr. Sumita, who is working in Jodhpur. So he will give us all the perspectives on how ILD is being treated in a secondary setting. We have Dr. Varaprasad, who is a rheumatologist from Yashoda Somajiguda. He will be giving us insights on what we as pulmonologists really require when we treat a case of an ILD. We have Dr. Devashish, all the way from Orissa, to give his perspectives on how ILD is being taken care of in the eastern part of India. And we have Dr. Nitesh Gupta, who is an excellent academician who is working as an assistant professor in the Institute of Safdarjung in New Delhi. Sir, you can come this side. I think the light will be directly on you. Devashish, you can go. Sir, the light will be on this. So I will be taking you through 3 cases. We'll hope that we will be able to finish those 3 cases. And in this case, through Rajadhar sir, we will try to understand from our expert panelists how we really have to manage these real-world situations. So moving on to the case 1, he's a 68-year-old male who is a current smoker with 35 pack years of smoking, who is a non-alcoholic and a resident of Hyderabad. He presented with complaints of exertional dyspnea since 3 years, which has progressively increased over the past 3 months from a MMRC grade 1 to grade 4. The functional activity is also limited by his bilateral severe osteoarthritis of the knee, and he is currently homebound and he is on LTOT. The patient is also having a history of non-productive cough for the 2 years, which has increased more so for the past 3 months. There was no history of any loss of weight or an appetite or hemoptysis, wheeze, chest pain, symptoms of upper respiratory tract infection. He has a history of GERD, but there's no family history of any chronic respiratory illness. And in the past history, there is no history of any old pulmonary coughs. There's a history of diabetes, hypertension, and coronary artery disease, and the patient has undergone a coronary artery stenting twice, and the last stenting was done 1 year back and currently on dual antiplatelets. And with respect to the treatment history, he was admitted elsewhere twice in the last 1 year for worsening breathlessness, treated with oxygen and supportive management, and following that, he continues to be on LTOT. So in his autoimmune symptoms, he complains of history of arthralgia, more so for the smaller joints. There was history of myalgia, but apart from that, other symptoms were negative. He has got a history of exposure to the molds. He has got a history of exposure to the birds and the other possible organic dust. And on drugs, he is on a chronic treatment with antiplatelets, and he is an teacher by occupation. So we leave it to Rajadhar sir with the history.
So just a brief summary again, just 2 lines summary, and tell us the total time course. You've said MMRC 1 to MMRC 4. You've said 3 years.
So we've got a 68-year-old male who has got a multiple comorbidities of diabetes, hypertension, CAD, and he has undergone stenting and worsening breathlessness more so for the past 3 months and on LTOT with features of autoimmune features just like arthralgia, and along with that he has got a myalgia and significant exposure to the birds and other organic dust in residing area.
So if I could start off with Dr. Gopi Krishna. So Dr. Gopi Krishna, your thoughts about the history and what you think is going on here. So
I think there are 2-3 things. There is a history of smoke, and there is a history of exertional breathlessness gradually increasing, and an arthralgia and an exposure to birds and molds. So there are 2-3 things we have to consider. Yes, there can be a ILD. Probably we have to rule out the connective tissue issues, and probably we have to think about HP, and probably with the history of exposure to smoke, probably a entity of RBILD. These 3 things come into the mind. This is what I look at.
So Dr. Gopi Krishna, 3-year history, from moving from being reasonably asymptomatic to being breathless to the extent of being breathless at rest.
True.
So this is an aggressive disease process. So if you think about the various categories of ILD, the disease progression, does that lead you in one direction or the other when you're trying to do a differential diagnosis?
Yeah, probably we have to think, in lines of the CTD-related ILT, which can, progress a little faster.
Sure.
If not approached properly.
Okay, and maybe IPF too, isn't it? I mean, think about IPF, which is progressive and relentless and so on.
Yeah,
So,
with history, probably I cannot come to a conclusion of
Sure.
IPF and all.
So, let's move on, Vishwesh. I think
So
we've
on
got some
examination, the patient was conscious oriented, he was tachycardic, slightly tachypneic with respiratory rate 28 per minute, saturation was 84% on room air, and he has got clubbing, which is grade 3, cyanosis at rest, there was no palpable lymphadenopathy or pedal edema, and on chest auscultation, he was having vesicular breath sounds with find end inspiratory creps. So this is the X-ray.
Shall we just stop for a minute? I'll come to Sujit. Sujit, the history, and along with that, the examination findings. So you said find bilateral crackles, sort of looking at the X-ray. Were these crackles all over? Were these basal crackles?
It's more towards the subscapular region, but it is all throughout the chest.
Okay. So history plus whatever we have found on examination plus the radiology, does that already lead us in the direction of a diagnosis, or do you think we need more information?
I think, Raja, first of all, 3 years have elapsed, which is a story in itself. The 3 years it took, the patient is on oxygen at home without a scan or an X-ray. I mean, there may have been X-rays earlier, which we don't have, I guess, Vishwesh. But
Yeah,
3
we
years,
don't have it at present,
yeah.
so yeah.
So 3 years have passed. Here, there's clearly some interstitial process going on. He is a smoker, right?
He's a smoker.
He's a smoker and he's 60 plus. So, you would think of IPF as the most likely diagnosis. In a progressive ILD smoker, smoking-related interstitial fibrosis is known, but then we would probably have to see the scan to differentiate that, those features. But I think I would zero in on IPF as the first diagnosis here, until proven otherwise.
Sure. So, just before we move on, taking off from where Sujit left, Dr. Subhitra, you...
Also, clubbing and end inspiratory crackles, not common in HP, both of these things.
So, clubbing, end inspiratory crackles, and you see this chest X-ray, which was aptly described by Sujit. But also, I would argue that the lungs are not as shrunk as you would expect them to be. In a smoker, anything else that you would want to sort of think about, talk to the audience about? He mentioned smoking-related lung disease.
Exactly, yeah. Considering that the X-ray is not showing that much of shrunken lungs, we would also like to think about CPFE in a patient like this. And considering that this is more of a lower lobe involvement, CPFE again comes like first thing in mind after this. And the rapidly progressive disease again all fits into that kind of picture. Yeah. Thanks.
Sure. Move on. Let's go, Vishwesh.
So this is the CT which we have. These are the axial cuts at the upper end of above the level of the carina, and this is at the level of the carina and below the level of the carina. And this is at the basal level.
Yeah. So Arjun, let me come to you. Thoughts about the CT and how it ties into what we have discussed till now, including the history.
So if you go to the upper lobes, if you see the axial cuts over there, Vishwesh, if you can go back to the axial cuts there, the upper lobes. So we can see there are features of centrilobular emphysema there. The lung fields in the upper lobes are hyperinflated, and as we move down, we see an interstitial process which is happening. There is tractional bronchiectasis. The disease is subpleural, peripheral, more at the bases of the lung. And if you go down further, you can see some amount of honeycombing happening there. So this fits in with the process of CPFE, where there is concomitant emphysema along with an interstitial process in this place, which is a UIP pattern, which fits the diagnosis.
Yeah. So agreed. So for the audience, what Arjun very nicely described there was the apicobasilar gradient, subpleural distribution, septal thickening, traction bronchiectasis, honeycombing, all of which equates to a diagnosis of UIP, as he said. Show us the upper lobes again, Vishwesh. I couldn't see a lot of emphysema, but these are...
and there's not much honeycombing, to be honest.
Yeah.
I couldn't see much
more of
honeycombing.
traction bronchiectasis.
Yeah, more of traction.
Yeah. Yeah. And what did the report say? I mean, we've only got a few cuts. So did the report talk about emphysema?
So the report, as expected from any radiologist, query UIP. So
Okay.
They don't.
No mention of.
They have not mentioned whether it is a possible, probable, or definite. They just said query UIP.
I think the reason we ask this question, and I say this for the audience, is whether you have an emphysema along with the UIP we are talking about is important, because we know that there are implications in prognostication. You have more of pulmonary hypertension in this category of patients, and hence a greater mortality in patients who have this overlap phenomenon rather than just having pure UIP, which is also a bad disease anyway. Shall we move on from the CT? Yeah.
So then we got the labs done. The routine labs were pretty much normal. And the ABG was suggestive of a hypoxemic respiratory failure with the PO2 of 48 millimeters of mercury. And these were the lung functions which were done. The FE1 by FEC was 90% of the predicted, where the FEC was only 44%, and the DLCO was out of proportionately decreased 25% of the predicted value, and the TLC was 42%. RV by TLC was 108, and 6-minute walk test the patient couldn't perform because of the osteoarthritis of the knee. So
let's just hold on one moment. I'll ask Dr. Debashish. I mean, that's, I think, a very interesting lung function test report. So, Debashish, your interpretation of the lung function report? You have mine.
Yeah.
So, probably it's a case of restrictive ventilatory defect.
Sure.
And in the background of elderly male smoker, with CT showing probably UIP pattern with restrictive ventilatory defect. So can be a case of IPF, first and foremost thing. And second differential diagnosis we can keep is chronic HSP, sir. We can think of about is. And as the patient was having arthralgia and some sorts of CTD related features.
Yeah.
So IPAF we can also.
Sure. So we'll come to the diagnosis, Debashish. My question is actually, I'll ask you two particular questions. One is the FVC being at about 44% with a DLC of 25% predicted. Do these two numbers go hand in hand, do you think? Or do you think the DLCO is disproportionately reduced? That's one question. And the second question is the RV-TLC ratio, which is at 118%. How do you match that into with the rest of the lung function?
So it could be associated with PH, pulmonary arterial hypertension, if you can go for echo to conclude any diagnosis.
Yeah, so Nitesh, anything else that you would want to add to that?
So RV by TLCO is nearly raised, 120% is the limit. So the emphysema which was there, it may be the reason of one of this thing, air trapping has happened.
Yeah, so perfect. I think that's what I was trying to point out. The RV-TLC ratio being even a little bit raised probably indicates that there is an element of obstruction along with the restriction. And I think that even the DLCO being 25% of predicted is a tad too low to be explained just by the UIP pattern that we saw on the CT, which Vishwesh showed us a little while ago. Do you think that's correct? Sujit, what do you think? What your thoughts?
I think if we had the KCO, we would also know a little more here. If the KCO was also low, it would suggest there's a significant vascular component to this contributing to the low DLCO. And so pulmonary hypertension would then be significant, I think. So that value would have helped, and otherwise the RV-TLC could be also be due to the small airway disease component to this whole thing, because there's not much of emphysema on the scan that I can see at least. So I think this would fit in with severe restrictive disability, and looking at the scan, possibly it looks like to me probable UIP. There's a little bit of ground glassing I could see.
So Sujit, I'll sort of. So you say that it could be small airways disease. In patients where we are talking about UIP, rather than a more central disease, a bronchocentric disease, would you expect small airways disease?
Not much. Yeah. To be honest, if you look at small airway disease, you always think of HP.
Yeah.
If any feature of small airway disease is there, HP should be on the differential. Here I'm not, I mean, this could be HP. HP has had very difficult, all kinds of CT presentations. But it would be a little lower on my cards, looking at that apicobasilar gradient, clubbing, crackles, no squeaks.
Yeah, sure.
Sort of tends to tilt towards IPF.
Sure. Vishwesh.
So we went ahead with the investigations. MON2 and IGRA were done, which were negative, and CRP was less. ECG was suggestive of old infarct changes. Echo was suggestive of LV ejection fraction of 40%, with a high pulmonary artery systolic pressure of 55 millimeters of mercury. Eye examination was normal, ultrasound abdomen was normal, HbA1c was normal, and BNP levels were normal. But on investigations, the ANA by IFA was borderline positive, but however, the ANA profile turned out to be negative.
Yeah. So let me come to our senior clinician. So Dr. Prabhakar Rao, your thoughts. So you've heard the history. This patient is with you. Briefly, what are the diseases that you're thinking about here?
What I feel more than the etiological diagnosis is radiopathological diagnosis here. It appears there's a multitude of factors are there. COPD, bronchiectasis, ILD, emphysema, pulmonary hypertension. Almost there is no functional lung tissue there. Now the patient is going into the respiratory failure, and ultimately this is pulmonary hypertension, bronchiectasis.
Sure.
So there's no use of further splitting hair in this.
Sure.
Because as clinicians, we'll have to think, what can we do for this patient?
Sure. So the reason we are asking about a diagnosis, and I'll come to you, Arjun, your differentials, is because the diagnosis and the prognosis to an extent would be dictated by the underlying diagnosis. That's why we are looking for a diagnosis. So I completely take on board what you said. I think those are very important points. But what is your differential at this point, Arjun, changed from what you said before?
Sir, seeing that PFT, my differential would still, the first differential would be CPFE. Of course, I would keep IPF as the main ILD which is happening
Sure.
here. And of course, there could be an element of IPAF there. IPAF is not always dependent on serology, which is done at one time. These serologies are dynamic. Sure. You can repeat them, and sometimes, things come out to be positive at times, which were negative earlier. And also, there is history of small joints being involved there. So for me, these would be the top three differentials. And if, I fully agree with sir that in this point in time, there's not much that you can do about this patient, but if the patient is willing and if things are okay, if we can get a tissue of
Yeah,
some
so
kind.
we'll come to that in a moment. Another question, quick answer, Sujit. The question of IPAF versus this being IPF, and Vishwesh said that this was a borderline positive ANA, will have an impact on the management and even the diagnostic modality. The biopsy that Arjun spoke about will become far less important if this turned out to be IPAF rather than being IPF. So your thoughts about this ANA, and generally, how important is this ANA positivity in patients who have otherwise got IPF?
Sure. So this is a borderline positive ANA, Vishwesh has told us, and the ANA blot is almost, there's nothing.
It's just 1:200.
Yeah, and so nothing is positive on the blot. So I would probably not think this could be an IPAF because there are no other, we don't have morphology on pathology, neither do we have clinical symptoms suggestive of IPAF, but I agree with Arjun that you can be fooled with IPAF sometimes. I also suspect that in 3 years, this patient must have received steroid trials.
Yeah.
And if he felt better with it, he would have been on steroid when he presented to Vishwesh, which he wasn't on, right?
Patient had taken multiple episodes, courses of steroids and inhaled steroids as well, considering it to be a COPD outside.
Sure. So seems a little less likely there on IPAF. And honestly, a biopsy could help you get some features of IPAF. But in this condition, with a saturation of 84% on room air, I think any definitive biopsy, maybe in Patabi's hands with his kind of experience, we could probably think of it.
Yeah. We'll come to the biopsy question, Sonia. I can see your eyes. It says, no, you don't do a biopsy, but we'll come to that in a moment.
And we have a rheumatologist as well, Dr.
Yeah,
Varaprasad.
absolutely. So your thoughts about what we are talking about. Tell us about the ANA question. What do you think about a borderline positive ANA and the implications in this case?
Yeah. The ANA borderline, simply speaking, I don't think it is significant in this patient. And as we know, ANA can be one place also in IPF patient. And because there is no specific antibody, we can ascribe the ANA positivity to. I think we have to just observe it.
Sure.
Nothing much important.
Yeah, so same as the others have said, probably not IPAF given what we have heard till now, right?
Sorry?
I said probably not IPAF based on what we have heard till now. Exactly. So your differentials, Vishwesh, let us crack on.
So we did have a differential. We thought IPF as the first diagnosis, considering the age, smoking history, and the CT scan with what we had. IPAF was, we also had a differential because ANA was borderline positivity, arthralgia and myalgia was there. Hypersensitivity pneumonitis because of the exposure to the organic dust and the smokes, and idiopathic NSIP because there was no evidence of honeycombing to say it was a definitive UIP. So these were the differentials in hand.
Sure. So I don't know about the idiopathic NSIP, to be honest, Vishwesh, because we thought that this was a probable UIP pattern, given that there was not much of honeycombing. And it's not really looked by idiopathic NSIP, but I think the rest of what you have said is consistent with what we think about. So then the $1 million question, what do you do? So risk versus benefit, can we actually go ahead and biopsy these individuals? I can see Arjun nodding his head, so I'll ask this question to someone else. Maybe come to Sumitra. Sumitra, a patient comes to you. We don't really know the diagnosis. We've seen the differential diagnosis. We think having a definite diagnosis would have an impact on management. Would you biopsy? Would you not biopsy? What would you base your decision on?
Yeah, thank you very much. That is definitely a very interesting question, but considering that the patient is already in a type 1 respiratory failure, is on an oxygen therapy, it is really risky to get a biopsy. And will it really make a difference in management? I think already this is the importance of an MDT. Like, we are sitting over here and still we are having 3 different opinions, but we know that a common opinion that we formed is of an IPF. And we know that he's already progressed in the past 3 years, which again indicates that it's a rapidly progressive disease. Probably even if you get a biopsy diagnosis, considering that the CT is already showing a lot of traction bronchiectasis, septal thickening, it would be a fibrosis. It won't really change the management. So at this point of time, at least my opinion over here would be that we would not do a biopsy for this patient and treat him as an IPF.
Yeah. I agree with all of what you've said, Sumitra, with one sort of provision. I think the debate here is this IPF or is this chronic HP? And there's not a lot of honeycombing here. There is traction bronchiectasis, but not of honeycombing. So I think if you have a definite diagnosis, it probably is going to change management to an extent. If not completely, it would change management. But I completely agree with you that with, like Sonia was saying a little while ago, an FVC of less than 50%, a DLC of less than 30%, I think it would take a very brave man to sort of be forthcoming and say, you have to have a biopsy.
And as Dr. Sujit Rajan said, that the patient would have received steroids in the past course, and which that is not shown an treatment outcome, probably it would not show it again.
That and the pulmonary hypertension would also be an absolute contraindication to a biopsy. One would have liked tissue here, but I think the risk outweighs the benefit.
Correct. Anyone differ with that? Anyone on the panel or anyone in the audience differ with that? Anyone have any thoughts? Because I think this is probably the most crucial question in this particular case. Can't see any hands, so I think the panel is in agreement. Show us what you thought from the MDT.
So since the patient was on already dual antiplatelets and hypoxemic and already functionally limited, so we also thought that we wouldn't biopsy this patient, but we resorted to MDD. So again, in our case, it was discussed, there was a high risk of GA, there is a high risk of a pulmonary hypertension, severe hypoxemia, and the lung functions were pretty much reduced, and the DLCO was less than 30%, which all fitted into the contraindications for possible surgical biopsy. So we didn't do biopsy in this case.
Yeah, so we haven't done a diagnosis, so haven't done a biopsy. We don't have histological diagnosis, but we think this is most likely IPF, with a chronic HP coming in second. So let me come to you, Debashish, and maybe then to Nitesh. Your thoughts, this patient is with you now. You know that the patient has got poor lung function, poor quality of life, oxygen dependent, pulmonary hypertension. How is it that you're going to treat this patient? Very, very briefly, what is it that you're going to start?
So probably antifibrotics are the drugs of choice here, along with pulmonary rehabilitation and long-term oxygen therapy.
Okay. So no steroid, no immunosuppressive. No steroid, no immunosuppressive.
Patient is already in respiratory failure.
Sure. Yeah. Nitesh.
So no steroids.
No steroid? Okay. I don't know. I mean, I'll come to you, Sujit. I probably would give this patient steroid unless I knew for sure that this patient has received adequate doses of steroids before. You know, if they had received steroid before in the history, that's documented. We know that for sure. You remember that the CT, as Sujit pointed out, did show areas of ground glass, did show areas of active inflammation, and we do have chronic HP in the differential diagnosis here. I'll come to you, sir, in a minute. So I think I would probably give steroids and antifibrotic to start with, but I'll hear what you have to say, Sujit, and then we'll come to you.
Quickly, because of want of time, I think if I had a good cytologist at the hospital, which I don't
would do a
currently
BAL,
have,
yeah.
I'd probably do a BAL.
Yeah.
And that would help me take that decision on steroid. But I'd also, in addition to all that doctor mentioned, I'd also probably start a conversation on transplant.
Yeah.
I know he's 68, but we have now three
Sure.
68 to 70-year-olds who've been well transplanted. So,
Yep.
give him that option.
Sure. Brief comment, Dr. Prabhakar Rao. We'll go to case 2 otherwise.
I will give benefit of doubt to the patient. I will give deflazacort at least for 2 to 6 weeks. After 6 weeks, there is no radiological improvement, I will stop steroids. And definitely, I will go for bronchoalveolar lavage with the support of anesthetist, because that is much more acceptable than going for the lung biopsy.
Sure. So
This is what I feel.
very valid point. So lavage, I think, is something we should have said. So thank you, Sujit and Dr. Prabhakar Rao, for pointing that out. And I think I would personally, unless I have documented evidence that this patient has been on a long course of steroids, also give a steroid trial, like you said, sir. So in agreement with you there. Let's move on.
So, but however, in our MDD, we felt like the smoking history was pretty strong, and the patient was having clubbing, and the patient was having fine crepes, and the CT picture was more suggestive of a CPFE, and the PFTs were suggestive of CPFE. So we believed it could be a case of an IPF. So we didn't go ahead giving steroids, and we thought it was a case of an IPF, taking into consideration all these factors. So it was more of a case of a probable IPF based on the CT scan, wouldn't be fit into a definitive IPF. But considering the history and even an underlying diabetes, we were little skeptical on starting him on steroids. And he had already a bed bound, so we didn't want to give him any sort of new onset infections. So we went ahead only treating with antifibrotics. So this is what in the MDD, the entire thing was discussed. Cryo or surgical biopsy was deferred. As said, BAL was performed, and it was predominantly neutrophilic, and active infections were ruled out. And the consensus opinion of both the radiologist as well as the pulmonologist was an idiopathic pulmonary fibrosis. We started the patient on antifibrotics, oxygen inhalation, vaccination, GERD treatment, and pulmonary rehabilitation. And lung transplantation, as Dr. Sujit had pointed out, we also thought of, but it was deferred because we believed that the patient already had a functional limitation secondary to the osteoarthritis of the knee and had a poor cardiac reserve condition and also had a poor social support system.
Yeah, so wonderful. So everything covered, all ends covered, but like Rajam pointed out a little while ago, she's not on that team, and she probably definitely needs to be on that team along with everything else that's been said, the 68-year-old lady. So I think palliative care is the other arm that we need to speak about. So just to go back to that case for a minute, so my learning points from this case, Vishwesh, is that in patients who are on that balance, you sort of not sure of the diagnosis, histology might actually help. Taking a call as to whether you obtain tissue, the risk versus the benefit is something that you need to dictate. And here, thankfully, everyone agreed, but you would know of cases which are more borderline, where you cannot take that decision. And that's an important decision to take, because if that decision goes wrong, I think we might actually lose patients. That's one. And the second is this dispute about whether to give steroids or not to give steroids is important. And I think you did well on that MDT. You discussed, you thought about steroids, you thought the risk of the steroid outweighed the benefit, and you didn't give it. I don't think if there was another MDT team which thought a short course of steroids, like Dr. Prabhakar Rao said, would be something that's useful, even that would not be wrong. But I think this concept of having everyone together take a decision and then stick to it is something that comes out very nicely from that case, Vishwesh. Let's move on.
So now we have the case 2. This is from courtesy Dr. Narendra from NIMS Hospital. So this is a very exciting case of a 50-year-old male with no prior comorbidities, and he presented with complaints of initially dysphagia to solids, which later progressed to dysphagia to liquids since 3 months, shortness of breath on exertion since 2 weeks, which was not associated with any orthopnea or a paroxysmal nocturnal dyspnea, cough with mucoid expectoration for 2 weeks, not associated with hemopsis, bilateral symmetrical large and small joint pain since 1 month, which is associated with a morning stiffness and swelling, and fever for the past 5 days, which is not associated with chills or rigor. So this is on clinical examination, this was the finding in the patient.
Just go back, Vishwesh, positive points there. So
50-year-old male who presented with dysphagia, complaints of dysphagia, shortness of breath, cough, joint pains skin rashes, and fever since 5 days.
Sure. So I'll start off with Dr. Gopi Krishna. Dr. Gopi Krishna, those rashes, that history, what are you thinking?
With the history of the dysphagia to solids, which we cannot ignore, probably it can be a drug or it can be the primary disease itself, and the joint pains, and we can see some pigmented patches on the skin. First thought would come is about something like dermatomyositis, and probably the second would be something like systemic sclerosis, probably limited or diffuse once we start working up. Third would be something like a connective tissue disease like an SLE. This is what I think right now.
Sure. So dermatomyositis, scleroderma, and then SLE. Any thoughts, Arjun? Anything to sort of change, add? Sarcoid. Okay, sarcoid. So I think these rashes are classical, and when we look at textbooks, Vishwesh, we all see Europeans against a very fair background. And these typical sort of erythematous, hyperpigmented rashes look very, very different on a European skin as compared to what it does on our skin. So I think this is actually a description not in the literature, but I agree this looks very much like the dermatomyositis rashes that come out in the books. As long as you make the skin a few shades fairer than what it is, it'll look very similar to that. So let's move on.
So on examination, there was no icterus, pallor, cyanosis, clubbing, or pedal edema. Pulse rate was 88 per minute, respiratory rate was 16. The saturation was 96% on room air. Breath sounds were equal and no significant finding, and cardiovascular system was normal. So this was the HRCT which was done in 2021 outside, where there were presence of patchy subpleural consolidations, along with few areas of interstitial thickening. But as it went by in February, as you can see, there is progression of the lesion which moved to subpleural consolidation and interstitial thickening, along with evidence of GGO. And on 25th of March, there is a significant worsening of the lung lesions. There's an interstitial and interlobular septal thickening with GGOs with more of an apicobasal gradient. And this is what we had when the patient presented.
So Vishwesh, this patient is getting monthly CT scans because they are exacerbating and getting hospitalized.
Progression of symptoms.
Right. So, and was the radiologist's interpretation that there was a cavity in the middle of the right subpleural consolidation?
They had commented it as more like a breakdown. They didn't mention it as a cavity. There was a consolidation with a breakdown was the finding.
Sure. And this patient was admitted at that point of time? Was in hospital or?
No, this was probably in OPD visit, and this is the time when the patient had
got admitted.
Symptoms. Yeah.
Okay. Okay. So thoughts, maybe we come to you, Nitesh. Your thoughts about the CT progression, about what shows up and nature of the disease?
CT has progressed from peripheral patchy consolidations now to more of a peribronchial involvement with traction bronchiectasis throughout and extreme ground glassing with areas of consolidation. So disease is actually rapidly progressive disease. So differentials of dermatomyositis, involvement of lung will be again at the priority or CTD related disease.
Sure. So one of the things, Nitesh, I think you would agree is ILD, the inflammatory process progressing at this rate is unusual. So there's probably an infective process on top of what's going on already, isn't it? I mean, the background disease. Dr. Prabhakar Rao, your thoughts about this case? I know you had a comment, so quick comment and then a little bit about the radiology and we'll move on.
Actually, this has progressed very fast. Absolutely, there is no doubt. And then we have to entertain whether there are any other infections like viral, or is there any other bacterial, mycoplasma. We are forgetting more often than not. Mycoplasma is also a possibility. Sure. And I must share one of my thoughts. If it has been acute onset or subacute onset, one has to even remember Steven-Johnson syndrome. Sure.
I mean, the skin rashes you meant. Yes. The skin rashes. So you think, yeah, so I think that's I mean, you would look at the mucosa, but Steven-Johnson can result in such extensive skin lesions. So that's definitely a thought. Sujit, if you saw a patient progressing at this rate, January, February, March, would you think ILD progressing? I mean, I know you would take other symptoms into account, or would you sort of go ahead and do a BAL quickly to find out whether you're missing an infection?
At this stage, is he hypoxic? Vishwesh?
No, yeah, when he presented in March, yes, he was hypoxic.
He
but
was
to start off with, he was pretty normal with.
Yeah, so I agree with Professor Rao that we would probably need to rule out infection first here. The infection would be...
And we had a history of 5 days of fever as well.
5 days of fever, so infection would be high on the cards. So get a bronch in, even if he's on oxygen, and at least send out a lavage. And rule out any rapidly progressive infection in a patient was he on steroids when he presented?
In between, probably he was started, we don't have the history.
Right, so because if he was immune compromised in any way, first thing would be to get a bronchial wash. There are consolidations, but there's also a rapidly progressive interstitial element there. And so this guy would definitely need some workup. There's no question about it.
And the other reason for doing a BAL also, Sujit, would be that if you had to pulse this guy thinking that's a progression
you
of the
want to rule out
inflammatory process,
infection first.
you would want to rule out infection.
Absolutely.
Yes, Vishwesh, let's move.
Probably Procal, some blood
So
work.
then ANA was done, which was 3 plus speckled, and RA factor was positive, MDA5 was positive, Rho 52 was positive, D-dimer was positive, procalcitonin negative, CRP was negative, serum ferritin was pretty high, and LDH was also slightly on the higher side, and routine blood investigations were normal.
So I'll come to the rheumatology expert. I think this is beyond pulmonologist. So Dr. Vara Prasad, your interpretation of the investigations and what you think is going on.
Yeah, from the history, I think we have established it is connective tissue disease and probably dermatomyositis, and I agree with that line. It could be, and two things before going to the diagnosis. He had dysphagia, so probably he must have proximal myopathy. Maybe he didn't mention because he's breathless. Other thing, I'd also like a CPK here, whether it is elevated or not, to see if he's having myositis as well. Though LDH elevation may point out it is myositis. And coming to the serology, ANA is positive, and specifically MDA5 and Rho52 both are positive. Here, Rho52 is positive is an associated antibody most of the times. But here, the important antibody is the MDA5. Which is known to present like this, like classic. They may not have a classic dermatomyositis presentation, but they can have a brief course of arthralgias or arthritis and skin rash, and a progressive ILD, which could progress within a month, 1 to 3 months. So this fits into that description. I think, and infection is always, because 3 months of illness, infection is always that we have to rule out before going forward.
Sure. And tell me a little bit more, Dr. Varaprasad, about this ANA, the speckled and the cytoplasmic pattern both being positive. Does that have an implication when you think about the things that could happen to you, the connective diseases that could happen?
The intensity of the antibodies and it being speckled and cytoplasmic, like Rho52, it can be having both cytoplasmic and cytoplasmic and nucleolar, so that might be one. So the intensity is helpful there. The prognostication wise, the antibodies, the MDA5 and Rho52, those are more important because we have those data. And this 3+ means the antibodies are significant enough, beyond doubt.
Okay. Okay.
And the specificity of MDA5 or any antisynthetase is 95%, and specificity 95 to 99% specificity and sensitivity.
Sure. Yeah. Yes. Yes, Sujit.
Yeah, this I think I agree with the rheumatologist that MDA5 would be more important than Rho52. We had a case like this recently, and this is MDA5 positive CTD ILD. So it's an inflammatory myositis, and it's probably rapidly progressing this way because it's MDA5.
Yeah.
Also, the CRP is negative, Procal is negative, so this patient needs to be pulsed as early as possible.
And
I
you
mean,
would probably,
really
if you
pulsed with other immunosuppression, significant other immunosuppression.
And it would prognosticate very poorly for this patient. When you spoke to the family, you would be very worried about the way this patient is going.
You would have to, because they've tried, there have been multiple therapies we tried on a patient who's, but anyway, we can come to treatment, but right now pulse with cyclophosphamide is what we would do.
Yeah.
And follow it up with mycophenolate if he improves.
So that is what so these were the things which we had. What could be the probable diagnosis? What are the differential diagnosis? And do we need a histology? Like all these things has been taken already. So even in NIMS, I think Dr. Narendra sir has already pulsed this patient on methylprednisolone with 500 milligram for 3 days. First dose of cyclophosphamide with 1 gram was given. 5 cycles of plasma exchange also done, considering the patient was refractory to the treatment. One dose of rituximab was also given. But patient in due course probably developed a pneumomediastinum, shifted to RICU, but this time the fever was not primarily because of MDA. The patient also had an associated COVID because it was during the time of the COVID pandemic, and the patient expired on 22nd April 2021.
Yeah, so sad case. I think it's an interesting case, unfortunate case, but the fact that all treatment modalities were tried, I don't think anywhere else in the world you could have given this patient or done anything else for this patient compared to what has been done already. So
it's very interesting because our patient also was COVID positive, and I think Shenoy mentioned in his talk that COVID and MDA5 antibodies seem to be correlated for some autoimmune reason, you know. So our patient, actually, we shifted him to another hospital, Raja, where transplant is available.
Right.
So he's now transplanted 4 days ago, and he's stable. But we tried everything, including tacrolimus, all that you've tried. Only we didn't give him rituximab because he was already cyclophosphamide and tacrolimus. So there was too much immunosuppression going on. We gave 5 exchanges. He used to improve, got worse again. Terrible disease, terrible disease.
yeah,
Really.
yeah. And I think the pneumomediastinum is also the killer, isn't it? I've seen very few patients who develop a significant pneumomediastinum actually sort of surviving in the long term.
And I think Dr. Narendra, sir, who has treated this patient, wanted to say a few words.
So we lost this patient and we couldn't do lung biopsy because of COVID positive status at that time. But after 1 year, we got one similar case, young female, who has been treated outside. She has visited multiple hospitals with ILD. Maybe she has taken some steroids on and off. She presented with pneumomediastinum. So this time we were more vigilant. She had this healed Gotran's papules, Gotran sign, heliotrope rash. So our first diagnosis was dermatomyositis. But considering this, so we went ahead with myositis panel. She got MDA5 positive. So this case also, we started aggressive immunosuppressive therapy. What we observed is this raised ferritin, anti-MDA5, pneumomediastinum, and this ulcerative skin lesions with the anti-MDA5 and rapidly progressed. But second case also succumbed. But we did a lung biopsy in this patient, post-mortem lung biopsy. We have found that this organizing pneumonia and with some amounts of diffuse alveolar damage. So this was our experience of 2 cases of anti-MDA5. But unfortunately, we lost both the patients. Though we have started early aggressive combined immunosuppression rather than staged or upfront.
So, I mean, you lost both patients, but not due to the lack of trying. And I just, to reiterate what Dr. Narendra said, he didn't do an ante-mortem biopsy. I don't think there's any indication of doing a lung biopsy in any of these patients, but he did a post-mortem one, which is what he said, which I agree with. If the family allows you to do that, it's fine to obtain some information in these patients, but you wouldn't want to do a biopsy in these patients anyway.
Yeah. So in our transplanted patient, we'll get the biopsy report, but I don't think they would have changed the management.
Yeah.
You're right, absolutely.
Yeah.
Can I have a comment?
Yes, please.
Yeah. Regarding the MDF, the data we have is less, but the treatment should be aggressive. Here it is at the 3rd month we are seeing this patient. Had we seen this patient at 1st month, and patient had the same pneumonitis what the picture showed, even then the treatment should be as aggressive as this. And then only the mortality, there is mortality benefit. And now there is good data that the first line of management is steroids, pulse steroids followed by high dose steroids along with cyclophosphamide and tacrolimus from the start. And it has improved mortality from 80% to 30%. And the second one which has been coming up the data is tofacitinib, which is JAK inhibitor, because the mechanism here is an interferonopathy, type 1 interferonopathy, and it's a rapidly acting drug and is orally available. So that is the second one, and rituximab as well.
Sure.
So
yeah.
So we are moving to the last case. In the
Do we
interest
have
of the
time, Vishwesh?
Yeah, we just have 5 minutes.
Okay, 5 minutes. Go on.
So she's a 40-year-old female, non-smoker, non-alcoholic, no comorbidities, exertional dyspnea for 2 years. It's progressed over the last 3 months, non-productive cough, painful swelling of the right lower limb for 3 months, no other positive complaints. And symptom-wise, the patient was having arthralgia, rash, fever, myalgia, dry eye, mouth, and there was no history of any exposure to moles, birds, or occupation. She was just a receptionist. And this was the skin lesion that was there in this patient, and the saturation was 94% on rumor, no clubbing, no palpable lymphadenopathy, and there were presence of bilateral vesicular breath sounds with crackles, and skin lesions were tender raised erythematous lesions.
Yeah. So quick comment, we'll sort of one-liner, I'll miss my flight otherwise, and so will Sujit. I know of these two people. So starting off with you, Arjun, what do you think is going on?
An autoimmune process, probably sarcoidosis, the skin lesions there.
So the skin lesion you interpret as what? Erythema nodosum? What's your erythema nodosum? Okay, and not clubbed, low saturations or lowish saturations, bilateral crackles. I have to say bilateral crackles is an unusual finding in patients with sarcoid unless you've got sort of stage 3 sarcoid or sort of stage 2 sarcoid, but we'll see the scans, etc. Let's move on, Vishwesh.
So then examinations were done, like all were pretty normal. Even the sputum culture gene expert was done, that was negative. And this was almost like a similar X-ray. There was bilateral infiltrates, and pulmonary function test was again suggestive of a restrictive etiology. And MON2 was negative, IGRA was negative, ACE levels were pretty high, and calcium levels were normal, ANA profile was negative. And these were the CTs with which the patient had presented. So these were the mediastinal cuts.
Yeah. So quickly, large mediastinal nodes, isn't it? You've got a station 4, you've got a station 7, there's nodes even in station 10. So there's significant mediastinal adenopathy, and let's see the parenchyma. And quick comment about the parenchyma, Debashish. Couple of words about what you see in the lung parenchyma.
So there is involvement of the peribronchovascular region, mainly ground glass appearance along with consolidation.
Yeah. Yeah, and the nodules, isn't it?
Nodules,
you can see some
well.
nodules,
Nodules as
septal
well, so,
thickening in the upper lobes, GGOs. Yeah.
So
Sumitra, so clinico-radiological diagnosis, how did you reach it? And do you actually need histology here? Or, I mean, all Arjun needed was a photograph to diagnose sarcoid. So do you think we need histology? And how would you obtain it? Quickly.
Yes, so clinically we can see that the patient has got the symptoms of type 1 respiratory failure. The skin lesion is very classical of erythema nodosum. The CT scan again is very classical of sarcoidosis because there are peribronchovascular nodules and thickening present along with the ground glassing. So the clinico-radiological diagnosis is sarcoidosis. And along with the lymphadenopathy as well that we can see over here. So we can reach to a diagnosis with that thing as well.
Histology, no histology?
Histology, unless we are considering any other differential diagnosis in this patient, she has no history of exposure. So HP, I mean, again with lymphadenopathy, I would not be thinking of anything else. But yes, we would like to rule out tuberculosis. And the BAL will definitely be required. Sarcoidosis can be confirmed with your EBLB, with your mediastinal lymph node FNAC as well. So we can combine the two things, BAL along with the biopsy, and hence get a confirmed diagnosis. Rule out tuberculosis definitely for this patient.
So I think I'd like to hear what Sujit thinks, but I think someone like this, I would definitely want to get histology. I would want to make absolutely sure. And you know we've got good data now, Indian data, to show that a combination of mucosal biopsies plus transbronchial biopsy plus an EBUS TBNA, which is going to be reasonably easy here, can give you a diagnosis of sarcoid with almost 100% certainty. So I think that's the way to go. Sujit?
I think I'd probably start off with a skin biopsy because that would be the safest site to biopsy. But I agree with Sumitra that if tuberculosis was anywhere on the differential, which is possible always, you're going to give long-term immunosuppression, you want to get that out of the way.
Yeah.
So we are just rushing through. So
yes.
Rarely.
Yeah.
Only panic.
Very rarely. But, you know, just to get the granuloma, Sonia, so that you have a diagnosis. If they had refused a lung biopsy, I would have done at least a skin biopsy to start. If I had to choose one site, the skin to start off with, and if they had agreed to the lung biopsy, probably go for the lung first.
Yeah.
So we did the MDD. There was a suspicion of chronic granulomatous disorder, possibly sarcoidosis, considering the clinical symptoms, erythema nodosum, raised AC, and PFT evidence. Radiologist's opinion was also favoring a sarcoidosis, but we thought that we need a histological confirmation, especially to rule out an infectious etiology like TB in India. So what are we going to choose? We already did this. So we had an access to EBUS, so we got an EBUS done. We also took endobronchial biopsies. And all that we had was a granulomatous etiology consistent with sarcoidosis with negative evidence for any tuberculosis.
So Nitesh, quickly, this patient is in front of you. what would you treat the patient with, and the duration of treatment. First presentation.
So we would like to start patients on oral steroids and at a dose of 0.5 mg per kg, maximum dose of 0.5 mg per kg for a period of about 6 months, and then we would gradually taper till we are able to reach 5 to 10 mg dose, and we'll continue the dose, and once a 12 months period has gone on the maintenance dose, that is the time we try to taper the dose. Response will be documented by symptoms, by spirometry, and possibly a year later by a radiology.
So in the best interest of the time, and I have to send my faculties back home safely, so we will conclude the panel discussion because we are at 4:15 now.
Yeah. So just one point before we finish off, important point, I think, for the audience. Two things which Nitesh said which are important. One is the dose is 0.5 milligram per kg body weight for lung sarcoid. There are 3 organs that you need to remember: neurosarcoid, cardiac sarcoid, and ocular sarcoid, where the dose of steroid is going to be higher. That's one. And the second is there's good data to show that treatment for less than 12 months actually means more relapses as compared to treatment for just more than 1 year. So those are the 2 points, Vishwesh, but thank you very much. And thank you to our panel for being with us and doing this study. Thank you so much.
Thank you, everyone. Thank you, moderators and the panelists, for such an enlightening talk. So in the interest of the time, we are moving to the next session, academic session. So to chair this session, we have Dr. Balraju Tadikonda and Dr. Sonia Dalal. And the talk will be on lung transplantation evidence and way forward by Dr. Janesh Thakur, who is a senior transplant surgeon at Yashoda Hospital, Hyderabad.
Good afternoon, everyone. So we'll now have a talk on the lung transplantation and the interstitial lung disease by Dr. Janesh Thakur. He's going to enlighten us on his experience and the road ahead as far as lung transplantation in interstitial lung disease is concerned. He's a senior cardiothoracic surgeon. He's an immense experience with transplantations, and he's at the moment working as a transplantation surgeon at the Yashoda Hospital. Sir, all yours.
Thank you. Good afternoon, ladies and gentlemen. I want to thank Dr. Vishweshwaran for giving me the opportunity to share my experience and my views on the road ahead. He made it very clear to me that don't give us any holy crap from the book. You have to talk straight from the heart and based on your experience, no textbook information. So that's what I'm going to do. I'm going to speak from the heart, and I hope I don't upset anybody. The goal of this talk, my goal is to share with you my experience of lung transplantation and reflect on the road ahead. We have done 24 lung transplantations in the last 13 months, and I'm going to talk to you about these patients and what I have learned and what we can learn and how we can improve, how I can improve from my experience. Most of our patients were having interstitial, I don't know, there's a difference in the slide is not moving. I don't know, some wrong slides are coming in. Should I?
From the beginning, sir.
From the beginning?
Exit the PPT and
Sorry?
go back to the normal mode, sir. PPT mode.
What is a PPT mode? This slideshow? There, it's moving there, see? It's not moving here.
We can use the slide.
There it's moving. Oh, yes, thank you. In our experience, most of our patients that I have operated most of them were having interstitial lung disease. Of course, you all separate out interstitial lung disease into its multiple histopathological reasons, but we surgeons just club everything together as fibrosis. So our thinking is not as precise as this. So most of the patients had ILD, bronchiectasis was 5%, idiopathic and others, including COPD, was 2%. I want to focus principally on 3 points which are relevant to which are related to the I want to speak to you specifically of 3 points which adversely affect the outcomes of lung transplantation. First is the recipient-donor size mismatch. And the second is that patients in acute exacerbation are a surgical challenge. And those patients who have got COVID ARDS or H1N1 ARDS and who are become candidates for transplant, they have a complex thought process going on. Then I would like to reflect on the road which is ahead of for lung transplantation, how to treat patients with acute exacerbation with transplant, what is the way to treat patients with ARDS. I have devised one operation to correct the size mismatch. I'll share that thoughts with you about the guillotine excision of the lower lobes. To initiate a national program education program for doing HLA. Right now we are not doing HLA testing for the donors. We have only recipient HLA, no HLA for the donors. There is a lot of talk about ex vivo perfusion, drones on transplant. I will share my views. Xenotransplantation and wearable artificial lungs. This is what I'm going to just comment upon for the future. Outcomes, patient selection. This is one thought which I want to share with you, is that patient selection is the key to outcomes. I will share one little story with you. This is Dr. I read on the UNO's website this sentence, which is quite interesting. Lung transplantation is the most complex medical endeavor undertaken by man. It was anonymous, but it was on the UNO's website. I want to begin by telling you the story of lung. Yeah. Sorry for this interruptions. Dr. Bragg G. Hattler was one of my mentors at the University of Pittsburgh. He was touring over India, as many of the Americans go over North India. They want to see Taj Mahal and they want to see the Red Fort and the palaces of the Rajas and the Maharajas. At that time, I was in Bombay. So after he finished his tour, I invited him to come to Bombay. And his wife, me and my wife, we invited them for a dinner at the Taj Terrace. While we were sitting there in the evening for the dinner, the golden sun was setting into the Arabian Sea and the whole atmosphere was very beautiful, sea breeze blowing from the Arabian Sea and the golden tint on all the terrace restaurant. At that time, Dr. Hattler asked me one question. The question he asked was, what is the single factor, according to you, that has improved the outcomes of lung transplantation? So I answered that question by saying good surgical techniques, better anastomotic, better sutures, good anesthesia, he said no, better preservation of lungs, he said no, better critical care, better cardiopulmonary rehabilitation, he said no to everything. So I was wondering, what is the answer? And then he said, patient selection, patient selection, patient selection. From the first lung transplant was done successfully by Dr. Joel Cooper in 1983 at University of Toronto. Till 1998, 40 transplants were done, but not a single patient left the hospital alive. The longest survivor was 8 months, and he also died in the hospital. So in 1998, all the learned pulmonologists and probably thoracic surgeons all got together and they devised guidelines for selection. They belong to the International Society of Heart and Lung Transplant, the American Society of Transplant Physicians, American Thoracic Society, European Respiratory Society, and Thoracic Society of Australia and New Zealand. And they developed international guidelines. Once these guidelines were practiced, the outcomes started improving. They were published in the Blue Journal. The outcomes started improving and more patients started getting registered for lung transplantation. And then these guidelines were revised once again, 8 years later in 2006, again in 2014, and every time the new guidelines came, the outcomes started to improve. 2021, the guidelines, this is the latest guidelines, which tell us which patients we should operate, which and when to operate them. Each guideline is divided into disease-wise. And under each disease, when to refer a patient for lung transplant and when to list a patient for lung transplant. The timing for ILD, the timing for referral is very crucial. You cannot be too early. Early referral so that the patient can wait for a good donor because there is a problem about size and HLA mismatch, as I will tell you in a few minutes. The patient and family can get educated and modifiable risk factors like high or low BMI can be adjusted. So this is one of the page from the guidelines. The natural history of ILD is unpredictable and 5 to 20% of the patient get acute exacerbation, which you all know better than I do. Referral to lung transplant at initial evaluation for initial diagnosis or when the patient requires 1 liter of oxygen. When to list a patient according to the radiological evidence of UIP, when DLCO is less than 40%, this is according to the guidelines, there's nothing, desaturation less than 88%, and when there is a radiological evidence of NSIP with DLCO less than 40%, or one of these criteria. How does lung transplant differ from other organs like heart or any other organ like lung or like heart, kidney or liver? Lung has got a window. It has got a transplant window. You have to be sick enough to need a transplant, but you should be well enough to tolerate the transplant, to bear the transplant. There is a certain period, besides we have to understand that the lung retrieval rate all over the world is 17 to 20%. That is 1 out of 5 organs will be usable. There is a window when you are suddenly deteriorate and the risk of transplantation becomes 10x. The 3 points that I want to talk to you about are first, the size mismatch. The size mismatch between the donor and the recipient. I hope I can give you a concept of what is the difference. Take, for example, this recent patient we operated. This recipient was 147 centimeters in height, and the donor was also 147, but you can see the difference in the size of the lungs. This lung is half the size. There is more than a 50% disparity in the size in the chest cavity. There are a lot of formulas. There is a Cleveland Clinic formula for collecting from predicted total lung capacity of the recipient. You predict the donor's lung capacity, and then you calculate a ratio. There are European Respiratory Society formulas, but I don't think that in real life any of these formulas really prevent mismatches. If the donor size mismatch, so my question would be, what is an ideal match? What is an ideal match? A donor which is 4 centimeters shorter and of the same gender for ILD. These problems are mainly for ILD patients because the chest cavity is small and becomes 4 inches smaller, which means that if my height is 6 feet, my chest cavity, if I have ILD, will be about 4 feet 10 inches, 5 feet 10 inches. So it is there is a difference of 4 inches or 10 centimeters. And if there is a gross mismatch greater than 10 centimeters on a male donor for a female recipient, it becomes an incremental risk factor to poor outcomes. The graft volume reduction that we have to do to correct the size mismatch can be done in 2 ways. One is non-anatomical and one is anatomical. I prefer to do non-anatomical because it reduces the warm ischemia time. Probably you all are wondering what is warm ischemia time. Warm ischemia time is the time which is measured from the time the lung comes out of the box and is implanted, and we start perfusing the pulmonary, remove the clamp from the pulmonary artery and start perfusing the lung. That period of time is called warm ischemia. Warm ischemia time correlates with primary graft dysfunction more than cold ischemia time. Warm ischemia time being higher, I prefer to do non-anatomical this thing. Also, it produces, the disadvantages are it produces pulmonary hemorrhages, staples are expensive, and in the post-operative care, the critical care people will think that there is a consolidation. The anatomical is that the warm ischemia time is more. Bronchial stenosis, because when you take the lower lobe and bronchus intermedius and you attach it to the recipient's right main bronchus, there is going to be a disparity. So chances of dehiscence and stenosis are very high. And all the studies, including the latest Toronto General study, shows that anatomical is associated with poor outcomes. The second problem that I want to discuss with you, or second this thing, is acute exacerbation of ILD. A patient who is, this is of table 2, page 4 of the guidelines. It says that a non-ambulatory patient is an absolute here. These are absolute contraindications. Limited function, non-ambulatory with poor potential for post-transplant rehabilitation is an absolute contraindication to lung transplantation. Now, if they have also mentioned that may make transplant more likely harmful for the recipient. So how are we going to handle these patients in acute exacerbation? Dr. You just mentioned that that they offered a lung transplant to a patient who was recently in acute exacerbation. If he is non-mobile, it's an absolute contraindication. The overall incidence, as you know better than me, is 5 to 20% per year, and the mortality of acute exacerbation is 76 to 98%. So worsening of acute exacerbation, I don't have to mention this to you. The in-hospital mortality is 78 to 96%, which is a very high mortality. Now, from our experience, I have operated on 3 patients who were in acute exacerbation, Pannalal, Abdul Samad, and Niteshwar. He was a 61-year-old coal miner who came from Dhanbad, was in acute exacerbation, was treated with solumedrol, and had an uneventful surgery, recovered very well, was wide awake after the surgery, but at T56, he developed severe PGD, and we were about to shift him to the theater to put a VA ECMO to support him, but sadly he arrested and died. Second patient, also similar age, everything about in late 50s, was presented with acute exacerbation, was on steroids, was not put on, we got a donor on the very same day. He was this thing, we chose the lung, we went ahead with the transplant, but at T60, he went into septic shock and became hypotensive and passed away. Niteshwar is a 61-year-old patient who was our first success in acute exacerbation with ILD, non-ambulatory, on ventilator and on ECMO for 10 days. The first bridge to transplant, which is alive 110. You can see he's celebrating his wife's birthday at home. Lung transplantation for COVID ARDS or H1N1 ARDS. Dr. Ankit Bharat was the first one to do a lung transplantation on a patient of COVID ARDS in the world, and it might surprise you that the first successful lung transplantation, which was done in the United States, was also done by an Indian surgeon, or surgeon of Indian origin. His name was Dr. Sheshadri Raju, S. Raju. It's the thing is published. So, strangely, both had Indian origin. Dr. Balakrishnan at MGM Hospital was the first one to operate on a patient with acute ARDS, COVID ARDS. He has published his patient. So the question is, when should we consider doing lung transplantation in patients with COVID ARDS? These are the guidelines which have been published by Shaf Keshavji from Toronto
Sir,
General
2 minutes,
Hospital.
please. 2 minutes only.
2 minutes more. Age less than 65 years. Candidate should have single organ dysfunction. Do not consider for 4 to 6 weeks if there is COVID ARDS. If there is radiological evidence of irreversibility like honeycombing or bullous destruction, then you can go ahead and do the transplant. Traction bronchiectasis is reversible in acute situation. Patient should be awake to understand and discuss lung transplantation. If they wake up with lung transplantation, they develop post-traumatic stress disorders, which may be unsurmountable. Patient must be able to participate in rehabilitation, even on ECMO, must have all other standard criteria, which is for lung transplantation, and patient must have a recent RT-PCR which is negative. Patient should have, the center should have experience with ECMO bridging, and that their donors must be available. These are the 10 criterias, and we are we have an experience of 6 or 7 patients. One of them has survived, 2 of them in acute exacerbation have passed away. Just a few more seconds I'll take to show you our results. This is minimally invasive lung transplantation. Patient was discharged, you can see, with staples on the 11th post-op day. On 38th day, he's driving his own car and is back to his normal life once again. This is Rajni Devi. She came from Ahmedabad, minimally invasive lung transplantation. She's back to her home and living a normal life. This is pulmonary alveolar microlithiasis. Patient is the first one in Telangana to get a lung transplantation. He had a minimally invasive lung transplantation. On the 11th post-op day, he's doing his bicycling and rehabilitation at the rehabilitation program. This is Niteshwar, who is now back at home, and he is getting rehabilitated. He was a 61-year-old non-ambulatory acute exacerbation with IPF, ECMO as a bridge to transplant. I think it has stopped. I'll be happy to answer. I'm sorry I couldn't finish this thing, but I'll be happy to answer any questions.
No questions? Any questions? Yeah.
It won't go further, right?
So lung transplantation, as per say, counseling the patient become very difficult. So my question is very straightforward, sir. In your opinion, which one was the baddest case you have taken and it was successful, sir? Quite simple, sir. Which was the bad case, most bad case, and it was highly successful? This guy, he's 110 days on ECMO.
Not 110 days. Today it's 110 days he's off ECMO. He's back in this thing. He was on ECMO for 15 days, acute exacerbation of IPF. He was previously diagnosed, worked up, went deteriorated, but he is the bridge to transplant which has been successful. And when I first joined the hospital, there were already many patients of COVID who were already on ECMO for many days, 35, 40.
Okay,
I operated 5 of them. All surgeries were uneventful. 2 of the patients got decannulated from the ECMO, but eventually all 5 died. For operating on these kind of patients, there are further slides, you need a long-term acute care facilities. You need them to be present and gradually wean from the ventilator. Their muscles are all atrophied, so they need rehabilitation and they may have bed sores, so they need wound care. So these things are the challenges.
Nice, sir. Nice, sir. New ray of hope, sir. Nice. Thank you, sir. Thank you.
Thanks for your talk, sir.
Okay, Vishweshwar. Sorry, I couldn't finish it.
We'll take it up. So we have the next talk, which is very important, especially for the postgraduates sitting over here. It's an approach to a case of a pulmonary embolism. And we have Dr. Arjun from New Delhi who will be enlightening us on this. Thank you.
Who is next? Yeah, good evening all. So the next talk will be by Dr. Arjun Khanna, an approach to pulmonary embolism and update. So Arjun Khanna is an ex-assistant professor at AIIMS New Delhi, and he's also now head of department and senior consultant pulmonary medicine, Amrita Institute of Medical Sciences, Faridabad, Delhi NCR. So He has more than 80 publications and book chapters. Arjun, please.
Good evening, everyone, and thank you for the kind introduction. I thank Vishwesh for having me here. I know everyone is tired now. We've had a long day. So this talk is meant for the postgraduates because this is something that we all see in our daily practice. And pulmonary embolism keeps haunting us. Somehow or the other, not always a very pleasant patient to manage. And this patient always comes back to haunt me. And because this patient, you know, Murphy's Law, anything which can go wrong will go wrong. So this patient was a senior resident doctor from PGI Chandigarh. So managing doctors is a very difficult, ball game altogether. And if you've ever managed anyone from PGI, then you know what I'm talking about. So this is approach to a patient with pulmonary embolism. So this guy was a 30-year-old male, a transfusion medicine doctor, a senior resident research associate at PGI Chandigarh, and a non-smoker. This slide, they've messed it up. They've said software engineer. No, he was actually a doctor. No comorbidities or past illnesses. And this boy had come to holidays. You know, he had come to Delhi for his holidays and he developed fever, left-sided chest pain, an acute URI kind of a thing. And then on the third day of illness, started having chest pain. And when he presented, to the hospital after 5 days, he was in frank respiratory failure. So the illness started as something like chest pain, fever, cough, respiratory distress, and you tend to think in terms of pneumonia, and that is what the doctor himself thought that he has. And he presented to the hospital with these complaints. Obviously, in retrospect, I'm telling you the history now, there was no history of trauma, recent long distance travel, no surgery, no history of any malignancy. So on examination, he had tachypnea, tachycardia. His saturation was only 83% on room air. And on auscultation, there were decreased breath sounds on the left side of the chest posteriorly. The ABG was suggestive of a type 1 respiratory failure, and the PF ratio was lower. So provisional diagnosis of respiratory failure, pneumonia, associated respiratory failure. And this was the early onset winter season. This is last year. So we were not really having that much COVID at that time. So a diagnosis of probable, viral illness, LRTI secondary to, or a bacterial infection, pneumonia secondary to influenza, and one of those diagnoses was entertained and he was admitted to the intensive care unit. So this was the X-ray that was done on day 1, and where we can see there were some infiltrates on the left side there, mostly in the basal areas. The TLC at the time of admission was again 13,300. The ECG done at this point in time, this is for all the postgraduates, the commonest manifestation of pulmonary embolism on an ECG is actually sinus tachycardia. So don't go by those fancy S1, Q3, T3s because those are exceedingly rare. So this guy had a sinus tachycardia on the ECG, and if you look at the right-sided chest leads, which is lead 2, 3 and AVF, and V1 and V2, there was some kind of a strain happening over there. As with all patients who come to a hospital in an acute care setting with fever, respiratory distress, and respiratory failure, a D-dimer in our hospital is a part of the protocol that we do. So the D-dimer which was sent in the ER came after a few hours as being grossly elevated, 4,406. So this was the picture at this time. We were still entertaining the picture, the diagnosis of a pneumonia, a left-sided pneumonia with sepsis, because the presentation was such. The patient had come with fever, the patient had come with a pleuritic chest pain. So we were still not really considered, we had not considered pulmonary embolism in our differentials, at least till this point in time. And if you go back to your Paul Marino, which says, when you see the chapter on pulmonary embolism, the first line that says, on pulmonary embolism is that the biggest problem with management of pulmonary embolism is we don't think about it. And that is what was also happening here. The ECG was done. Go back to it retrospectively and you will observe that there are STT changes in the right-sided chest leads, but you tend to overlook them. You tend to oversee them when you are managing these patients. So can this be pulmonary embolism, or this is just infection or pneumonia? What would you do next? And this D-dimer testing, which has been sent in the emergency by the resident over there, was it really indicated? If practical tip here, a usual practice point in the OPD is, if you see a patient who has an unexplained breathlessness in your OPD for the postgraduates here, and somehow, you want to think about a pulmonary vascular disorder such as pulmonary embolism or anything which is affecting the pulmonary arteries, ask the patient to walk in the OPD. Even if you don't do a formal 6-minute walk test, just ask the patient to get up, walk, come back. Patients with interstitial lung diseases and patients with vascular diseases tend to desaturate rapidly. So this is a important, simple, practical tip. In your OPDs, if you contemplate pulmonary embolism at some time and you want to see whether or not it is a vascular disease, ask the patient to just move around a little bit. A patient with an obstructive airways disease would not desaturate as much as a pulmonary vascular disorder or a pulmonary interstitial disorder would. So D-dimers are breakdown products of clots. So wherever there is clotting in the body, whether it is in the pulmonary vasculature or in the legs or anywhere in the body, the D-dimer levels are going to be high. The D-dimers can also be present positive in sepsis. Very, very impressive papers where they have compared levels of D-dimer elevations in sepsis vis-a-vis patients who had frank pulmonary embolism. And if you go through these papers, you'll realize that the actual levels of D-dimers are not very different in patients who have fulminant sepsis and those who have pulmonary embolism. So don't be fooled by D-dimer values alone. Pregnancy, of course, pulmonary embolism, clotting elsewhere or anywhere in the body. Post-op patients, very common. You'll be called to see a post-op orthopedic review. The patient underwent an orthopedic surgery 24-48 hours prior, and now the patient has breathlessness. You'll order a D-dimer, and the D-dimer would come out to be positive. Now, this D-dimer can actually be positive due to the surgery itself, and because our orthopedic colleagues or surgical colleagues are very fond of giving a lot of IV fluids to the patient is actually in diastolic heart failure, which is precipitated by the fluid overload, and that falsely elevated D-dimer tends to push you towards a diagnosis of pulmonary embolism. So take it with a pinch of salt, take it in the right manner. Age adjustment of D-dimer values should always be done. For a 70-year-old or an 80-year-old person, a D-dimer value of 500, 600 is absolutely normal. During the COVID era, we were so fond of getting D-dimer values done, and it was very sad to see patients who were 80 years old, 75 years old, being given full doses of anticoagulation just because their D-dimer values were high. So a very important message for all the postgraduates here is, whenever you are checking D-dimer values, please look at the age-adjusted values. There are formulas available. Elderly people are going to have higher values of D-dimer, whether or not they have any clotting or emboli or vascular disorder anywhere. So it is a very good ruling out test. If you suspect that a patient has a pulmonary embolism and the D-dimer value is normal, it is an excellent ruling out test. However, D-dimers being positive does not mean that the patient has a vascular embolus anywhere in the body. So what do you do in the emergency setting? Getting a CT pulmonary angiogram sometimes is not practical. Patients have renal dysfunction, or if it's not, you want an emergency diagnosis. VQ scans for all practical purposes are not available everywhere. So this is something that we all need to be, as pulmonologists, we all need to learn doing lung ultrasounds and also simple basic vascular ultrasounds. So if you can do a lung ultrasound, you can very well take your probe and you can put it on the veins, or you can ask your radiology colleagues to help you doing that in the emergency setup. And something known as a compression ultrasound of the large veins of the leg, when you put them on the large veins, especially the femoral veins, if there is a filling defect over there, there is going to be obstruction of the flow, and there is going to be a fall in the, the distal flow across that vein. We did a very interesting study on this at Metro, where this was one of the DNB theses of one of our postgraduate students, wherein lung ultrasounds and vascular ultrasounds and 2D echos were performed by a respiratory postgraduate, and the same patient was then, done up by a radiologist, and the results between the lung ultrasound, a vascular ultrasound, and an echo being done by a training pulmonologist was not very different from what was done by a trained radiologist. So all postgraduates here must have a basic knowledge of doing a lung, a vascular ultrasound, and a very basic 2D echo. And if you are suspecting pulmonary embolism in your emergencies, and you still have time, there is going to be, a lag between ordering a CT pulmonary angiogram and you want to give something about your patient, you want to anticoagulate them, start doing the compression ultrasounds. So a compression ultrasound was done in this patient, and the compression ultrasound showed that there was a large flow, a large embolus in the proximal thigh vessels. A CT pulmonary angiogram was subsequently done, which showed bilateral clots in both the left and right main pulmonary artery as well as the main pulmonary trunk over there. So the diagnosis of a CT pulmonary angiogram was made. The lung window over there shows us that there is a large infarct in the left upper lobe as well. So do not be fooled by the presence of fever, high total leukocyte count and a pleuritic chest pain. Up to 1/3 of patients may present with this as the initial feature. So our patient eventually turned out to be a case of pulmonary embolism. There was no pneumonia, no sepsis over here. High TLC, a pleuritic chest pain and fever. 1/3 of your patients with acute pulmonary embolism are going to have these features, and this is something that we all must remember. And even in such patients, we must think about pulmonary embolism as a differential in the ER. So a PERT team was called. This is something which is coming up in a big way. What is a PERT team? A PERT team is a pulmonary embolism response team. Every hospital should have them. It makes our life very simple. It consists of a pulmonologist, cardiologist, interventional radiologist, and someone from the ICU team. And who calls the shot? Someone who's the more loud, most vocal person in the team usually calls the shot, but it has to be, it's like an MDD, for an ILD, where you have pulmonologist, rheumatologist, the radiologist over here again. So a PERT team was called. Our hospital has identified people from one person from each department who, get together whenever a patient of pulmonary embolism is, is encountered. So the PERT team sat together and thought, what do we do now? How do we manage this guy? How severe is his disease? Do we thrombolize him, anticoagulate him? Do we do both, none, or do we put in an IVC filter? And by this time, we started getting phones from PGI Chandigarh to make our lives very, very difficult. So there are multiple guidelines on the management of thromboembolic disorders, especially pulmonary embolism. There is a very recent update to the chest, which was in 2018. But the best guidelines on pulmonary embolism, the easiest to read till now, which I always go back to, is the 2016 chest guidelines. And there are European Society guidelines which have been published in 2020 and 2021. I somehow don't find them very friendly. So for all postgraduate friends here, postgraduate colleagues, please go through these guidelines, because these are the simplest guidelines and the most easy to assimilate. And of course, whatever new comes on this, you can add to your knowledge or data bank. So when do you thrombolize a patient with pulmonary embolism? This is easy. Whenever a patient of pulmonary embolism is in shock, whenever there is gross hypotension, the systolic BP is less than 90, or from the baseline blood pressure, the mean blood pressure has fallen from more than 40, you need to thrombolize your patients. This is easy, no problem here. Our patient had come with a normal blood pressure. So this we need to remember. And there are other indications wherein if the patient is hemodynamically stable, but there is something wrong with the right ventricle of the patient, we'll come to this, which is known as a submassive PE, or if a patient has undergone any, patient has a CPR or a cardiac arrest due to a pulmonary embolism, if there's a very extensive clot burden, again, this is a very subjective kind of a thing to say, but American guidelines say this. So on the CT scan, even if the patient has normal blood pressure, but the clot burden is exceedingly high, you would want to monitor them, and probably a lot of these candidates would be candidates for thrombolysis. If there is a free-floating clot in the right atrium or the ventricle, because these can go, to the brain or other areas and cause trouble there, or if the patient has a patent foramen ovale, wherein the clot can travel to the brain. So these patients, even if they have a somehow, if they are hemodynamically stable, you need to probably consider them for systemic thrombolysis. There's something known as a non-massive PE or a submassive PE. Now, this is where all the problem comes. Now, what is a non-massive PE? This is where the blood pressure of the patient is okay. The patient is hemodynamically stable, but there is something wrong with the right ventricle of the patient. How do you show that something is wrong with the right ventricle of the patient? You do an echo and you show that the right ventricle is not working properly. You do a CT scan, and on the basis of CT criteria, you see there is size disturbance on the right ventricle. Or you do cardiac biomarkers, TROP, which is troponin, and NT-proBNP. So if there is any involvement of necrosis or involvement of right ventricular wall, these patients, and the patient's blood pressure is still maintained, the patient is not in gross or clinical shock or hypotension, this is known as submassive PE. So our patient underwent an echo, the ejection fraction was maintained, the RV was dilated, and there was flattening of the interventricular septum because of the RV overload. The TROP-T was positive, and the NT-proBNP level for this guy should have been less than 400. It was 7,760. So our patient had submassive PE. So at this point in time, any patient who is in the ICU has a pulmonary embolism. All postgraduates must use the PACE risk calculator in these patients, which tells you what needs to be done next to your patients, because this calculator has a lot of composite points, and you look at the age of the patient, the underlying comorbidities of the patient, the vitals of the patient, the lab parameters, and based on this you give a PACE score to the patient. If you can't remember the large PACE, there is something known as the modified or the simplified PACE, which is just comprising of 2 or 3 features, and you need to do this for all your patients of pulmonary embolism when you are trying to manage them. So the PACE classification would tell you how bad your patient is, what is the risk of dying of this patient. So if the PACE simplified is more than 1, or if the PACE is, the classical PACE is 3 or 4, and the patient has a submassive PE, these patients need thrombolysis. So this is again from the 2016 guidelines, and this tells you the same thing what I've said now. So the patient was in intermediate high risk of pulmonary embolism as per the PACE guidelines, and this patient, we talked to him about the pros and cons, and because he was a doctor, he understood that systemic thrombolysis was indicated for him, but he was also scared of systemic thrombolysis leading to bleeding somewhere else in the body. However, we went ahead and we did thrombolyze this patient.
Arjun, 2 minutes.
Yes, sir.
Yeah.
Also, one very important point here, if any patient has a submassive PE and a concomitant DVT, these patients would have poorer outcomes. So if you have a submassive PE wherein you are confused whether or not to thrombolyze these patients, if there is concomitant DVT, probably the best way out would be to thrombolyze them. So this patient had RV strain, TROP-I was positive. So this patient was thrombolyzed with alteplase over the next 2 hours. What next? The next step is, after the patient has been thrombolyzed, whether you choose between heparin, the newer anticoagulants, vitamin K antagonists, and how long should the anticoagulation be done. So the guidelines tell us that most of the guidelines now are preferring the use of NOACs, which is dabigatran, apixaban, over the vitamin K antagonists. When it comes to the use of heparin versus no molecular weight heparin, heparin is now used only for patients who have gross renal dysfunction. Otherwise, for all practical purposes, the step down would be either directly to a low molecular weight heparin, any of those, enoxaparin, deltaparin, or a NOAC. So the data right now suggests that you can straight away shift from your patients who've been thrombolyzed to NOACs, or if you want to use low molecular weight heparins, all are equally good. Vitamin K antagonists are difficult to handle, so most of us are moving away from them. The patient was thrombolyzed and the very next day developed significant hematuria, full field hematuria, started bleeding. The patient was started on rivaroxaban 1 day prior to this. What do we do next? So you stop anticoagulation and wait, you put in an IVC filter, or you continue anticoagulation. So because the patient was bleeding profusely, this was gross hematuria, we had to stop this. And then comes the indication for an IVC filter. So when do you put in an IVC filter? Patient who has contraindication to anticoagulation, but the clot burden is high, or if someone has an active DVT and the patient can still throw a clot to the pulmonary circulation and is a precarious patient hemodynamically, you go ahead and put in a IVC filter. Or if the patient has a compromised renal, lung or heart in any other, due to any other disease, you put in an IVC filter. So for this patient, an IVC filter was put. Unfortunately, you feel bad for a doctor colleague. He went away, he went home, and he was asked to continue his antithrombolytic therapy, his anticoagulation, rivaroxaban, for a long period of time. Him being a transfusion medicine guy, this is a very sad story. He stopped taking his rivaroxaban, had persistent breathlessness, and when he came to us for a follow-up after 6 months, we did an echo, and at this point in time, the right heart was badly dilated, the pulmonary artery pressures were exceedingly high, and at this point in time, for a 30-year-old doctor, the diagnosis of a CTEPH was made. So why am I mentioning CTEPH now? There is a specific drug available in India which can be used for such patients, which is riociguat, although the therapy of choice class A indication is a pulmonary endarterectomy. However, for all practical purposes, not many centers do it, so riociguat is now available. So this is actually an abridged version of a case series, which is around 150 slides, and it it discusses almost all aspects of anticoagulation, including NOACs, the side effects of particular NOACs, what to do when. So I am uploading this slide here, and I'll give it to Vishwesh for all the postgraduates who are interested, because I have just given you a very abridged summary of this. So just to summarize, PE is extremely underdiagnosed and often missed. Do not be fooled by fever, pleuritic chest pain, high TLCs. You can still have pulmonary embolism with these findings. CTPA is the gold standard. D-dimers help you in ruling out the disease. Pulmonary embolism with shock, thrombolize your patients. Pulmonary embolism without shock, check for signs of right heart failure and then decide. IVC filters are for patients who have a high risk of bleeding, but they need therapy. NOACs are replacing the vitamin K antagonists. The duration of anticoagulation needs to be individualized wherever there is a known disease which is caused. For example, a surgery, a prolonged immobilization has caused the pulmonary embolism or the DVT leading to pulmonary embolism. The anticoagulation can be 3 to 6 months. For a lot of patients who have cancer-related anticoagulation, patients who have APLA-related anticoagulation, you cannot give them even NOACs. For these two conditions, the patients have to be on some kind of a heparin. Most of these patients would be on low molecular weight heparin, cancer-related and APLA-related. So please do remember these two conditions. And look out for CTEPH, because specific therapy is now available. So make sure that you keep repeating echoes and clinical examinations of patients who have gone home with a diagnosis of pulmonary embolism. Thank you.
Thank you, Arjun. That one case summarizes everything. All the management of anticoagulation, IVC filters, thrombolysis in one case. Thanks a lot. There will be no questions.
So we will be starting the workshop soon. So in the meantime, it is going to take another 10 minutes to arrange the workshop. So I will be speaking, it all started with ILD in the daytime, so we will end with an ILD because we have taken a detour, we went to pulmonary vasculature and other things. But what I am going to speak to you right now is what that is happening in the world and what you are going to see in the near future as well. We are coming up with a term which is referred to as a progressing fibrosing ILD. And especially for all the people who are going to practice ILD, this is something which is going to change how you are going to see and manage a patient of any ILD in the future. So we all know that the ILD is a heterogeneous disease. You have got an idiopathic interstitial pneumonias, you have got autoimmune diseases, you have got hypersensitivity pneumonitis, you have got sarcoidosis, you have got LAM, PLCH and so on. And we heard and we experienced most of it during the earlier part of the day. So for the postgraduates here, which of the following do you think is a part of a progressing fibrosing ILD? Will you call an IPF as a progressing fibrosing ILD, or an idiopathic NSIP as a progressing fibrosing ILD, or a sarcoidosis, or A and B, or all of the above? So how many of you here, please raise the hands, are only for IPF? So there's no one. Idiopathic NSIP? No one. Sarcoidosis? A and B? All of the above? Okay, so all of you have cleared your MBBS entrance exam. That means the answer is always all of the above. So what we are seeing here is your PF-ILD is not a single entity. Any of the ILD which you see in your clinical practice, be it a sarcoidosis, be it a HP, be it a idiopathic NSIP, or a drug-induced, can progress to what we refer to as a progressing fibrosing ILD. So what is progressing fibrosing ILD, and how do we really define it? So we all know that it is a diverse group of ILDs. We have seen that any ILD can progress to a progressing fibrosis, and they share a similar disease behavior. That means they are going to progress. And they have a overlapping genetic, pathophysiological, and clinical features. As the name suggests, you are going to see a progression in your HRCT, you are going to see a progression in terms of your lung function decline, you are going to see a progression in terms of the symptom worsening, and yes, all these things leads to a progression as evidenced by early mortality. So initially we thought that only your IPF is a progressive disease. That is why we started treating, and all the clinical trials that happened with respect to the antifibrotics were focused on IPF.
But what later people observed is not only IPF is a progressive disease, or any of these other non-IPF ILDs can also progress. And when they progress with an exertional and a progressive dyspnea, they have worsening dry cough, they can develop into respiratory failure evidenced by clubbing, they can have fatigue, and they can have Velcro-like crackles. So before we understand the term progressing fibrosing ILD, which of the following is not a CT characteristic of fibrosis? A, honeycombing, is it a fibrosis or not? Yes. Mosaic attenuation? No. Traction bronchiectasis? Yes. Reticular opacities? Yes. None of the above? No. Okay, so mosaic attenuation, as we all know, occurs either by a airway involvement or by a vascular involvement. So anything else which you see, either in the form of a reticular abnormality or a traction bronchiectasis or in the form of a honeycombing, indicates that you are probably dealing with a case of a fibrosing ILD. So anytime you see any CT like this, where you have got a honeycombing or a traction bronchiectasis or a reticular opacities, you need to follow up this patient, because not all patients are going to remain like this. They have a tendency to progress. So, and as you can see from the CT scan here, this is how they progressed, A, B, and C. At different timelines when they took the CT scan of these patients, this we would have observed, but we never labeled them as progressing fibrosis before. But right now, why people are labeling them as a progressing fibrosing ILD is because you have got therapeutic options for these patients as well. Another thing which is very important, especially when you see a case of a CTD ILD, is when you look for any of these signs, that means an anterior upper lobe sign. As you can see from the markings here, when you have got some islands of fibrosis, which are more towards your anterior and in the upper part of the lung, or when you have it in the four corners of your axial section of the CT scan, or when you have a fibrosis which is having a straight line, like it is, you can clearly demarcate between a normal lung or an abnormal lung, or when you got an exuberant honeycombing, that means the whole lung appears to have an honeycomb. That means probably these progressing fibrosing ILDs are secondary to your connective tissue disorder, and the most common connective tissue disorder which you will see is systemic sclerosis, followed by your rheumatoid arthritis. So in IPF, it is always lung limited, whereas in any other case, it can have a systemic involvement as well. So now here comes the question. Okay, so we are saying that we are dealing with a case of a progressing fibrosing ILD. Are you going to treat all your patient as a progressing fibrosing ILD? No. For example, let's say that I have got a hypersensitive pneumonitis and I can clearly identify the antigen and I am removing the patient from the antigen. Probably that patient is never going to progress. So we cannot label him as a progressing fibrosing ILD. So which patients can be confirmed to have a progressing fibrosing ILD? So initially there were multiple definitions for your progressing fibrosing ILD. They said that if your FVC declines by more than 10%, or it declines between 5 to 10% with a worsening of your HRCT, or 5 to 10% with a worsening of your respiratory symptoms. So many ambiguous definitions were there. And few people also looked into the lung function capacity. They thought that, okay, if the 6-minute walk test decreases, we'll label it as progression, or acute worsening happens, we'll label it as progression. But multiple permutations and combinations were tried, and they came up with multiple definitions. But recently, in the 2022, we have an official guidelines from the ATS, ERS, JRS, ALAT clinical practice guideline, which defines at present what is going to be a progressing fibrosing ILD. So if you see the chart here, you can see that as I showed you in the first slide, any of these ILD has got a tendency to progress. But if you see the blue shade here, your systemic sclerosis, your rheumatoid arthritis, your occupational ILDs, your chronic HP are the ones which has got a lot of a blue shade, and these are the ILDs when you see in your clinical practice, you need to keep them on a close follow-up because these are the ILDs which are going to progress pretty rapidly. So as on today, you will call a patient as having a progressing fibrosing ILD. Whenever we see a progressing fibrosing ILD, we are speaking about non-IPF. So they should have at least 2 of these 3 following criteria: worsening respiratory symptoms, or you got an absolute decline in the FVC of greater than 5% within 1 year of follow-up, or your absolute decline in the DLCO is greater than 10% within 1 year of follow-up, or you have got a radiological worsening as evidenced by increase in the severity of the traction bronchiectasis, or new appearance of the GGOs, new fine reticulations, or an increased extent of the reticular abnormality, increased lobar volume loss, or new or increased honeycombing, then we will refer it to as a progressive fibrosing ILD.
So this progressing fibrosing ILD constitutes almost 13 to 40% of all your non-IPF ILDs, and they are associated with certain genetic factors. Like when you see their genetic, they may have a common tendency of a short telomerase syndrome or have surfactant protein coding genes. In the morning you heard that we are interested in something which is referred to as a MUC5B gene, or it can be associated with a certain part of an HLA susceptibility or a smoking history or a continuous exposure to the antigen, as in the case of a chronic HP. And if you see, the why we are very much concerned is, like if you see this graph, you can see that in systemic sclerosis, if a patient has got a progressing fibrosing ILD, it occurs very early in the disease. So for example, the maximum amount of the fibrosis develops within the first 7 years of the onset of your systemic sclerosis. So until and unless you recognize, you keep this patient on follow-up and do not treat, probably within 7 years, your patient will develop a permanent injury of the lung, and that is why you need to properly follow up these patients. And the most important thing which is really concerning is, if you see IPF, we say that there is a mortality of 70 to 80% in 5 years. But if you see idiopathic NSIP, if they have a progressing fibrosing component, the mortality is 20% in 5 years. That means in 5 years, I'm going to lose 1 out of my 5 patients who is having a progressing fibrosing phenotype. And if I'm having an RAILD and the patient is having a progression, their mortality rate is 39%. That is almost 1 in 2 of my RAILD will die in 5 years, secondary to a lung fibrosis. And in case of systemic sclerosis, it is as high as 34 to 46%. And in case of a sarcoidosis, it is 1 to 5%, whereas in case of HP, which is the most common ILD in India, we are seeing less of an IPF. And so-called IPF that we see, when we take the history proper, most of it tends to be a chronic HP. That means even in that, if you develop a progression, probably almost 2 to 5 out of your 10 patients will die in the next 10 years. So how are we going to really address this thing? So whenever you define a progression, right now we have a very standard criteria. You need to follow up these patients. You need to make sure that they have 2 of the 3 symptoms of either the symptom worsening or the radiological worsening or the lung function decline. And once you know, then you initially start these patients on treatment for a particular disease. Let's say that a patient comes to me with a HP, or a patient comes to me with a systemic sclerosis. On day 1, I am not going to put these patients on any antifibrotics. On the day 1, I will treat the patient as a case of a HP, or I will treat the patient as a case of a systemic sclerosis, like either with a steroids or a steroids with an immunomodulators, and then I will wait for at least 6 months to 1 year, observe with a CT, observe with a lung function, and if they fit into the criteria, then only we can label this patient as a progressing fibrosing ILD. So that means any patient who comes to you with the first point of contact, you should not label them as a case of a progressing fibrosing ILD, and you need to follow up these patients. And it doesn't always depend upon one pulmonologist opinion. You need to have a clinician opinion, you need to have a radiologist opinion, you need to have a pathological consideration, and you need to see the patient as a whole rather than just looking into the CT. That is why we are taking 2 out of the 3 criteria. And moving on to the management of the ILD, we have already had a very good lecture, but I just want, for the postgraduates here, you need to know that the most common immunomodulator that we use is an MMF, and the starting dose is 500 milligram BD, and we escalate as high as 3 gram per day. And what you need to know is, in a country like India where TB is endemic, if your ILD patient on MMF is showing loss of weight, loss of appetite, don't take it lightly. Probably these patients can have an immunosuppression and they are more prone to develop tuberculosis, and you need to monitor the CBC count because it can cause leukopenia. And the second drug that was previously used most common was the azathioprine. I'm not going into the details. And we have seen in a case like an MDA5 positive, we may have to even use a cyclophosphamide or rituximab, and these are the experimental drugs that are available. So the most important point of the talk is, we are concerned about the PF-ILD because once we define progression, now the guidelines clearly say, unlike your IPF, you can even treat your patient with a PF-ILD with the antifibrotics, because the mechanism of the fibrosis that happens both in the IPF as well as in your progressing fibrosing non-IPF ILD are the same. And I'm not going into the trials. So what they have said recently is the recommendation from the NHS that nintedanib is recommended within its marketing authorization as an option for treating a chronic progressing fibrosing ILD in adults. And even the ATS guidelines clearly says that we recommend, with respect to pirfenidone, they do not endorse it, and they say that the further research is needed into the efficacy, safety, as well as the effectiveness of the pirfenidone, both in the non-IPF ILD
as well as in other subtypes of non-IPF PF ILDs. But they again say that even your ATS endorses that if you can define progression as per the current criteria, even your non-IPF patients can be treated with nintedanib in a patient who has failed a standard treatment, that is maybe a steroid or an immunosuppressions. And with respect to the nintedanib, we start with 150 milligram BD, but in case if your patient has a dose-limiting diarrhea, then you can make it 100 BD. But if still the patient has got a diarrhea, then you may have to stop the nintedanib. And pirfenidone, the effective dose is 2,400. Unlike most of the times during COVID, we have seen prescriptions giving 400 milligram TDS. They are not effective doses. So the effective dose is on 2,400, but most of the Indians tolerate somewhere between 1,800 to 2,400 milligram. So, and in addition to this, your PF ILDs, or for that matter, any sort of an ILD does not end with a drug treatment alone. You need to involve the palliative care. You need to make an accurate diagnosis what sort of ILD you are dealing with. You need to educate the patient about the side effects. You need to involve the non-pharmacological therapy. You need to provide symptom relief. For example, a patient with an ILD is having a debilitating cough. You can give pregabalin. You can give gabapentin. You can give opioids. And even people have even tried thalidomide for the suppression of the cough. And you need to be educated about the supplemental oxygen, and pulmonary rehabilitation is a very important role. And when nothing works, your transplantation is the last resort for your patient. And so I will conclude with this slide, what we are going to follow for an IPF. If your non-IPF patient also presents to you with debilitating symptoms or respiratory failure, the management right now is not much different from that of an IPF. And if you can define progression, then you can start using nintedanib in these patients. So as of now, we know that all the PF ILDs have a common pathogenic mechanisms. They have a self-sustaining fibrosis. They are associated with decline in the lung function. They are associated with worsening dyspnea. They are associated with deterioration and they are associated with early mortality. But what we don't know is how are we going to predict which ILD is going to progress, and how are we going to see that which patient we need to choose initially to treat, whether augmented immunosuppression have a role or not, what is the role of the pirfenidone, and how are we going to really assess for the treatment response, and what are the patient-centric outcomes that we are going to take into measures. So to summarize, the progressing fibrosing ILD represents a phenotype that can occur in any sort of an ILD, and many factors likely determine the course of the ILD progression. Like in HP, it is an antigen, whereas in a CTD, probably the patient's lack of immunosuppression, or while the definition of the PF ILD still resides from a clinical trial, at least as of now, we have one standard definition to say that which ILD is referred to as a PF ILDs, and antifibrotic therapies, especially nintedanib, has been approved both by the US as well as by the NHS for the treatment of such cases. Thank you. And I would request people here to just move out for 5 minutes. So in the meantime, we'll set the auditorium for the workshop, and then we will have a cryo and a rigid bronchoscopic workshop. And now I request our chairperson to felicitate our speaker, Dr. Janesh Thakkar sir. Dr. Janesh Thakkar sir, onto the dais, please. And may I request Dr. Arjun Khanna to join us on the dais for the memento. And I request Dr. Sheetal to felicitate our chairpersons, Dr. Balraju and Dr. Sonia Dala. I request Dr. Sheetal to come on to the dais. So we will be back into the hall within 5 to 10 minutes. Thank you.
Synergy of updates from national and international experts under one roof. Aimed at continuous medical education of postgraduates and aspiring pulmonologists throughout the country. Know the latest advancements from experts in respiratory medicine. Every third Sunday of the month from 7 to 8 p.m. Coming soon. Welcome to Pulmo Mentor Web Meets series, an academic initiative of Yashoda Hospitals, Hyderabad. Pulmo Mentor is a series of interactive web meets. First web series aimed at case-based learning approaches in pulmonary medicine with recent updates. Synergy of updates from national and international experts under one roof. Aimed at continuous medical education of postgraduates and aspiring pulmonologists throughout the country. Know the latest advancements from experts in respiratory medicine. Every third Sunday of the month from 7 to 8 p.m. Coming soon. Welcome to Pulmo Mentor Web Meets series, an academic initiative of Yashoda Hospitals, Hyderabad. Pulmo Mentor is a series of interactive web meets. First web series aimed at case-based learning approaches in pulmonary medicine with recent updates. Synergy of updates from national and international experts under one roof. Aimed at continuous medical education of postgraduates and aspiring pulmonologists